So it doesn't go below maybe a 60, when earlier I used to go as low as 30s. So because of the decreased severity of hypo, my hypo awareness has also been regained. And of course, a greater time in range, which we all know is the new indication of good glycemic control. Quality of life, like I said, better sleep, so no nocturnal hypos, less anxiety, less hypoanxiety, less fluctuation, has reduced the burden of diabetes. Like I keep talking about, it makes decisions for you. It's like your actual pancreas, which is working, you know. And the biggest thing, which I mention in every time I talk about DIY, is that the APS keeps up with my timetable and not the other way around. Earlier, even with the pump, I knew that my pump would change the basal from 6 in the morning, it would make it to 1.75. And I knew I used to wake up every day at 6 in the morning. Let's say there was a day that I wanted to sleep in. I would have gotten a hypo if I had stayed in and not gotten up to eat because my basal was increased. With the APS, it adjusts according to you instead of you adjusting according to diabetes, which is a great, great relief. Clinical impact, I got my A1C down from 7.9% to 5.7% within 10 months of looping. I was surprised. I thought it was somebody else's report they gave me, but it was actually 5.7 with very, very minimal hypos. Time in range from 67% went up to 93%. It's from my Clarity app, and hypo awareness regained, which was also fabulous. I'm going to show you now some screenshots of my graph before and after looping. So this is a small indication of how my life used to be pre-looping. Of course, it wasn't like this all the time, but yes, these were the spikes and the drops in terms of fluctuation. This is how my graphs used to be on a day-to-day basis. It was a bit of time in range, but then there were drops and peaks and drops and peaks. And now I will show you the graphs post-looping. And these have been taken on random days. As you can see, it's almost 100% time in range. And this is the effect of looping. The next screenshot I'm going to show you is the day I began looping, and I very consciously took this screenshot because this is what my sugars were like. The moment I began looping, the magic started, and you can instantly see a difference. It doesn't even take that long. There's an instant reaction. So the pros, if I had to conclude and sum it up, the pros of looping, of course, it's a technological marvel. We haven't seen something like this in type 1 diabetes care. Bolus from phone and watch. So this is my Apple Watch, which also has the option. So you don't require your third-party PDM if I'm using a pump of like an Omnipod. It minimizes the amount of things you need to carry. Basal modifications, you can change basals up to like every hour. You can have a new basal rate. Time and range, huge, huge perk. Override settings. So when I'm working out, when I'm dancing, when I'm on a long flight, I literally have a flight override settings, which decreases my basal rate for 16 hours. I have a dance override setting, so I don't go into hypo at those times. It adapts rapidly because it's not FDA approved, right? So since it's not FDA approved and since it's a patient movement, there's constant updates. So the same way you would update your iPhone, you will update your loop as well. It's by the patients, which I feel is the most important part, because I keep saying that you need to work with the user and not for the user. And here the user is making something because the user knows the challenges we face. So since it's by the patients, it's got that user-centric design. And of course, there's an open loop option. So in case you just begin looping and you're a little unsure of how it's going to be, there's an open loop option, which means that it'll, before it makes the decision, it'll ask you whether, listen, I'm going to make this decision. Shall I go ahead with it? And then you can decide to say yes and no. I trusted it blindly and went with closed loop directly, but there are a lot of my friends who have used the open loop option as well. The data is very conclusive. This was a study by Dana Lewis, and mean blood glucose and time in range improved in every time category that they have sort of done the study for. A1C dropped from 6.4 to 6.1. Time in range increased from 75% to 82%. And this data sort of reflected into me as well when my data also proved this. The cons, yes, there are a few cons of DIY looping. It is DIY, which means build your own app. You can't just buy an app from an app store yet. It's not FDA approved yet. So if that's a concern for certain people, I completely understand. It's not a cure. It's not that once you put it on, you can just chill and relax. Of course, there is that maintenance of diabetes you need to continue. Tech trouble at times. And since it's a DIY, there's no helpline. You can't call up and say, like, listen, something went wrong. You need to do it all by yourself. Compatibility and options. So this is the DIY loop that I'm using with the Omnipod and the Dexcom G6. There is other options which you can use with older Medtronic pumps. There's also Open APS and Android APS. If you don't have an iPhone, that can also be used. A lot of people ask me what are the difference between DIY loop and Medtronic 670G. There's more customization with DIY loop. There's different target ranges, not just 120 mgdl, which is what the standard is at the 670. Pump control by phone, which is also different. The loop makes
will speed up a bit.
Yes, the loop makes predictive and proactive decisions, unlike the Medtronic, which basically gets it to suspend once it drops. And there's, of course, cross-device compatibility. We've just done a paper on this with Dr. Jyoti Dev, Dr. Banshid, Professor Parthakar, and myself, which is available to read now. And the loop does not sleep so that people with diabetes can. So that was the We Are Not Waiting. That's all about DIY loop. I would be happy to take questions if there are. Thank you so much.
So thank you. It was very, very interesting. The only limitation I thought was it was your personal experience. So probably we need more and more experiences and data.
There's a lot of experience. There are more than 30,000 people using this around the world. So that's where the data is from.
It's definitely fantastic. But yes, we need more research-based data on this. And probably this will definitely help type 1 diabetes a lot. Absolutely. And the questions will be taken at the end of the session. I'll hand over the system to Dr. Ami.
Yeah. So thank you, Jazz. Moving further, it's my privilege to introduce the next speaker, who is also a friend, Dr. Vinay Dandania from Ranchi, who is going to be talking on electronic medical records and data management, a gold mine in the hands of a physician. Introducing Dr. Vinay, he's a consultant diabetologist attached at Seva Sadan Orchid Medical Care in Ranchi. He's a principal investigator for ICMR, MDIRF, and INDAP study, a faculty at various conferences, seminars, and workshops. Is a member of UDF, RSSDI, DFSI, and IMA. The secretary of our RSSDI Jharkhand State Chapter and an alumni for ISB Hyderabad. Over to you, Dr. Vinay.
Thank you, Ami, for that very kind introduction. Can I share my slides?
Yes, sir.
Good afternoon. And after the last two lectures, I'm here to actually take you to a ride for documenting the data, whatever you get in your iPhone and whatever you get on your telemedicine. We also need to document those data. And I'm going to talk on electronic medical record system and data management, a gold mine in the hands of physician. And I don't have any financial disclosure for this presentation. If you see the different scenarios, how will you intensify therapy if an existing patient with an A1C of 9.6 and a recent history of MI, assuming that he has come to you without his previous medical records? This is a very, very usual scenario. Patient will come to you with the cardiologist file and will forget your own file while coming to your clinic. So that is how it actually helps. And if I would like to conduct a study among type 2 diabetes patients on insulin with CKD, or some study on GDM, or on type 1 diabetes on pumps, how am I going to do with these files? And this patient under your treatment for 5 years has lost all his previous records and is requesting for a copy of his lab investigations since his first visit for reimbursement purposes. So these are a few scenarios where EMR is going to be very, very helpful. And how do you define that? EMR is a digital version of a paper prescription that contains all the information of a patient's medical history from one practice. And it is very useful digital tool in management of diseases, especially chronic disease like diabetes mellitus, hypertension, CAD, where patient needs long-term regular follow-up. This is very, very important. And why EMR? Because you can document all the aspects of treatment help in not only retrieving data when needed, but also in medical legal cases. I don't know if we can actually, I was looking for some more data to support this, whether we can use our records in medical legal cases, track every aspects of patient's health, identify health issues better than with organized data, monitor response of treatment, improve quality of care and reduce errors in prescription, communicate enables transparent and informative communication to patients. So these are the key components of EMR. We are going to talk each one of them. Now, what is patient management component? It is equipped for patient registration. Whenever patient comes to your clinic, he needs to be registered. And patient registration includes key patient information such as demographics, insurance information, contact information, etc. And this is how it has been done in our clinic. When the patient first comes to the reception, his name, address, sex, date of birth, mobile phone number, UID number, address, everything has been mentioned along with the referral as well. And this is a very, very important data so that we can actually have a track of these patients in future. This data also helped recently in the COVID time, whenever in contact tracing, suppose a patient turns out to be COVID positive in your clinic, and on the same particular day, you have exposure of 5 to 6 patients on an attendance waiting here. So this data actually helps in tracing them as well. If you see the clinical component, electronic documentation, document notes such as history and physical, consults, discharge summaries, operative notes, etc. The pharmacy system, the nursing component for collection of key patient information. And this is the sheet where we actually make a record of all the detailed history, from medical history to allergies, to complaints, why he has come to your clinic, from current treatment to the previous treatment or the past histories as well, the family history, the reviews. So all you can make a sheet as a record for always in your EMR. And this is going to be very, very helpful in future follow-ups as well. You can also have a profile for diabetes, from having diabetes, duration of diabetes, onset of diabetes, with complications, without complications, macrovascular complications, whether he has undergone any evaluation in the past or he hasn't undergone any evaluation. So all these things can be kept as a record in a clinic. Similarly, laboratory components is also very, very important. It has two sub-components: capturing results from lab machines, the patient which they get the reports, or if you have tied up from your laboratory, you can have from the lab machines, which is usually in the West. Integration with orders, billings, and lab machines. So what happens is, from the physician's office, like if you order some test, it goes to the laboratory interoperatively modules. From there, it can go on to the pathological lab, the hospital lab, the radiology, whatever is been needed, to the hospital information exchange system, the public health, like notification in the case of COVID. So everything can be done from the LIM. This is very, very sophisticated system of integration of data from your clinic. So at one go, everything can be done. And this is how the laboratory data is been stored in our clinic, from the common test to the additional test, whatever is been needed, from hematology to biochemistry, lipids, kidney function test, liver function test, the additional test, the other hormonal profile like the C peptides and everything that can be added. And at first visit, the second visit, the third visit, and you can have a sheet where you can compare the follow-up reports, like the HbA1c, which was 9.7 in the first visit, is now 7.6, then it is 6.3. So you can actually compare the data in last 6 months time or 1 year time in one single view, which is in front of you. Billing system is also used to capture all charges generated in the process of taking care of patients, and these charges generate claims which is submitted to insurance companies as well. Then we have a patient portal where you can view the patient history, treatment, and medications, can check on records or additional notes. Scheduling software can direct patients to log into their accounts and schedule appointments. And this is the final sheet which you actually make after getting all the data, from the vital statistics to blood pressure monitoring to oxygen saturation, temperature, from complaints, main complaints, the diagnosis, the medicines advised. So everything can be there in one sheet, and even the test advice in future can be asked to get it. So how does the final EMR look like? It's a nurse which can capture the patient demographics, vitals, medical history, personal history, history of present illness, and test result. And then the patient comes to the doctor, who can capture the diagnosis, prescribe medicines or test, record prescription by selecting from drug database. And that is how it gives a printed prescription, graphs and charts with the comparison of different A1Cs in the last 6 months or in the 1 year time. Data analysis has been done. You can do later on for generating your research purpose, and you can visit the history data. The patient compliance and adherence can be looked into. So what are the advantages of EMR? It facilitates quick data transfer. It improves healthcare quality defined by adherence to guidelines and decreased errors, enhances safety and efficiency, and reduces number of lost records, help research activities, allow for a complete set of backup records at low cost, It improves patient compliance, facilitate quality assurance, and reduce medical errors, cost saving at the system level for chronic disease prevention and management. And if you see the data which you keep in your clinic, you can actually find out between 1 year time how many type 1 diabetic patients you have seen, how many patients secondary to chronic pancreatitis. So all this data can be actually seen in a couple of minutes time. This is a very, very simple job. Similarly, how many gestational diabetes visiting your clinic in a year time or a 6 months time, and how many patients are on a regular follow-up. So these are the data you can actually generate for your research purpose, publication purpose, and even follow-up purpose. So these are very, very important and easy tools in your day-to-day practice. And if you see, the MCI recommendation is to keep records for 3 years from the date of commencement of the treatment, and it demanded issues in 72 hours. Maintain a register of medical certificates, giving full details of certificate issued, and efforts shall be made to computerize medical records for quick retrieval. So this is from the MCI. Now, ease of use is very, very important. Now, most vendors are offering free trials or live demonstration so that we can actually learn and understand whether it is handy for us. You can have a cloud-based hosting. Most EMR vendors offer a cloud-hosted option. Now, there are advantages of this and there are disadvantages as well. The advantages is you can log in from anywhere from your different clinics from the same software. But the disadvantage is if you are opting to change the software, it becomes very, very difficult to shift the data from one software to another software. So there are advantages and disadvantages of cloud-based hosting. Integration is, it offers an e-prescription and electronically ordering laboratory tests and results. Very, very helpful in this pandemic area. And we learned a lot about telemedicine. This has been a very, very useful tool in this pandemic for teleconsultation. And many vendors are willing to build out additional integrations upon request. So find out if this is possible. And I tell you what Dr. Srinivasan was pointing out was actually having a documentation of your teleconsultation is very, very important. And you need to have a record of teleconsultation. And this EMR actually helps to keep maintain a record, which is not possible on phone consultation or WhatsApp video calls, or for that matter, even FaceTime video calls. Cost, the prices of EMR systems are highly variable. When requesting an estimate, find out what the initial activation costs are and how much each additional component will add to the price. And even the annual maintenance can be discussed when you are installing a software. Implementation and customer service is also very, very important. It can take from a weeks to a couple of months time. And people like me who are sitting in tier 2 and tier 3 cities, it takes a little more time as well. So what are the commonly used EMRs in our clinics? One Glance is the most popular, I suppose, and most of us are using One Glance since a long time. It gives a patient management software for doctors, clinics, and hospitals. Then we have HealthPlix, the smartest EMR ever. It gives e-prescription, lab, billing, dashboard, mobile app, pharmacy. And the salient features are quicker than handwritten prescription, transform your life in a day, a billing interface you will love, and deep insight powered by artificial intelligence, ML, and big data. Care and delight patients with mobile app. The other one is the Doc Plus, Doc Pulse, which is also very, very popular. Then we have Docon. A lot of my colleagues are using Docon in metropolitan cities. It's very, very handy. It's just on an iPad. You need to actually get a prescription printed through Wi-Fi. Practo is another very, very popular now prescription for chronic lifestyle disease. So I would like to discuss a very interesting illustration of EMR in the Dr. Mohan's Diabetes Specialty Center. And I'm know Dr. Ami is very friendly with this software. Various modules in diabetic electronic MR at DMDSC. If you see right from the front desk, it goes for appointment, registration, history taking, consultations, billing, laboratory, special test. Then after the reports, they come to the consultants, go for dietary and education, go to the pharmacy, and for the follow-up then. So this is a very, very classical way of actually moving around in an EMR in a very digital way. Clinical research applications. The clinical applications is the patient-specific assessment and helps clinician make clinical decisions by flagging the patients who are at high risk for complications, have drug allergies, and need preventive care. For example, the moment I make a note that this patient is allergic to Norflux TZ, he had some skin fixed drug eruptions with Norflux TZ. Whenever the patient comes for a follow-up, it pops up on my screen that I did not prescribe this medicine to this particular patient. But on a paper prescription, we may forget, or the patient may not get the older prescription where you had made a note. So you're likely to re-prescribe the same medicine which the patient is allergic to. By effectively managing a patient's demographic, medical history, medications, test results, diet advice, physical activity, the diabetes EMR plays a crucial role in providing comprehensive diabetes care. And the diabetes EMR serves as a rich database. As I said, you can actually take out all your data, like which patient, how many patients are on fixed dose combination of SGLT2 inhibitors and DPP4, how many patients are on Rizodac, things like that. You can retrieve all the data independently. How many patients are having type 2 diabetes with comorbidities like hypertension and CAD. So what are the short-term cost benefits? It reduces time spent on filing, retrieving, and organizing physical charts, reduce amounts of physical space, and time saved with information exchange between medical professionals and insurance companies. And long-term cost benefits, if you see, it significantly reduces the risk of data breach and HIPAA violations. I mean, right now we are not into this in our country, but shortly we are going to have this. Transferring large amount of data is simple and faster when changing locations. Less physical papers are needed, along with reduced necessity of paper products, easier to adopt new regulations. Handwritten charts can be difficult to comprehend by future healthcare providers, making EHRs and EMRs much more efficient for future users. So these are the advantages and disadvantages. Advantages are it enhances speed of clinical workflow. It is expensive, both initially as well as maintenance cost is there. Then the advantages helps in the standardization of various procedures like medical and clinical examination, and the automation has increased the ability for continuous improvement. But disadvantages, some doctors and other healthcare providers find it difficult to use computers, provides a comprehensive lifetime digital record for every patient, and if the system fails, it may slow down activities of the center, and it happens many a times. Efficient delivery of care with streamlined clinical workflow sometimes can affect doctor-patient interaction, as the doctor may be spending more time working at a computer than interacting with the patient. So it is not a replacement to your clinical examination and the clinical history taking. Don't forget that. It's just an assistance to your, it's a tool which actually helps you in delivering a better care to your patient. It's not a substitute. Clinical decisions can be made rapidly. Last slide is my last slide.
Okay.
Leading to better and faster medical intervention, and problems may cope up both in software and hardware. And data entered is secure and can be shared between medical providers, and prevents medical errors by having complete patient history on mind. And let me tell you, at the level of pharmacy, many a times the handwritten prescriptions are wrongly read, like a dimol tablet can be read as a dionyl tablet. So it is definitely a superior way of presenting your prescription on a printed paper. So to summarize this, the EMR is a valuable tool for both clinical and research applications. The EMR system can help in standardizing various procedures and has enhanced the quality assurance program, and a strategy focused on financial support, multiple networking, and training of technical support staff may be necessary to promote broader adoption of EMR system by medical services providers in India and other developing countries. So I thank the organizers and I thank everyone for giving me this opportunity on day one of the technical symposia. Thank you very much.
Thank you, Dr. Vinay, for such a comprehensive talk on EMR. Now, over to Dr. Vishal for the next presentation.
Really, thank you, Dr. Vinay. And I think a lot of doctors who are listening to your talk would start using EMR now. The next talk is another very interesting talk, and this is by Mr. M.A. Maluk Muhammad. He's a PhD doctor, and he has been working with the research and India operations of Twin Hill Technologies. He has developed a new technology, the Twin technology, in which they are actually assessing the continuous glucose monitoring data from the patients and the data obtained from the lifestyle changes, the diet that they are taking, and then they give a feedback to the patient. And this feedback has really helped a lot. I have read a research from them in which they have really changed the life of diabetic patients, reduced and removed insulin, reduced and removed sulfonylureas, SGLT inhibitors, DPP-4 inhibitors for a lot of patients. And I think this is really going to help a lot. And again, this is a kind of artificial intelligence uh, method, and he's an alumnus from IIT Madras. So I believe he and his team are doing a great job, and we are eager to listen to him. So over to Dr.
Thanks, Dr. Vishal. And to start with, let me wholeheartedly thank Dr. Bansi for giving an opportunity to talk in this great forum, where I would love to share our invention that we had come out with, the world's first reversal of diabetes through technology. The technology is called the digital twin technology. I just like to add to what Dr. Vishal said. It is not just the CGM patch. CGM patch is one of the data which we use to build the digital twin. It is a digital twin technology which is really making it happen. After 35 days of time, as I go through, you'll be able to understand more about it. So very, very proud to share that we had come out with the world's first digital twin technology to reverse chronic disease, wherein by we try to achieve the normal clinical range and stop medications. So how did it all start, and where did it, what is it possible? Is it really possible? Because since 2012, since Dr. Roy Taylor started to talk about reversal of diabetes through low-calorie diet, a lot of people have been talking about a lot of other dietary programs and other things. What is this that the technology is going to do? What is the innovation in it? In what way we are different from the others, right? So the genesis started from the other co-founder of the company, Dr. Jahangir Mohammed, whose earlier company, Jasper, was revolutionizing the world of Internet of Things. You name any IoT platform across the globe, it is from his earlier company called Jasper. Tesla, Elon Musk has worked with Jahangir for more than 10 years in building the driverless car, the automated car. Elon had a vision. He wanted his car to perform better as it ages, and he wants it to live, have the longevity of the car higher and bigger. And there, what they did was they tried to build a digital twin of the car. It was easy. You put sensor in the car, pick up the data from the car, and start to monitor the car, and they revolutionized the world of IoT. Jasper was acquired by the network giant Cisco for $1.48 billion, one of the largest acquisitions in the world in the year 2016. Later, when Jahangir wanted to start something new, he wanted to do something on healthcare, where we both met in a common platform where both of us were speakers. I was talking about the technology which we had created based on my PhD work, where at the last chapter of my thesis, I might have talked about how mobile computing can offer precision treatment. And in what way can it bring a revolution to the healthcare system? And that is where, with my own experience of my son having a liver transplant, I came out of the thought process. I wrote an article, which won the best paper award. I was talking at a particular conference where me and Jahangir synchronized together to start this particular company called Twin. Where when we wanted to start doing something on the healthcare, we dig deeper. We spoke to hundreds of doctors across the globe, like people like Dr. Bansi Chabu, Dr. Shashank Joshi, and other great stalwarts across the globe. And we found out that one killer disease, which is really, really causing huge calamity, both on the life of individual, both on the, as well as on the economy of the country, it was diabetes. Diabetes was the root cause for all of the diseases that you named through. And then, being engineers, we wanted to understand why is it so. World medical science had got evolved in a very big way. A lot of innovations had come. A lot of pharmaceutical solutions had come. Why is it thus diabetes is seen as a lifelong progressive disease? Why can't it be solved? Why? Where is the problem? And that is where, when we dig deeper, we understood that diabetes by itself is not a disease, it's a condition. And the actual root cause of the problem is the damage to metabolism. And the entire fraternity here knows that metabolism is nothing but 1,000 plus biochemical reactions that takes place in the body at every instance of time, and it keeps changing. No two humans have the same metabolism. And moreover, we ourselves don't have the same metabolism throughout our lifespan. It keeps changing at every instance of time. It is so dynamic, it is so messy, and we did not have a mechanism to precisely measure the damage metabolism. So high sugars are bad. Doctors are left out with no other spot where, though they know the root cause of the problem, still they were trying to remove the sugars using the molecules that are available, like metformin, sulfonylurea, DPP-4, SGLT2, and other stuff, right? And we all know the root cause of ultimately all these diseases is diabetes. And ultimately, the root cause of all those is the damaged metabolism, right? And that is where, and we all know, lot of things came in. Medication came in, diet fads came in. It starts with metformin, sulfonylurea, and it continues and ends up with insulin. And we have been talking about how to make people live with diabetes, with the symptom, suffering of symptom, and with we know when the complication is going to hit and what is the best way to do. And doctors was trying to do the best to ensure that they delay the onset of insulin. And that is the kind of treatment which was prevailing all along. And then we came. If at all we want to solve the problem, can we measure the metabolism? If we measure the metabolism, the root cause of the problem, we'll be able to bring it a solution. And that is where we took the genesis of what Jahangir has done with Jasper. In Tesla, we built a digital twin of every member who wants to get treated. And every chronic ill member who comes to our treatment, we built a digital twin of it. First of its kind in the world, a whole body digital twin to precisely measure the damaged metabolism. How do we do it? And what is the way we do it? We wanted to do it because ultimately we are human. We cannot bombard the body with sensors. In a car, you could do it. So we picked up 3 to 5 sensors. CGM patch, a body composition monitor, a sensor watch. Depending on other conditions, we gave ketomojometer and the blood pressure meter. With this set of sensors, we picked up around 3,000 plus data points every day from the body. In addition, 4 comprehensive blood tests was done in a year. And in addition, causal data from the individuals collected. Individuals from the individual, the food that he logs, the history of the member, what are the other pattern was collected from the individual. But these set of signals, a digital twin was built for every member who came into the treatment. And just try to visualize here, the digital twin in the platform continuously kept getting data from the body. Every 5 minutes once, data kept flowing to the platform. And the change that is happening in the body was picturized in the digital twin, where we ran a machine learning algorithm, which correlates across all these data points and does a computation of 1.4 into 10 to the power of 104 computations. Huge! Every day. 1.4 into 10 to the power of 104 computations correlated across all these data points every day to precisely measure the metabolism. That is where we succeeded. First of its kind of patent pending solution came in. Having measured the metabolism, how to heal it? We all know chemicals can solve a particular problem, but leading to other side effects and other complications. What is the best way to solve it without inducing any chemical? We were all born and we grew up with 4 inputs of the system. One is breathe, sleep, activities, and food that we eat. Is there a way that we could travel the same journey and solve the problem as what we thought through and we worked on it? And we made it happen, right? And we built, and we wanted to understand what is the way we could do it. Yes, the digital twin, which precisely measured the damaged metabolism, offered precision nutrition as a solution. The treatment factors that is involved here are precision medicine, precision nutrition, precision activities, and precision sleep. And precision medicine is kind of a transition medicine. We cannot pull out all the medicine on a single day. It has to be tapered, and gradually, as the member progresses, as the metabolism improves, it is tapered down and gradually stopped. And typically, when members have started to get treated through digital twin technology, more than 70% of our members, we were able to stop all diabetic medicine in a span of less than 25 days of time. And in insulin patients, where we were able to stop more than 90% of our members insulin in a span of less than 2 weeks time members, and another 20% of our members, we were able to stop all diabetic medicine in a span of 45 to 60 days of time. Members who had really damaged their metabolism very badly, it took more than 90 days for us to stop. Amazing outcomes we had been seeing, right? And when I talked about precision nutrition, what is all about precision nutrition? Is it another dietary program, or the company is trying to offer any supplementary program? It is not a supplement. We are not here to sell supplements. It's not another dietary program like a keto or a paleo diet. What does it mean? We all know there are a lot of literature which has been talked about. Dietary program can solve a particular problem. When you cut the source of sugars in the body, automatically sugars gets normalized. There is no rocket science or magic in it. But ultimately, it led to other complications, elevated cholesterol, end organ damage, many cases. That is the reason why many people did not go near to the dietary program. It was part of Delta X to the regular treatment of using with medication in order to regulate the sugars, was what has been done so far, right? What is precision nutrition all about? Precision nutrition is nothing but the food that we all eat knowingly, unknowingly, has 87 factors in it, right? And which are categorized as macro, micro, and nutrients, right? And macro elements alone, there are 25 elements are there. 50, and we all know that macronutrients are only a source of fuel to the body. The actual energizing factor that is responsible for growth of organs, growth of immune system, growth of cellular system, growth of bones are actually attributed to the 57 micronutrients which comes from the food that we eat. And we know the first person to taste our food and processing to start is the biota, the bacterium. In a damaged metabolic body, the bad bacteria rules the good bacteria by precisely balancing across the macro, micro, and biota, depending on the metabolic condition of the body. They are able to ensure that we offer to go solve the problem at the cellular level. Typically, so this particular treatment involves a year long of activity. I said when member starts the treatment, in less than a week's time, they get normalized sugar. They start to see the normalized sugar. Less than 2 weeks, insulin stop. And medication stopped in maximum less than 60 days of time. 90 days HbA1c can be seen less than 6.5. No medication. But it doesn't mean that they are normal. They are reversed their diabetes. They are just normalized the sugars. We need to go solve the root cause of the problem is the damaged metabolism. We are not here to control sugars. We are not here to manage diabetes. What is it all about, damaged metabolism? Yes, we all know that. It is inflammation, fatty pancreas, fatty liver, and fatty muscles. We need to ensure we solve this problem, all these things holistically. And the insulin resistance gets to be regulated. The beta cells has to be grown. So the first quarter, normalization of the sugar takes place. The second quarter, the optimization of the chronic condition starts to take place. Third quarter, as the body is free from the chronic condition, the optimization of the organ takes place. And by the fourth quarter, the regeneration of the beta cells completes. And that is the reason why it's a 1 year treatment completely. Right? And when we mean, what do you mean by metabolism is, we try to reverse diabetes, optimize cholesterol, optimize BP, optimize BMI, liver health, heart health, kidney health, pancreas health, insulin, inflammation, and insulin resistance. This 10 encompasses the metabolism of the human. We look at the body holistically and ensure that we solve the particular problem safely, right? And what is the technology all about? Yes, 200 plus parameters are fed to the platform, to this digital twin. And parallelly, 200 plus parameters are monitored depending on the health parameters. And we try to build a living system of an individual and because the treatment just doesn't involve just offering the health of the individual. We try to coexist the health and happiness of the individual, right? Precisely, you might be asking, how does the balance of the macro, micro, nutrients happens, right? It cannot be done through matrices. Assume that a piece of tomato is given to an individual. And we all know that most of the diabetic member will be deficient in potassium or water-soluble mineral. And we all know that the mineral half-life of every mineral is completely variant. Water-soluble will have 14 hours to 12 hours. And some will have 6 months, 2 months, 2 weeks. It is totally different. To take it, this is a popular example I keep talking about to people. Most of the damaged metabolic member will be deficient in potassium. Assume that we give a piece of tomato to each of you and assume that the tomato offers 300 milligrams of potassium. When we eat a piece of tomato, how many of us could say what was the potassium availability? What is the bioavailability of potassium in our body? The truth is no one can tell. The bioavailability of any nutrient for that matter depends on the other micronutrients present in the body at that point of time. And other nutrients is nothing but it is the metabolism of a human. So precisely as the digital twin is able to measure the metabolism, it offers the right meal plan, balancing across all the 87 factors depending on his metabolic condition by which he is able to heal his metabolism. It is not a dietary program, whereas it is a healing program. As the members travel through the journey of healing in a span of 35 days, when the member enters the platform, the digital twin precisely identifies the metabolic condition of the body and lists out the food items which are intolerant of the body and classifies those as red food. And the digital twin which prescribes a meal plan ensures that it doesn't include the red food. But as he travels through the journey of healing, the red foods start to become orange and green. The member can start to go back and eat his staple food after 7+ months because he has healed his metabolism and he can start to handle it by himself. And that is what we are able to do as technology. Yes. And how easy it is. The first month, the digital twin gets completed around 80%, where the member is expected to spend around 6 to 10 minutes on getting certain data, doing some actions. And as If the member progresses through the journey of healing, after 35 days, the member need not wear the CGM patch. The CGM patch is removed. The digital twin has started to learn. The digital twin start to predict the sugars. It is just not the sugars. It has a capability to track the filtration of the kidney. It has a capability to track the cholesterol movement of in the blood. It has a capability to also monitor blood pressure in the blood, in the body, right? And that is the power of digital twin. And as he goes through, partial food log will do, and sensor subsequently get removed. And when 6 months plus, just he need to wear the body composition monitor, use the body composition monitor sensor watch, and he need not even give the food log, because here the digital twin doesn't understand idli, dosa, sambar, puri. It understands what he has the micro level, the sodium, the potassium, the folate, the zinc, the mercury, and that is what makes it very, very powerful, right? And we all know every human metabolism is unique, and you could see here in the initial stage, most of the food are intolerant. As he travels through the journey of healing, as his insulin resistance increases, as the beta cells gets regulated, right? The food which are intolerant start to become tolerable. It becomes green, and he can go back and start to eat his normal food. This was an example to show a live data of an individual. You can see here, 50-member data was pulled at an instance. We picked up a couple of factors for the treatment.
Mr. Maluk, I think you have to hurry up a bit.
Sure. I'll be stopping. I'll be closing quickly. So, few factors were taken into consideration. Please look at how each body reacted. This body reacted with this body. They wanted more of sleep, whereas this body wanted more of activity. This body wanted more of potassium. It is totally unique, right? And that is what digital twin made it happen. And that is where we are able to offer a cellular level solution by which we are able to make the person go back and become a normal man. It doesn't say the white is the 14-day average from the CGM. Look at the prediction at an accuracy of 97%. After 35 days, the CGM patch is removed, and the platform digital twin starts to measure your sugars, right? And we call it as a virtual CGM. It's another patent pending solution from our company. And similarly, the blood pressure, you could see 30 days blood pressure, and you could see the prediction at an accuracy of 97%, right? We call it as a virtual PP. And by precisely going through the recommendation of the digital twin, we precisely say digital twin is nothing but a digital version of the individual. It precisely know what is good and what is bad and what is his progress he is trying to make. By precisely, methodically following the recommendation of the digital twin, we ensure that the member becomes happy and healthy, right? And this is the outcomes that we had produced so far on the commercial version. So far, we have treated around 6,000 odd patients, and the reversal rate on the commercial side stands at 79%, right? And greater than D35. And these are the other chronic condition reversal, because most of the member come with other comorbidity existing in the body, and you see the percentage of reversal what has been achieved. We sustain the reversal rate at 79% in the commercial front. We also do run a world-class, first of its kind RCT, randomized control trial, headed by Dr. Paramesh, supported by Dr. Joshi and others. And our reversal rate on day 180 is 100%. And look at the other reversal comorbidity conditions. Amazing results we have been producing so far. And all our outcomes have been published in premium journals, including ADA, American Association of Endocrinologists, and International Conference of Endocrinologists, and other popular places. Yes, we do run a US-based RCT, partnered with Cleveland, and it is underway, right? And we have a world-class people who have been advising us, people like Albert Huang, Francine. From India, we have Amrish Mittal and other great stars who are part of it. And it is a treatment offered by doctors. Digital twin is a plug-in to the doctor to make the doctor super powerful. It is not a model which can be handled individually. As rightly presented by Dr. Srinivasa Murthy, the digital twin can only recommend whatever has to be done, and it is the doctor who has to publish what has to be done. It is completely driven and supported by the doctor. Doctor has to do it, and every member gets a wellness coach, a health coach, and the health coach is a kind of an enabler, but the actual solution is the digital twin. Yes, this is the team, and from India we have myself and Dr. Shashank Joshi, part of the leadership team in our company, and we had launched a product in US too, and doing amazingly great. Thanks for the opportunity for giving me to present. Though I was rushing to talk about because we are running short of time, I just tried to squeeze whatever best I could share with people here. Thanks for the opportunity, and thanks to the entire doctor community who has been supporting us in bringing this to the members who are suffering from this particular horrible disease. Thank you.
Really, thank you, Dr. Maluk, not only for your talk, but also for doing good research in the field of diabetes and bringing this technology to the public. Just one question. What is the cost for an individual to enroll in your program for 90 days?
See, the treatment is a 1-year treatment because we are looking at reversal of diabetes, not for maintaining sugar. It is in sensors, doctor consultation, diagnostic, everything. It is 72,000 per year.
Okay.
Everything inclusive. There is nothing including tablets.
It will make a great difference in patients' lives, definitely. Over to Dr. Ami for further proceedings.
Thank you, sir. And now we're moving on to the next talk on the medical devices in diabetes management. We have our next speaker, Dr. Sanjay Rajput. Dr. Sanjay Rajput is a consultant gastroenterologist, hepatologist, and endoscopist in Ahmedabad. He has done his endoscopy training at the prestigious KEM Hospital and also taken training in Boston, USA, published paper in international and national journals, and has performed more than 50,000 diagnostic and therapeutic endoscopic procedures, has a huge experience in diagnostic and therapeutic biliary and pancreatic ESRPs, biliary esophageal and enteral stent placements, and all type of feeding tube placements, and various many other procedures. I invite you, sir, and over to you, sir, for your talk.
Thank you. Thank you very much. I'm Dr. Sanjay Rajput. Would you like to share my screen?
Yes, sir, you can share your screen.
I would like to thank you, Dr. Bansi Sabu and his team for organizing such an excellent conference. Today we are talking to the new developments in diabetes and obesity management in endoscopic therapy. We know that the people who are having diabetes and obesity are foodie. They have weight loss option like intensive lifestyle modification, nutrition, counseling, exercise, behavioral therapy, pharmacotherapy, endobariatric interventions, and surgical options. We know that why people don't follow the lifestyle modification, because it is very difficult to maintain. As we see this slide, it is very difficult to maintain continuous diet, continuous exercise, and all those things, because people don't have the habit of making it as a daily routine and follow it regularly. Otherwise they can lose their weight if they follow this type of heavy exercise and heavy diet consultation. There are pharmacotherapies which helps in losing weight, but why people don't lose weight? As you see that once they start losing weight, they don't follow the regular exercise, they don't follow the regular eating habits, and they start to regain weight. So most important thing what we can offer or in endoscopy obesity treatment for BMI of 25 to 40, we can give this patient with the help of exercise, medication, and this patient can undergo endoscopic therapies, which we are going to elaborate in few slides. Bariatric surgery is the gold standard for weight loss, but why people don't go for bariatric surgery? Because of complication. Less than 1% only people who require weight loss surgery goes to the surgeon because of fear of complication and the cost, as well as the other things which they don't follow the surgical guidelines. So there is a endoscopic methods which will help these patients to bridge the gap between medical therapy and surgical management. It may be used as primary therapy, can be used as bridging therapy, and as a revisional procedure. Why it is popular? Because it is less invasive, reversible, and it has a very low cost than the usual surgical therapies, and it can be repeated. Patient can go home in the next day with this type of procedure. They don't require the long stay. Primary therapy for obesity, most popular is intragastric balloons. Second one is tissue apposition technique. Third is nutrition diverting therapies. And it can be used as secondary therapy in transoral outlet reduction in cases of post-obesity surgery, revision obesity surgery endoscopically, and organ plasma coagulation for treating these patients after surgery. Intragastric balloon is the most important and the most widely available therapy. There are different types of balloon which has their own quality and their own usage. Orbera balloon is the most used balloon, which is fluid filled, which we insert into the stomach. V-shaped duo balloon is two balloons inserted into the stomach. Sparse balloon is an adjustable balloon which we can adjust after putting the balloon. Obalon balloon is a gas-filled balloon which do not require endoscopy. Ellipse balloon is also fluid-filled balloon which do not require endoscopy. And transpyloric shuttle is another way which we can use these balloons as a therapy. Orbera balloon is widely acceptable and widely available balloon which is a single spherical balloon which can be placed endoscopically. You can see the how it looks after endoscopy. This is the video of balloon which we place. Once it is inserted with the help of and by the side of the endoscope, it goes in and it remains there. After 6 months, we put around 450 to 900 of 700 ml of the fluid according to the size of the stomach and according to the capacity of the person's stomach, which we measure during the endoscopy. If the stomach is too big, we put 900 ml up to 7 to 900 ml, and if in females we put around 450 to 500 ml. This is reshaped balloon. Reshaped balloon has two balloons placed side by side attached with a catheter. Here we put around 700 to 900 ml balloon, and this is parts adjustable balloon. This is a catheter which is put inside the stomach. This catheter can be taken out with the help of endoscope to resize the balloon, whether we want to reduce the size of the balloon or if you want to increase the fluid inside the balloon if patient is not losing weight according to the our choice. So this balloon is quite helpful in those patients who do not want a single size balloon, because once we place the balloon we cannot resize other balloons. The most common side effect of the balloon is pain, nausea, GERD, and erosions of the stomach and early removal. Around 5% to 7% of the patients, they do not tolerate this balloon and they want their remove the balloon early. But obalon is a gas-filled balloon where the endoscopy is avoided. Patient has to swallow the balloon which is attached with a catheter, and this capsule, once patient swallows, we can fill this balloon with a nitrogen mixed gas. This is how it looks. When you swallow this balloon, with the help of the nitrogen canister, we can fill the balloon, and if we have to put around 2 to 3 balloon according to the size of the patient's stomach, and then the patient will lose weight. Another balloon is ellipse fluid filled swallowed balloon, where we put a balloon after in the capsule. Once patient swallows the capsule, we fill the balloon with the fluid. And the most important thing, you don't need to remove this balloon because it degrades by itself in 4 months. So this is also important. Patient don't have to undergo endoscopy anytime from swallowing to removing. Transpyloric shuttle is another way where we use this balloon the first balloon is attached at the pylorus and the second balloon remains in the duodenum. This assembly is put with the help of the endoscope, and then we remodel this balloon inside the endoscope in the stomach. Then we inflate, and then it creates a method of like gastric outlet obstruction intermittently and delayed gastric emptying, and patient will have longer time of satiety. So this balloon has result like 15 to 20% weight loss in the initial phase, and then at around 6 months they have excessive body weight loss of around 15 to 20%, which is good for the patient to reduce this comorbidity. The most common complication are contraindication are patient with having prior GI or bariatric surgery, large hiatus hernia, severe or uncontrolled GERD, and other anatomic abnormality and coagulopathy. Tissue apposition technique is another technique which is coming in big way. This is a endoscopic sleeve gastroplasty where the gastric volume is reduced by using endoscopically placed suture to create a gastric sleeve similar to the sleeve gastrectomy, where this is the Apollo suture device which is attached to double balloon endoscope, and then accordingly S shape, U shape or W shape sutures are placed on the greater curvature. This is how we this gastric volume. This animation provides an overview of the this is how we use this. We mark the stomach with the help of APC on the greater curvature, and then with the help of this endoscopic device, we place this suture. These are the polypropylene suture, and they are non-absorbable. So it creates a good to full thickness plication, and the capacity of the stomach is reduced to around 60%. So this gives a very good weight loss. If the patient tolerates this procedure very well, patient can go home the same day. This is a day care procedure, and this is a future of endoscopic management of obesity. This is the first one. Here you can see the how the in A it looks, the stomach looks like open, and in C it is completely tunneled. Endoscopic sleeve gastroplasty has given very good result, and very recent 5-year data has shown that total body weight loss was 15% in overall, while 90 to 61% has 5 and 10% total body weight loss at the end of 5 years. So very less side effect, like around 1.3% only. So this is well accepted in view of the endoscopic procedure with such a good result. Another method of endoscopy therapy is pose, where a tissue, it is a platform-based endoscopic therapy where an anchor is placed into the stomach in body and the antrum, and it causes decreased intake capacity, initially delayed gastric emptying also that return to baseline by the end of 6 months. Very importantly, it improves the insulin sensitivity also, and it enhances the postprandial decrease in the ghrelin. So all over this pose is very famous in Europe, and it has 49% of the percentage of the excessive body weight loss was at average 6 months was achieved. Nutrition diversion therapy for those patients who loves eating. This is another therapy where an catheter is placed from stomach, and then uh, like endoscopic bag where a catheter is placed from the stomach into the stomach, and then it is taken outside from the mouth. This catheter goes in and it is taken outside to the stomach, and the bolster is inside the stomach. So it is just a method by which patient whatever eats, he can use a suction machine. Those patients who want to eat mithais, chapatis, and excessive weight gain they can use this device to suck all the thing from the stomach. They have to use saline to dilute the whatever they have taken, and then they can use this saline after half an hour of their food taken. So this is a very good device, but more cumbersome than routine device, where we can use this as a therapy, and it has shown that it has almost much better results than other therapies. But only thing is it is a cumbersome technique which patient has to go to bathroom to use the toilet and take out this, and has to use the suction machine. Another good method of controlling diabetes, as we know that duodenum has endocrine cells which are modified in cases of diabetes, and they have hyperplasia and inflammation in duodenal cells. They are called duodenal neuroendocrine cells. When we use the thermal therapy to modify these enteroendocrine cells in the duodenum, we can modify the diabetes. This is a catheter which we put into the duodenum, and around 3 centimeter of the duodenal mucosa is burned with the help of saline, and this has shown to cause a very good diabetes control, and there is a reduce in the HbA1c level with the help of this mucosal resurfacing catheter. Another technique is incisional anastomosis technique to produce a malabsorption, where people are putting magnets into the duodenal or jejunum, and one magnet is placed from below, which is causing an anastomosis like mechanism, and patient have whatever patient takes bypasses the duodenum and jejunum, and it is like a malabsorptive procedure, and incisionless anastomosis can be created. And like that only, endobarrier is also used, where you put a barrier from the stomach or the esophagus, and that duodenojejunal bypass can cause this uh, malabsorption like mechanism, and having a good diabetes and control and obesity control. Another matter is transoral outlet reduction for endoscopic by endoscopic suturing in cases of post surgery, where patient has regained weight and has again developed the glycemic control is not well, where we do the suturing of the outlet, and then this outlet is reduced up to the 8 millimeter to 10 millimeter, and then a patient again start losing weight, and then their glycemic control improves. Another technique is revision obesity endoscopic surgery. It is a platform based technique which helps the patient into using the losing the weight. Argan plasma is another method by which we can burn the mucosa of the stomach, and then the patient will have this weight loss like endoscopic sleeve gastroplasty. Argan plasma has been used in all other area also, and with good result. Around 16% of the patient will have symptomatic stenosis with the argan plasma, because it is not controlled method. So that we may have to use the dilatation in this therapy. So take home message is obesity is a major public health issue. Losing 5 to 10% of the body weight can be enough to provide health benefits. Intensive lifestyle modification is a lifelong commitment that requires a team approach. Pharmacotherapy can be helpful alone or in combination with other therapy. Bariatric surgery is recommended for BMI more than 40, and endoscopic bariatric therapy can help in boost weight loss for in 30 to 40 BMI. Obesity is major public health issue. So we have to take care of everything in the account, and ask the patient to give them the best endoscopic management to reduce them the weight loss around 10 to 15%. If they can reduce this 10 to 15% of the weight by themselves, we can help. Cannot reduce, then we can help them by helping them with the endoscopic therapy like balloon, like endoscopic sleeve gastroplasty, or any other method of the endoscopy. Thank you very much.
Thank you very much, sir, for the wonderful talk. I now ask Dr. Vishal to take over for the introduction of the next speaker.
Yeah, thank you, Dr. Sanjay Rajput. It was a nice discussion. And the best part of this session is that we are continuously moving from doctors to techies and making life easier for everybody. And the next session is from another techie. He is Mr. Bhargav Susale. He is the co-founder and CEO of Meteos Technologies that specializes in artificial intelligence. And artificial intelligence in the eye actually detects tissue level changes which are not visible to the human eye. And the advantage with humans is that we use reasoning more than what we see. So the final solution is when we are able to enhance our capabilities with the help of AI. And to discuss this in the field of diabetic retinopathy, we have Mr. Bhargav Susale. Over to you.
Thank you so much for the kind introduction, Dr. Vishal. I'm just going to share my screen. I'm hoping everyone can hear me just fine. Okay, thank you so much. Now I will sorry, just need one moment to just move Zoom out of the way. Thank you, everyone, and good afternoon. Today, I will be speaking about artificial intelligence and its use in detecting diabetic retinopathy. I'd like to start with a story. This is Rohan, and Rohan has had type 2 diabetes for the last 10 years. So last week, Rohan visited his doctor for his regular diabetes checkup. And the doctor said, Rohan, look, you've had type 2 diabetes for 10 years now. You need to get your eyes checked. You're at risk for diabetic retinopathy. Please go immediately. Rohan is a good patient, and Rohan told the doctor, yes, doctor, I will go tomorrow. Rohan did not go. He thought to himself, oh, I have to book another appointment at a separate doctor. I have to travel in traffic, and very bad traffic in India. I have to get my eyes dilated when I go there, and then I won't be able to drive back. Anyway, my eyes seem fine. My vision is normal. Why should I go? Rohan at first was right. He had no symptoms. This was his retina. Everything was very clear. But after some time, he developed some form of diabetic retinopathy. The retina started seeing damage. There was still no symptoms. After that, there was further damage to the retina, and there was still no symptoms. And then there was sudden and complete vision loss, and it was too late to do anything about it. He immediately rushed to the eye doctor and said, doctor, I can't see from my right eye. Can you please help me? And the eye doctor told him, I'm sorry, it is too late now. You should have gotten your eyes checked when you were previously referred. Rohan is like 70% of people with diabetes. They don't go to the eye doctor when they're referred to. So what is the solution to this problem? The solution is that the DR screening must be brought closer to the patient. It must be done by the diabetes doctor or at the point of primary care. There are 73 million people with diabetes in India, and there are 400 plus million people globally with diabetes. 33% of them already have some form of diabetic retinopathy or will develop it. And 10% of them will suffer vision loss. Now, in India, there are actually 5,000 retina specialists, and there are 120,000 doctors treating diabetes, either endocrinologists, physicians, or primary care. This means that if the physician does not screen for DR, the patient will go blind. But screening is difficult. It's not easy. Using an ophthalmoscope is not easy. It requires a lot of training, and you can make mistakes. The fundus cameras that are also available are big, bulky, expensive. And even then, you'll need an eye doctor to diagnose or interpret the fundus image. If you use telemedicine, it will require internet, and it can also be very time consuming. So the solution to this problem is through hardware and software innovation. And I'd like to present one such solution today. It's a solution that does not require dilatation. It is handheld and completely portable, and it is cost effective and affordable. It uses AI to assist image capture and also automatically interpret the image of the retina. It does so without any internet connection and without any human readers required. It can be used by anyone. So this is a video I've got to present today. There's no audio. It's a simple demonstration of this handheld device, which is used to image a patient here and capture an image of the retina. The device automatically captures an image when the retina is in view. Once that's done, you can actually select the previously captured images and quickly generate an AI report. An AI will automatically assess the images for quality and then check for DR. And the report is generated in less than 10 seconds. In this case, there was no signs of DR detected. If DR is detected, the report looks like the one here on the left, where aside from also highlighting that DR is detected, it tells you where the lesions are detected in the photo of the retina. It also tells you whether an image is of low quality or is acceptable for grading. We have validated this device with thousands of patients in the past 2-3 years. Our first study was actually with Dr. Mohan in Chennai, and we did a study on 300 patients, And we saw that the sensitivity for this device was 96.6% in detecting referable diabetic retinopathy. And in detecting severe and proliferative diabetic retinopathy, the sensitivity was 100%. The specificity for the device was 89.6%. We did another study with 304 patients with Daikon Hospital in Bangalore. And here we saw that the sensitivity for referable DR was 98.84%. And sensitivity for sight-threatening DR was 100%. This was actually presented at ATTD in Berlin 2 years ago. And it was also published in BMJ, British Medical Journal, last year. We also did another study which evaluated the device with 900 patients in a clinical setting. And it is the largest study evaluating the performance of an offline AI using non-mydriatic retinal imaging. And this was presented in ADA in 2019 as well. The results of that study showed a sensitivity of 93% and a specificity of 92.5% for referable DR. And for sight-threatening DR, it actually showed a specificity of 98.7%. We also then took the device to another place where we wanted to evaluate this in a community screening setting. So in Bombay, in the Bombay Municipality Corporation, we actually undertook a screening from people who were living in Dharavi, who did not have access to proper medical care. And this was done with Aditya Jyot Eye Hospital in Bombay. This was actually an interesting study because we had no medical personnel involved in using the device or providing a diagnosis, except for the purposes of, verifying the results of the AI. So we screened 231 individuals with diabetes, and we saw that the sensitivity for referable DR was 100%, and the specificity was 88.4%. This was also published in JAMA Ophthalmology in 2019, and it was the 5th most cited paper in JAMA Ophthalmology in 2019. It also had an invited commentary from Johns Hopkins, where Dr. Alvin Liu, who's an ophthalmologist at Johns Hopkins, said that it was a paradigm-shifting approach to DR screening, and it could greatly benefit both developing and developed countries where access to care is limited. Interestingly, Kiran Majumdar-Shaw also took an interest in this device, and she also tweeted about it. However, even with all of this, these are still very early steps. There are still many challenges faced when we try to deploy this in a clinical setting at scale. Now, one of the biggest challenges we do face is that habits are hard to change. Even with a validated device that solves many of the problems, oftentimes doctors can be very busy with OPDs and just lack familiarity with eye care, which is something that is a harder mindset shift to change. We also sometimes see that there's a very do-it-yourself approach, or as they say, jugad, where many times untrained personnel tend to start diagnosing retinopathy themselves, even if they don't have the qualifications or experience in doing so. And of course, most recently, we've had the COVID-19 pandemic with lockdowns, low patient loads in clinics, and the prioritization of COVID, understandably so. It does, however, mean that other diseases sometimes can take a backseat, including diabetes and diabetic retinopathy. So what are the next steps from here? Now, I think the first step is always continued awareness and deployment. As of today, there is no large-scale deployment of AI-based diabetic screening yet anywhere in the world. So that is something that we need to keep creating awareness about and working on deployment. Then after that, aside from just detecting the presence or absence of diabetic retinopathy, it would be good if an AI can also grade the severity of DR or stage it. Is it mild? Is it moderate? Is it severe? Is it proliferative? This way, we can also separate patients that require urgent referral from maybe a patient that is, has mild DR and does not need referral. And of course, it's also supporting new diseases. The same issues that we see with diabetic retinopathy also exists with other conditions such as glaucoma, where screening today is insufficient. So supporting new diseases via AI, such as glaucoma or cataract, can help provide holistic eye care, both at the level of the practitioner and the patient. I'd like to actually give a thank you to all the photos mentioned here, because they've been our biggest supporters from day one, and we would not have been able to build this technology without any of their support, right? And we would not be able to speak in today's conference without their support. So I'd like to just give a round of thank yous to everyone here. I would like to conclude by saying the current ways to detect diabetic retinopathy is perfectly suited for a world that does not exist. So I invite you to join us in changing that. Thank you so much. Yeah.
Thank you, Bhargav, for a nice introduction into offline DR software, in which we can actually screen our patients in the clinic and we can refer them accordingly. So do you have any words, Dr. Ami?
No, I think we have had a wonderful technology symposium. We've covered a wide range, including how to get our glycemic control, to including how we can diagnose the complications and help patients to lead a better quality of life, even through telemedication, how to maintain their records. I think we've covered a whole bit in these in couple of hours, and I am sure the audience would have really gained something new to learn in these last couple of hours.
So if we have any questions, we can take them. And I would like to ask Dr. Srinivas Murthy sir first. Sir, how do we actually take the identity of the patient? Should we go in for something like Aadhaar card, but all those things can be actually fake. So how to take the identity of our patient when we are considering him for a teleconsultation?
Okay, I think we should take up the government ID only, the valid ID. Of course, if it's fake, then we don't have anything, because most of the fake currency notes are exchanged in the clinics. If you are aware, that's one of the commonest places where you can exchange your fake notes in a doctor's clinic. So similarly, the Aadhaar card, the driving license, that's what we upload, we scan and put it into the system. And that's what we do at our place. Vinay?
I think Vinay wants to ask something.
We don't even ask for an Aadhaar card in our clinic when a patient visits for when we are taking their demographic details. We never ask for an Aadhaar card or their identity proof, isn't it?
So then, sir, is it practically feasible to ask for an identity in this telemedicine consultation? Is it feasible?
Yes. Technically, legally, we have to ask. We don't ask in our routine OPD practice, but in the telemedicine, it is a mandatory. You need to establish your identity. See, this is a simple thing. You are giving scope for fraud. Basically, like in your name, the insurance is not there. So you can book in some other name where the insurance is there, example. So the patient can fool around with this prescription with that name. So you are telling somebody X is called up you, and there is no identity. You didn't establish. So the onus, the legalities will come to you if you fail to establish identity. Not in the clinic, but in the telemedicine, it is mandatory to take the identity, prove that is the patient what you are talking to, and then it needs to be documented.
Yeah, definitely.
The easier way, what we were doing here in Ranchi was, we used to ask for their report. Like if you have a COVID positive report from a laboratory or from a government organization, the name is there, the age is there, their Aadhaar number is there. And if they present their report in front of you, then only we used to advise them on teleconsultation.
No, that is true. Vinay, that is exactly agreed. See, now I am Dr. Srinivas Murthy, but I will get Vinay's reports, whom I know, my friend, and I'll present as I am Vinay. So where is that relationship to claim? Because I don't get in my name the insurance, so I'll take Vinay's report and show it to you, claiming that I am Vinay. So that is what is required. That Vinay means you need to have your whatever the government ID in the teleconsultation. It's very important to prove the identity, and then only you proceed. In fact, I showed you in the step in the guidelines. The ICMR guidelines clearly says if you don't establish ID, you don't continue with your teleconsultation. There is a step. That is one of the most important steps.
One question I have with Dr. Maluk Muhammad. Sir, you have really shown nice things. How do you integrate? You have shown. But do you have a take-home message for us? What should we really do, and how can we get benefited from this app of yours? And can we get some abstract from this app which we can actually use in our clinics these days?
Sir, we partner with doctors. As I said, it's a treatment offered by doctors. And we welcome all doctors, whomever is interested to offer this as a patient, to partner with us at free of cost. And there's a commercial agreement which is there. Doctor gets benefited. Doctor gets a twin care app. It's a contactless treatment. Patient need not come to the clinic. Diagnostic solution is done at the doorsteps of individual. And it's end-to-end is the twin support completely. And if you're interested, my person can reach out to any doctors who are there. We are currently available in 13 cities. We had launched in US. Things are really progressing extremely high. Our data are validated by IIT Madras. Exclusively, independently, they have studied our complete data, and they are coming out with an independent report very shortly. They will be presenting it to the media very shortly.
So you are planning to expand it to tier 2 and tier 3 cities also in our country?
Yes, very shortly, very shortly.
Right. And Bhargav, what is the cost of this app, Remedio Fundus on Phone app that you offer?
I can share a few details for cameras pricing generally. I think the Remedio Fundus on Phone retails for about between 3 to 3.5 lakh INR in India. Yeah, and I think that's the range for most fundus cameras out there. Maybe a bit more, maybe 4 to 4.5, but Remedio is 3 to 3.5, if I'm not wrong.
Fine.
Yeah. So I guess we are on time.
Right.
Yeah.
Perfect. Good job. Both the chairpersons, Vishal and Ami, excellent job.
Thank you, thank you, thank you. I think Dr. Vishal, would you like to wind up?
Yes, I think the session was quite good. We could see a lot of innovative ideas coming from techies. We could see a lot of helpful things coming out from our doctors, and I think such sessions will definitely help in enhancing our capabilities. Doctors now need the support of techies, and techies coming into our field are not actually to replace us. They are actually to help us to build a better future for our diabetic patients.
Very true.
Yeah. Dr. Jaideep?
Thank you. I will just say thank you to both the chairperson, Dr. Ami ma'am and Dr. Vishal sir, for conducting the session so smoothly and covering maximum topics. And difficult thing, as sir told, that yes, techies are here to help us. So, ma'am, last word from you, and then we can close the session and we can move ahead.
Yeah. So thank you very much. Thank you, Dr. Jaideep, Dr. Vishal, for co-chairing with me, and all the speakers for their wonderful talk, enlightening us today afternoon. Wishing you all a safe life ahead and a pleasant weekend ahead. Thank you very much.
Thank you, ma'am.
Thank you.
Thank you. Thank you, everyone.
Thank you.
Reporter and chairpersons, please proceed the session.
I think I request Dr. Manisha Gupta to kindly start, if she is here.
Yes, sir, I'm here. I welcome you all on this virtual platform of 11th World Congress of Diabetes India 21. I thank Diabetes India for giving me this opportunity. And initially, thanks for giving me the opportunity to discuss about type 1 with all stalwarts in diabetes. Initially, we used to have sessions regarding type 2, but since few decades, we started having a specialist symposium on type 1. And thank you, Diabetes India, for having this third. I think we have 3 sessions, especially on type 1. To begin this session, I would like to invite Dr. G.D. Ramchandani, Sir is a senior physician and consultant and leading diabetologist in Kota. And he has been serving in this field of diabetes since 2 decades. Welcome, sir.
Thank
And
you.
along with him, I would like to invite Dr. Shuchi Chug. She herself is a type 1 diabetic and managing beautifully her diabetes. And she has been trained especially in this and training others in the field of diabetes. So I welcome you, ma'am, to this session. So, sir, kindly take the lead. Yes, yes, ma'am.
So, thank you, Dr. Manisha, for a nice introduction.
Thank you, sir.
First of all, good afternoon to all the legendaries of the type 1 diabetes. And now we are moving to the very important and very interesting session of the Diabetes India, that is Type 1 Diabetes Symposium. For this, we have 6 speakers, and they are truly attached to the type 1 patients, not only by as a doctor, but as a I can say family. Just they are the family members of the type 1 diabetes. I have seen 6 names, all are legendary of the country. So I, with Dr. Suchi Chuk, we welcome you all, sir, and welcome all the delegates and all the speakers in this wonderful symposium. For this, first I request Dr. Suchi Chuk to kindly say some word before starting this next session.
Thank you, Dr. Ramchandani. As you said, all are legendary people and all are legendary doctors. Actually, they are more than doctors to people or children with type 1 diabetes. They are uncles, aunts, moms, dads, and everything to children with type 1 diabetes. And it's their love, which we have seen since past 2 or 3 decades, that type 1 is here, and now there's a great awareness about type 1 diabetes. So it's my pleasure to be a part of this forum. But yes, all the people I book, because healthy children with type 1 diabetes can be healthy adults with type 1 diabetes only by doctors like them.
Thank you, Dr. Suchi. I think a type 1 diabetic child or adult can understand about the legendaries and the speakers of the country. So you will very well know all these 6 persons. So first, I invite the first speaker of the today's very symposia. That is none other than Dr. Archana Sada. I think Dr. Archana Sada does not require any introduction, but as a formality, I definitely introduce her. She is working as a consultant diabetologist at Aurangabad and running a SARDA Center for Diabetes and Self-Care Center for the past many years, and looking around, I think, more than 500 children. And I have seen this the program of UDAN at SPAD conference. That was an amazing and wonderful program. So she's a founder of that UDAN, an NGO for the children with diabetes. And she is a member of RSGA National Task Force. And under that banner, we are doing Diabetes Bites since last many months. And she was organizing secretary of IDEC Pune. And her area of work is diabetes education, and care of truly care of low resource setting, especially in small city Aurangabad. So I invite Dr. Sada to kindly start the first session, that is a tips for successful type 1 diabetes management. Dr. Sada, please.
Thank you, sir. Good evening, one and all. It is a pleasure to be here in Diabetes India to have a session, not just one, but many sessions on type 1 diabetes. My special thanks to Dr. Banshi Sabu and his team. Thank you, Dr. Ramchandani, for this wonderful introduction. And Shuchi, you're always close to heart. So it's a pleasure to see you here. I can see my colleagues and mentors and seniors who will be talking. So I'm the first batman. I will take it forward. And the topic is the tips to successful type 1 diabetes management. Now, I thought of how will we go about this, and finally felt that let me share a few tips for people who do not have exclusive type 1 care centers, because that is something where everything is already existing. The whole ecosystem for type 1 care is existing. So my thoughts were this, to share what a doctor can do. So my talk is from a doctor perspective in ability to provide successful type 1 diabetes management to the children, adults, and their families who come and visit them. So it's an art and a science. On this screen, you see Sanika. She was 10 years old when she had type 1 diabetes. Today, she is a diabetes educator. You can see how proudly she shows off her device to monitor her CGMS sensor. But we realized over time, as everyone has realized, there is a lot of science. We have just seen the technology session. Wonderful technology has come in, but there is also a lot of art. There's a lot of soft skills involved, and hence the education, motivation, counseling are just as important as the insulin technique and regime, the pumps and the CGMS, and the carb counting. So we have come a long way from a chapter in a book 20 years back in medicine to what we see, hear, read, understand today. But that merger, the art part, is something that we still have to learn, without which the science does not manifest itself. So my first thought here is the approach, the doctor's approach. Whosoever, it is not about resource limited. It is not about being in a, maybe if you are in the best setup in the country, in the world, yet what is the doctor's approach to T1D care? So unless and until our approach starts with empathy and then steps on to a willingness to engage with the person and the family who steps into our consulting, and with the ultimate goal to empower our patient and their family. So I believe, and this is not just a belief, I'm sure everyone here will endorse who is working in type 1 diabetes, that unless we are empathetic in our approach, unless we are willing to engage, and unless we are now willing to empower our patient, because the olden days, it was a very glucocentric approach. It was an approach of, I am the doctor, you are the patient, I know, and you listen to me. And there is no such thing in type 1 diabetes. We want to empower them so they don't need us anymore. I mean, that is the ultimate aim, that they can take care of themselves. And the picture here is the first one-up challenge that was done for Kalsubai Peak from the students all across the country, and they made it because they were empowered. So first tip for a successful care, I would say, is create a team. Even if you have a very small clinic, if you have a very big busy practice, it is not possible to take care of type 1 diabetes without having a team. Because if you are going to see, if I am going to see my patient in 5 minutes in a busy OPD, then wherever there is no team, there could be different ways. We need a nutritionist, a qualified nutritionist who knows what is type 1 nutrition care. We can have coaches who, if we have more patients, we can have somewhere a bridge between the educators, doctors, and patients. And we can have leaders with type 1 diabetes who can be part of our team. So sometimes nutritionist, educator, counselor are one person rolled into one, which is fine. As long as we keep on learning, we keep on upgrading ourselves, we are scientific as well as in our skills to counsel are updated with learning in our peer group. So leaders with type 1 diabetes, I would like to add here, or their family members, make wonderful educators, wonderful counselors, and wonderful support team. So these are people we can actually structured way, we can teach them, we can involve them, and they can become a great team member for us, where in every case, even if we have professional qualified people, they must be a part of our team. That is one successful mantra for having good diabetes care. Then we need to maintain an inter-visit communication channel. So I am just giving little tips of things which we often miss. Everything else everyone is doing, so I'm not talking about that. So what happens between two visits? There is a The official guidelines are visiting, but often the visit can be even a longer time because, say, in COVID times, they were not coming in early enough. Then how do you communicate? And 3 months is a long time. If there is no follow-up, no way they can reach us or we can reach them, there can be a loss of motivation or care, or things can be missed. So there are various things that can be done in times of technology today. The simple things can be helplines. These can be 24/7 phone numbers that an educator can run or a type 1 leader can run. There can be WhatsApp groups which are seen at specific times so that they do not disturb us, and they can be groups of same age related or that village related or that town related. Some way we can put them in a certain group, or just boys or just adolescent girls or something, whatever criteria we want to use. They can be a buddy who can be assigned, a type 1 leader who is willing to just go in a rotation duty, saying that I'm available from 4 to 8 every day. If you have a problem, call me. So these can be done. These can be done. We have an hour of online type 1 meets every day, and that is how Udan, my organization, is reaching out to the remotest of village, because even when they're sitting on the bullock cart under a tree, they have a phone which has internet on it. So that is the biggest technical advantage today that has helped us to train our patients, stay connected and keep motivated. And social media, especially for youngsters, is extremely motivating. Hence, it's not showing off. It is actually a big motivator to hear success stories and share all kinds of training, teaching. YouTube videos can teach in every language. You can reach every corner. So maintaining an inter-visit communication channel is very, very important. It can be a very humble helpline to a very complex site or technology. Another small tip which I would like to add here is maintain documentation. Often we talk to people who have a lot of children, who have seen adults with type 1 diabetes, who are taking care, but they do not have a structured documentation program. And then either we lose out, we have loss of follow-up, we don't have data, we cannot take care of them because the last data is lost. And so many patients we know are very careless and they don't have their reports, etc. So a good registration process with all the details, including permissions. So that is one tip. Do take permissions from our patients, that if you want to use their photographs, if you want to use their data, if you want to be able to call them, because they can take objection to even being called. So anything, take all the permissions, take all the due form and all the information needed. And then we need to maintain documentation for investigations part, of course, as a follow-up, because you want to know how it is progressing and you will want to be able to look back, as well as the clinical, say the growth chart, the blood pressure measurement. So everything, it's very important to have a documentation. Very good softwares are available. I'm using a very simple one which helps me on a click. It's on my phone, it's on my laptop. Anywhere in the country I am, in 1 second I can see the data of all my 900 children in 1 second. So I think that is something we should all do. Now coming to what can make a big difference. So out of hundreds and thousands of things which my dear friends here will be sharing, I'm sharing one important thing which I felt is focus on the first month. A person who comes with newly diagnosed type 1 diabetes is vulnerable. Their family is vulnerable. They are traumatized. They have actual lot of blood sugar fluctuation because they have come after infection or newly detection, and the doses are not yet settled. So they may be on very high insulin doses which reduce later, vice versa. So it's very important that our first month is the intensive phase, you can say, of care, not of treatment necessarily, but of care. So busting the myths around type 1 diabetes in this time, emphasizing on insulin always. We all know that we are talking about a lot of social media campaigning where insulin can be stopped and people flock there and sometimes are at the risk of losing their life. So that is the time to emphasize that never are you to stop insulin. Then also address honeymoon phase in the first month itself, because if they land in the honeymoon phase and requirements go down, they're very susceptible to all the alternative therapies. So we have to warn them against them. And again, perfecting the insulin and monitoring techniques in the first first month, managing hypoglycemia and looking out for anything that we can miss, all the comorbidities in the first month, so our patient gets worked up, and individualization of a treatment. Because we will come to know whether the patient comes from a low socioeconomic group, patient has literacy issues, access issues, family environment, whatever it may be, doesn't matter. Or everything might be just great, might find a very intelligent child. The level is so high that we can offer them more. So the first month, I would like to emphasize, is a very important time. Please take out time. If we do not have time, please see to it that someone who has time sees to them, because once traumatized, that impact can last a lifetime. So hand holding for the first month gets to be very warm, very soft, and very, very special. And that will set the tone for the entire diabetes management for the rest of the child's and the family's life. So individualization of care is the next thing. Every person who walks in is not the same. They will need insulin, yes. Principles are the same for everyone, but which insulin, how, what device, what method? We have to individualize. Monitoring, physical activity, follow-up and investigations, availability, affordability, accessibility, emergency care, and medical nutrition therapy. So these foundations of care have ultimately in the center education, education, education. So that is the pillar on which everything is based. But we have to individualize this. This is what can make a very good care method if we individualize the treatment. And I'm going to talk about that very briefly, each one of them. I'm not going to go into the insulin regimes, but I want to really emphasize that we have options for everyone, from the humble regular insulin and NPH to be used as a split mix regime, to the basal and bolus, and of course the insulin pump for all who can. Let's offer them, everyone who can. Let's not deprive them thinking they can't. I know patients from villages who said, ma'am, offer us the pump, we'll have it, we'll find a way, we can get it sponsored, we can get it from the MLF fund, we are smart enough. And sometimes we over or underestimate our patient. But if all those things, we can make all kinds of regimes which using regular and NPH, if there is no affordability and accessibility of basal and bolus analog insulins. So mix match as per the need regime can be created in every clinic everywhere in the country, but no premix insulin, please. It is, in a growing person with type 1 diabetes, it is not what we want. We do not endorse premix. It is either a 30% or a 50% formulation, and both of them give us inadequate short acting, and there's no flexibility. We know all the harm that comes in. It's not covering the lunchtime. There's so much of glycemic variability. I know it's easy, it's convenient, but at least in that case, one can go for regular and NPH. Suppose it's better than dying, I agree. If there's nothing else, regular and NPH, at least the doses can be taken. So let's give everyone option with the basic to the best insulin with interesting regimes, because we know the physiology. Let's make it happen. Let's offer the pump to everyone and no premix insulin, please. Next comes the monitoring. So we all know we have to do it. It has to be logged. I just want to say that we all know the 8 sugar pattern. We know it should be done, but create your own patterns. That is what is the secret to good care. Learn, and there is no point in just checking if we cannot interpret them and take action. So the action can be point of time, which the family has to learn, or the action can be seeing a pattern over a couple of days or a week, and that an educator can help. It can be messaged, it can be mailed, or it can be met, and then the pattern can show them how to set the doses. So either way, unless we learn, so I have demonstrated a pattern I call 3+7, so 3 sugars every day and 8 sugar one session, willingness, and how much the child needs. At some stages they may need more monitoring, sometimes less, but create your own pattern which suits them. Have a dialogue, set that pattern, and make a pattern which is individualized as per the accessibility of the strips. But there is with insulin without monitoring is absolutely it's hardly a treatment, right? So when we talk about insulin is essential, we also talk about monitoring is essential. So we can tailor make it for anyone we can, and whoever can should have a CGMS. We have so many things like the Libre Pro to the everything. So all that technology session is going to be there. So I'm not going to into it, but I'm just saying for those who have not used, at least try it once. It is just such a wonderful learning curve that one has. Continuous use is wonderful, but also intermittent use, maybe once in 3 months to set the pattern by the doctor can be amazing. There is an insight, you can fine tune the care, and the person who uses just has an eye opener. They know what affects their sugar, what activity, what food. I mean, you can tell a doctor something else, but a CGMS is going to tell the truth to one own self, and that is a wonderful motivator. So it gives a lot of flexibility. One can play, sing, dance, whatever, and it really gives them flexibility. And that's something please try. Whoever hasn't, at least try once. So this is just one of my little girls who is on a CGMS, and look at their smiles. I mean, they were so happy that all the little ones, I just want that to happen. So next topic we all talk about, it's tough for doctors if you don't have a nutritionist. So nutrition is a very vital topic. We have to learn, there's no choice. So balanced plate is the first basic thing. Identifying macros, everyone can learn. People who cannot do actual carb counting because of literacy issues or IQ issues or anything can do visual carb counting. Then actual carb counting has to be learned. It's so difficult. It took me so long to learn it. It was tough for me, but ultimately I had to, because I have to communicate with all the children and their families. So I had to learn it. So that is very important. And ultimately one can do a self-meal planning, carb counting, dose adjustment. We cannot skip this chapter. Absolutely, we cannot. Maybe there can be levels, but we cannot skip it. So every family can learn to eat healthy, can monitor, can adjust doses as per the nutrition, can do carb counting at certain level. For example, this is little Sapna, and look at her plate, it is well balanced. She can do visual carb counting. She knows that her chapati is of 1.5 carb count. She knows how much that dal is. So she balances her plate and she knows visual carb counting. Otherwise, she cannot, because they're all literate. One very important topic is follow-up. So we can't just treat and let them go. So whichever guideline, I'm not going to go into this table, and this is the ISPAD guidelines of follow-up at 3-monthly level, micro, macro, autoimmune, psychosocial, anticipatory guidance. Please go through it, whichever guideline you follow, or make your own protocol, but there has to be a follow-up structure and screening. So these are some of my children who at regular intervals at various places will go step by step and get the screening done. I won't call it last, but yes, the most important is the education and its tools. So we can give them basic education, we can give them comprehensive and advanced. Whoever feels I don't have a team, at least go for the basic first. Take time, next level is comprehensive. And then of course with technology, we can go into advanced. But every person can be and must be educated irrespective of literacy status. There are many tools. I mean, there are many, many tools, and whoever is willing to learn, I cannot speak here, but there are a lot of ways one can do that. And Shuchi is one of the best designers for many of these tools. And these are some handmade tools that we use like games and board games and pins and playing cards. So many things one can do. Again, amongst the tools, it is the earthen pot in which we store insulin. So everyone has their own way, but I'm just saying if you do some jugaad, there is so many ways of reaching out to children. And this is my last point, which is peer group activity. So please introduce people with type 1 diabetes to experience. These are experienced champions and they make motivated educators. And that experiential learning works way beyond what we teach. So this is a very essential. Every child says, I'm the only one in my village. And when they know other person, they feel very good. So this is where people bond. And the only bond here is that we all have type 1. So they're on top of the Altabad Killa and they're so happy. They learn, they are motivated, and they get better. It is still easier than said than done. We try to learn, and this is what all the calculations, which all everything looks like. It is so, so tough. We know, but we also know that we can do it. So every child deserves the best to lead a fulfilling life, and we can do it with some basic steps and structure in place. And that is my message, that do not skip any step. Innovate, improvise, find a way to do it, create your own teams, but do not skip any aspect of care. Wherever you are, reach out to an organization nearby and then do it. But do it. Do not leave a step unturned. Thank you so much.
Thank you, Dr. Archana, for a wonderful talk on the tips and I can say tools for the management and from beginning of the insulin to the family or the type 1 diabetes say that I'm not alone. Similarly, we have 6 stalwart of the legendary of the country here and the beginning is so excellent. जब आगाज इतना अच्छा है, I can understand अंजाम बहुत अच्छा होगा. Today we are wonderful speakers and I don't want to miss a minute, a second in this talk because there's we cannot, and every time we are learning and learning and learning every time. So thank you very much, ma'am. So I think we will take question answer in the last, and everybody I think will stay up to 6:20, 6:15 because this session is going to a wonderful session. So for the next speaker, I request Dr. Suchi Chuk to invite the senior most speaker of today's talk is Dr. Jingan sir.
Thank you, Dr. Ramchandani, and thank you, Dr. Archana. Your talk endorsed one thing, that hope, connect, and empathy can do wonders. And to introduce Dr. A.K. Jinghan is a very difficult task because everyone knows him and he is working in the field of type 1 diabetes since last more than 3 decades. He's founder of Diabetes Education and Research Foundation. He's founder of Juvenile Diabetes Association of India. Most of you will be knowing that he is the one who started diabetic matrimony so that every child with type 1 diabetes can live a healthy and normal life till eternity. He is the one who was the key so that the CBSE allows snack break for children in board exams, and that now has gone to NEET exams and other exams also. So I'll not take more time. Dr. Jinghan, please. Thanks a lot.
Thank you. Thank you very much for such a nice and kind words, Dr. Suchi, because I know everybody knows that whatever we are talking today, you have gone through all those stages. And I think you are the best role model, and any program or whichever we want to have, we must take your consultation, take your advice, because the person who has gone through all those stages, I think he can guide us in a much, much better way. Thank you very much for the Diabetes India for inviting me for a part of this thing. It's such a prestigious and I think August gathering. I'm to the chair and my regards to the both chairpersons, Dr. Ramchandani and Dr. Suchi, for permitting me to present this program. This is about the strategy, about how we can go ahead with this, and that is a public healthcare system. Because after Dr. Sharda, she has very, I think, nicely how to deal with how we have to, because everything is a different, and it is a individualization, because each child treatment is a different. So that no uniform policy can be there. And based on that, I have made some presentation. So I'll just share with you. And this is regarding the how we can have about this thing about the program and how to go ahead with that. So this is about the type 1 diabetes in India, that we know that number of the incident cases below the age of 14 years. And we know that India is having the highest number, 10 in the top 10 countries, territories for the number of the cases. And then coming to the other slide, where again the number of children and adolescents with the type 1 diabetes in thousands, that we again, the India is again making a top and this thing. As such also, you know, the diabetes, as regard the diabetes, India is a capital of diabetes in the world. And if we talk about type 1 diabetes, again, we are seeing that number are increasing every time. About when we talk about the overview, these are the 2 slides, which I'll be about the overview and what are the problems which are faced by the type 1 diabetics, that we have a healthcare system run by the country, different states and territories of the India. Parallel to public health sector for both urban and the rural India, we have a private medical sector is also, which is more popular. Presently, a program called as the National Program for Prevention and Control of Diabetes, Cardiovascular Disease and Stroke is being run by the Government of India. So that's a one part which is there about the diabetes and the other diseases. So practically, we don't have anything about the type 1 diabetes, and that's there is a huge diversity of income among the people in India with such a huge population. And that's why the factors like cost of insulin and medicines, lack of awareness, social barriers, poverty, and we hope that everything will improve due to proper support from not only the government but also the NGOs working in this field. Despite the steep growth in the Indian economy, there has been a lag in the growth of India's health system, and which is quite inadequate to meet today's healthcare demands. And I think that is the reason that the RSSDI has now brought out some program, and which is, I think I'll be just discussing in the next slide. And this is a real good one because this is a one program where we are going to take care about the children, about their care, about their follow-up, about their education part, and at the same time that they should not get the complications, because this is a very, because in the developing countries such as India, we have a huge burden of diabetes and its complications. There are several issues, including the socio-economic factor. These, the general physicians, they don't insist upon the regular monitoring. Access to the healthcare in different parts of the countries. I think the people are lucky that who are staying, and those people who are taking care of a type 1 diabetic, I think Dr. Bansi Sahu, Dr. Sharda, Dr. Dalal, Dr. Shukla is one of the very dedicated person. So they are taking care of these children. But overall, if we talk, many areas, many places are there where they could not get the proper care, and non-adherence to the recommended guidelines, because the government also does not pursue. At the same time, the physicians also not very much aware about this thing, and that's why these guidelines are not followed properly. So this is how we can have the strategies for improvement, and this is that everything should be based as a public-private partnership platform and working in an environment where the patient-centered affordability should be there, and areas to focus is the holistic integrated patient-centered approach, high intensity and sustained mass awareness programs, then easy access to the healthcare facilities with the extensive use of teleconsultation. You just now saw that Dr. Sharda said that how those patients who are their type 1 diabetics, they are in touch with each other, and those 900 patients, how they are getting benefited with this. Affordable monitoring and medicines cost for effective diabetes management. I think that's one issue, because many a time these things are so expensive. If we talk about the conventional insulin, they are very good. But if we talk about the today analogs, they are quite expensive, and that's why it's a cost is the factor. Again, the policy and the planning, apart from the lifestyle behavior, that the government should abolish or reduce the sales tax excise duty on insulin syringes and drugs. And we tried, and we have been, I think I remember when Dr. Sushma Swaraj was the health minister, and at that time, we were able to get all those taxes abolished. So that was some people, they do take care of this thing. They are sensitive, they care, and this thing. And I am sure the present government will also, after the RSSDI takes initiative, that something will be done on this. Coming to the education part, I think this is the cornerstone of I think the thrust should be on this program, education, because if we can improve the patient's knowledge about the disease, if we can improve about the dietary habits, because many of times they don't know which things to eat, which things to be avoided. improved physical activity. That's again this thing, because many a time they will say, oh no, you have a diabetes. So many a time we came across the children who are going they were studying in the school, and when they were raised their hand for any physical activity or any competition, the teacher will say, no, 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 sit, you have a type 1 diabetes. So at that time you can think of how much trauma these children would have. So improved adherence, improved SMBG, good glycemic control, improved behavioral changes, and at the same time, smoking cessation and the weight reduction. These are the main, I think, the constituents which can lead to reduced complications in the hospital admission, reduce depression and anxiety, because this is very well seen in these type 1 diabetic patients and in their parents, higher cost effectiveness. So all these benefits we can have if we can take care, if we include these things in our patient education. And structured education, that means diabetes, the same thing is, I think this is a repetition, that self-management, diabetes patient education, clinical outcomes, and smoking cessation is there. So how we can do that on a mass level program? So large scale education programs for creating mass awareness for prevention, management of diabetes, targeting the general population, healthcare providers and policymakers in India for promoting the concept diabetes self-care. I think Suchi was saying, I remember 30 years ago when the children were in the type 1 diabetes and in the school, they were having a problem. And I went there in the school, talked to the teachers. He said, we don't even know about the diabetes. What is a type 1 diabetes? We don't know about this thing. So that was the scenario I'm talking about the 30 years ago, but it has now changed and the more and more awareness is there. So diabetes health mela, checkup camps, road shows, educating the school children and teachers about diabetes so that diabetic children can be looked after well in the school. And I think this has really helped, because then when we started these programs in the schools, the children were having a less episodes of hypoglycemia. They were not sent home when they were sick, and they were taken care in the school. With that, the moral boosting, it was a moral boosting for the parents. Otherwise, every now and then they have to rush to the school. Aggressive mass media campaign through the books, I think, with the leaflets, handouts, and spreading awareness to help the diabetic patients. Eradication of a diabetes in type 1 as a social stigma amongst the younger generation, that's there, and promoting the adoption of a socio-economically poor type 1 diabetic patient. I think that is the main idea or a theme behind the RSSDI program about the type 1 diabetic, that how they can take care of this socio-economic factor and their care. I think this is a various technology platforms for patient education, video conferencing equipment, TV, but these are all, I think, it will take time to reach to the rural program. But I think the rural area, I think the best is the telephone contact. And what Dr. Sharda was saying, that most of her children are having a WhatsApp in that, so that they can see, they can get knowledge. And that is the same thing should be enforced on a major scale, so that large number of type 1 diabetic children who are at a far off places, they can get the help. Again, the internet, and again, by means of the spreading all these awareness, by leading this thing, you can take care of these patients. Sorry. So coming to that, about the affordable monitoring and medicines cost for effective diabetes management. The cost of diabetes medication, particularly insulin, should be reduced. Up to 25% of patients who are prescribed insulin report cost-related problems. And insulin underuse due to cost has been termed as a cost-related medicine, that is for the non-adherence, that is called as the CRN. Teleconsultation is a growing field that may increase access to the care of patients. Teleconsultation includes a growing variety of applications. For rural population or those who with the limited physical access to the healthcare, consultation has a growing body of evidence for its effectiveness. And as HbA1c is the very good thing, but as Dr. Sharda said, that we can go for nowadays they can have a continuous glucose monitoring, And I think some of the pharmaceutical companies are freely distributing these gadgets so that the children can be taken care of very well. About the lifestyle and behavior well-being, successful diabetes care also requires a systematic approach to the supporting patients' lifestyle and behavior changes. High quality diabetes self-management education and a sustain has been shown to improve self-management satisfaction and a very good glucose outcome results. National diabetes self-management education standards can for all integrated approach includes clinical content and a skill appropriate diet and a physical activity regime and a behavior changes. This is what over the 35 or 40 years what we were doing, that you can see from that when Dr. Harshvardhan was just in the Delhi as a health minister long back about 15 years ago, then we started a diabetes education for school teachers for these and there that the how that awareness can be there. Based on that, then we had this about programs in the rural areas. We'll go there and find out if there are type 1 diabetic children are there. At the same time, we'll have annual health melas so that we can create awareness. And that you can see at the type 1 diabetic children, patient counseling, parent counseling, and here you can see Dr. Madhu is there, and from the professor of endocrinology, pediatric endocrinology, Dr. Jain is there, apart with all these type 1 diabetic children and their parents. So I think basic idea is to show this, if the same models can be replicated at a larger scale and a bigger scale, and by all the, I mean to say, those who are dealing with the care of type 1 diabetic. And here I'll say that RSSDI is taken initiative by all those which are called the healthcare centers or the type 1 diabetic care centers which they have selected. And through them, they are going to distribute these glucometers, insulins, all those education material, those diabetes educators who will take care of. I think such type of the program will definitely in future, what problems we are seeing today, maybe after 4 years or 5 years, we will be in a better position, and there will be a time when most of these type 1 diabetic children will be taken care in a nice way, because we all want no diabetics should die because type 1 diabetics should die because of the unaffordability of the insulin. And we all want that they should also live a life like a normal person. So this is the aim of RSSDI. All people who are 6 people who are dedicated people here, that how we can help our type 1 diabetic children. Thank you very much for listening patiently.
Thank you, Dr. Jinghan. Thank you for creating awareness, and thank you for working so long against all stigmas which type 1 diabetes face. Now I'll request Dr. Ramchandani to take this wonderful program ahead so that we can learn and really have a wonderful time for all type 1 diabetes in coming years.
Thank you, Dr. Suchi. आपको देख के मुझे एक शेर याद आ रहा है, दलाल साहब यहीं बैठे हैं, उनसे भी बाद में सुनेंगे। जिंदगी की असली उड़ान अभी बाकी है। उड़ान शब्द से मुझे याद आया, जिंदगी की असली उड़ान अभी बाकी है, जिंदगी के कई इम्तिहान अभी बाकी हैं, अभी तो नापी है चंद मुट्ठी पर जिंदगी हमने, अभी सारा आसमान बाकी है। So we have wonderful speakers ahead with us. And I think everybody is closely attached by heart to attach the diabetic children जो यहाँ पर बैठे हैं. So they are showing not only scientific content, but their emotions are there with the type 1 diabetes when they are speaking with the type 1. So now we are moving to the next speaker with a very important and very difficult topic and very commonly challenging topic in management of type 1, that is hypoglycemia, a big challenge in type 1 diabetes. And speaker is none other than Dr. Sujata Jali. She is from Belgaum, and she is attached not only in type 1 care of more than, I think, 1,000 children in KLEs, but she has won various awards, international awards. So she is working in KL University as a professor and head in the Department of Pediatrics. and she's a consultant in pediatric diabetes. And she is a recipient of Best Improvement Prize International Award 2020 last year by SWEET in amongst us more than 59 countries. For that, I request all of you have a big round of applause, because last year we were in everybody was in locked period, and she was the only diabetologist in the country who got this award. She got RSSJ Innovation National Award 2020, and her center is known as a Center of Reference 2019 and award by the SWEET Project Europe. She is a chief coordinator of IDF Life for a Child program, and there are various publications, various awards, and she's not only working for type 1 diabetes but also for thalassemia, and with the Rotary support with the Rotary. So I do not know that she does not require any introduction. So I met her twice or thrice, and I have very close attachment because my quite number of my family members living in that area near Mira, Sangli, Kolhapur, and that Maharashtra area. So I have one more attachment with Dr. Sujata Dali also. So I request Dr. Jolly to kindly go for the next session, which is very, very important. That is hypoglycemia, a very big challenge, and especially in our setting, in small setups and uneducated children, how to manage hypoglycemia. Dr. Jolly, ma'am, please.
Okay, namaskar everybody, and good evening. I thank Diabetes India for giving me this opportunity. And respected chairperson, thank you very much for your kind words for me. Today, I'm going to deal with a big challenge in type 1 diabetes, that is hypoglycemia. I think that is management is one of the pillars of management of type 1 diabetes. And out of all the acute complications of type 1 diabetes, hypoglycemia is the most commonest. And whoever is teaching or treating the type 1 diabetes should be aware of this hypoglycemic complications. And to introduce this subject, it's the commonest acute complications, as all of us know. And it's one of the barriers to achieve the optimal glycemic control, because the insulins go wayward with the dosages, and monitoring of hypoglycemia is a key component of diabetes control. And problem is young children remain at high risk of severe hypoglycemia because of their reduced ability to communicate their need. Suppose a 2-year-old child who has got hypoglycemia, he is like a parasite to his elders, that somebody has to feed him. As a pediatrician, I know how it is with the malnourished children. And so it is very difficult for him to communicate. Coming to the many definitions, what we have in hypoglycemia. Hypoglycemia by a patient is an event which includes all episodes of plasma glucose concentration low enough to cause symptoms or signs. So it may be 70 for one child, it may be 75 for one child. So it has to be individualized. Glycemic thresholds for hypoglycemia depends on diabetes control. A very tight control can go into more of a hypoglycemias. In clinical practice, we call it as a clinical alert or a threshold when it is less than 70 milligram. Coming to other definitions, clinical hypoglycemia is an alert where it is less than 70, and we recommend that they have to treat this below 70 or 70 hypoglycemia. That is clinical alert. Now coming to the serious hypoglycemia, when it is less than 54, which indicates a serious form of hypoglycemia, where the child may be having the defective about recognition, like sweating, like hunger, palpitation, all this may be there in this. Coming to the severe hypoglycemia, is defined as an event associated with severe cognitive dysfunction. This is very important because every child at least has 1 or 2 episodes of severe hypoglycemia, and it has got its own complications, which we should recognize. Subgroup is hypoglycemia coma also. And what we have to note here is that as young children require assistance to correct even a mild hypoglycemia event, so we have to train the caregiver to know the signs and symptoms of hypoglycemia. This is a very important slide for all the doctors here regarding the hypoglycemia. It is from ADA again. Severe hypoglycemia is the one which requires assistance to treat a child or ameliorate the hypoglycemia. Second is a documented symptomatic hypoglycemia. When a child brings a logbook to us and all, there is an documented hypoglycemia, so which is less than 70, and the child is symptomatic. We have another category where it is documented, but the child is asymptomatic. This is again very important when we talk about HAF, that is hypoglycemia associated autonomic failure. So this recognition is very, very important for us. And another terminology what we can use is probable symptomatic hypoglycemia. Here typical symptoms are there, but a child has not documented that the blood sugar is less than 70. Another terminology is pseudo hypoglycemia, where the blood sugar is more than 70 and still the child is behaving as if he has got hypoglycemic episodes. So these 5 categories we should recognize during our practice. So another classification what they do is, tell is about level 1, level 2 and level 3 types definitions. Level 1 is that without any symptoms. Okay, level 2 is that it is symptomatic and he can treat himself. Self-treatment can occur, that is level 2. Level 3 is that he requires a help for the episodes of hypoglycemia. Now we have defined hypoglycemia. Now let us see the incidence and how we are happy now that COVID is coming down in India. Same thing in 2000 and 2009, 12% of there is a decline in a cohort study in Australia, hypoglycemias. And severe hypoglycemia, even in Danish, 50% recognition is there, maybe because of the awareness and maybe because of the technology. In DCCT trial, we had 61 per 100 patient year in intensely treated versus the 19 in conventional group. What I mean by per 100 patient year is that it is number of new cases divided by total person time at risk. So if a patient is contributing for 6 months, 10 months, so it is the time at risk. So international registries have shown that America has got about 7.1, German has got 3.3, and other Western countries have got 6.7. And type 1 diabetes patients, on an average, they suffer 2 episodes of symptomatic hypos per week, or they suffer from 1 to 2 episodes of severe hypoglycemia per year, which is again very bad. And first it was seen that the children below 6 years of age, they have got more hypoglycemic episodes. But now in some of the studies, they say that there is no age difference of hypoglycemia. This again slide is showing that as the incidence of severe hypoglycemia increases with duration of diabetes and type 1 diabetes. So the last bar is showing 53.3 with the symptomatic hypoglycemia and 0.49 again increasing with severe hypoglycemia. That means with a longer duration, more of these hypoglycemias are seen. Why hypoglycemia challenge in type 1 diabetes? So infants and toddlers are at high risk. They are at high risk because their food is variable. He takes the insulin, then he says, Mama, I'm not feeling hungry. The insulin has already gone into the body. Whatever the blood glucose levels are there, it starts its action. Unable to recognize the early signs of hypos, of course, in younger children. Limited ability to seek a source or a help. So if an adult has got, or if an adolescent has got hypoglycemia, he goes and he takes his hypotabs or he consumes a carbohydrate accordingly. But child cannot do that. Nocturnal hypos are the worst what we see in the children with type 1 diabetes. And again, it is called as sleep induced HAF, it is called as, because the duration of in the night, the duration of the inter meal is very high, and insulin sensitivity is more in the night, and other counter regulatory hormones are more in this, less in this night. It is a major limitation for the tight control. Once he gets an hypoglycemia, he goes on reducing his insulin dosages. Once injected insulin, absorption and action are independent of the sugar levels. Severe hypos are frightening not only to the child and to the family, and it becomes a taboo if it is done in the, if it is noticed in the joint family or a school or in a group when your child goes for a play. And it causes defensive overeating. Very common. When we sit in OPD, the mother says he feels a little bit giddy, means he goes on eating chocolates, he consumes a lot of sugar. So these are defensive eating can occur. Then long-standing type 1 diabetes lose ability to secrete glycagon. It is secondary to beta cell failure, which later on causes the decreased glucagon secretion in alpha cells too. Recurrent episodes with tight control may aggravate deficiency. Economic burden is so much, and affection of workplace productivity. If a child has got a severe hypoglycemia, he has to get admitted, and again it becomes an economic burden to them. Long school hours. There was a study, very interesting study done in Pune. So he said that for type 1 diabetes, how much it takes time for him to travel to school and back, and the number of school hours. So he tend to get type 1 hypoglycemias in these school hours also. What is the physiological defense we see once a hypos in a non-diabetic patient? Our body is great where it decreases the beta cell insulin secretion. It increases the alpha cell glucagon secretion, increase in adrenomedullary epinephrine secretion. This epinephrine is very important because it limits the utilization of glucose and mobilizes gluconeogenic precursors. But all these defenses are typically compromised in children with type 1 diabetes. Again, this diagram is showing an glucose counter regulation. You can see here that there is a decreased insulin in a normal person and increased glucagon in a normal person. Because of the loss, it is lost in, both these are lost in type 1 diabetes. So these are, again, next diagram is also very important here. In a case where there is a type 1 diabetes, there is absolute beta cell failure. Relative or mild, moderate, absolute therapeutic hyperinsulinemia occurs, and falling glucose levels occur. Beta cell, if there is a beta cell failure, there is no decrease in insulin as a defense mechanism, or there is no increase in glucagon. And these episodes of hypoglycemia are, in addition, you can have an exercise-induced HAF or sleep-induced HAF. Even in exercise-induced HAF, which occurs after more than 6 to 8 hours of a severe exercise, and where he can, though he has an hypoglycemia, but his awareness decreases in this case. So all this together, defective glucose counter-regulation, hypoglycemia, unawareness, it results in recurrent hypoglycemia in these cases. Now, what are the risk factors for hypoglycemia? Risk factors are recurrent hypoglycemia. I will show you what are the effects. If we want a child to have an HbA1c less than 6.5, I'm sure ISPAD and all have allowed us to extend the HbA1c up till 7. High glucose variability, long duration of diabetes, I showed you in study already. Impaired awareness, that is half what we have got. Hypoglycemic unawareness, autonomic failure. Alcohol ingestion, again post-alcohol injection, you can have nocturnal hypos also. Less food consumption, very common in our neonatal diabetes who are now 4 years, 5 years, and children who are less than 2 years. And insulin itself, that is called as therapeutic hypoglycemias or hyperinsulinemias causing hypoglycemias. And the symptoms, as you all know, is shakiness, irritability, confusion, tachycardia, and hunger. Now, coming to the advanced signs and symptoms, what they can have is, with autonomic signs, they can have shakiness, sweatiness, trembling, and all. Neuroglycopenic signs and symptoms are very important. As Archana said, education, education, and education. How Vidya Balan had told entertainment, entertainment, entertainment. Same thing here, we have to do education, education, and education, because this portion is very dangerous, which can cause lot of complications for the child even in future, which I'll be telling you all later on. Behavioral problems are there, and some non-specific problems are there in these cases. So what it all can affect? It can affect the brain, cognitive dysfunction. It's a growing child. It has to go to college. It has to do complex mathematics. When he loses his cognitive dysfunction, then he'll be backward in his studies. So impaired memory formation, seizures, epilepsy, and fear of hypoglycemia is very important. Musculoskeletal falls, fractures, again, a lot of traumas. And heart, it can cause myocardial infarction, arrhythmias, dead in bed syndrome. In one of the studies, they said that 50% of the deaths in type 1 diabetes occurs because of dead in bed syndrome, because of the hypoglycemia. There is inflammation like COVID, you have IL-6 increase, CRP is increased, then these inflammatory markers are increased here. Hemodynamically, coagulation, there is an platelet activation is there. So endothelial dysfunctions occur. See, so many things can occur because of hypoglycemia, which sometimes we do not concentrate on these children when they complain about hypoglycemia. Now, I have explained about the medical consequences, employment for these children, driving. If they have hypoglycemia, they can end up with accidents. Travel becomes very difficult. Socio-economic, social traumas, all these are social consequences where a child can present with. Cardiac, I have already told you, they can have a prolonged QT interval. They can have arrhythmias, so they can die in the night because of the arrhythmias. This is one of the study done in Norwegian. 12 out of 20 hypoglycemia related deaths were because of the hypoglycemia. Dead in bed syndrome can happen, arrhythmias can happen. Neurological sequelae with severe hypoglycemias are very common. You can see they do not attain the full-scale IQ scores. Working memory is less. They have a larger hippocampus volumes. They have temporal sclerosis, reduced gray and white matter volumes. A child of 5 years, if he has frequent severe hypoglycemia, these are the consequences we can have. Psychological impact will be there. I have already told you. These are the two studies where they showed that sweating and tremor, it goes on, the awareness goes on decreasing as the age progresses, and severe hypoglycemia without awareness also goes on increasing as the number of years with type 1 diabetes. And this is again interesting study where they have done percentage of patients decreasing their own insulin. So see, 74% with non-severe episodes, they have decreased insulins. And with severe, they have decreased 79%. So even when they have interviewed the physician, treating physicians and all, they have also said that they will be also modifying the insulin, which comes in the way of their treatment. Now, how to manage the hypoglycemia? Again, education is very important, and you can give them 0.3 grams per kg of glucose to the child. For example, if a child has got 50 kgs, at starting you can give in 15 gram of glucose. And please do not use these chocolate milk, milk, foods containing fat, because they decrease the absorption of glucose and they cannot treat the hypoglycemia. In severe hypoglycemia, glucagon subcutaneous IM is very, very important. 0.5 milligram below 20 kgs, 1 milligram above 20 kgs. Even in emergency, you can hit that needle over the cloth also to save the patient in this. Intranasal single dose glucagon has come, but it is still not approved in pediatrics. Then another one is in hospitals, if the child is hospitalized, you can give 2 to 4 ml of 10% dextrose IV and followed by about 5 to 7 grams of glucose per kg per minute you can give. So you can treat them with the oral and you can treat them with the glucagon. So this is very important slide, but since I have less time, if the insulin, you have to take a history of insulin, type of insulin, recent food intake, recent physical active patient. It need not be a medical person who have to inject this. Please teach to the all the people at home, and this contains an lipolyzed powder with pre-filled water for injection. You just inject it in this and then you give IM or subcutaneous. Now we have this Goac hypopen, but it is costing $280. But you know, you just this red this one is there, end is there. You touch the skin and then press it. When and color changes here, that means you have already injected, and this need not be required to keep it in refrigerator. There is no visible needle is also there, but only thing is that it is $280. And these are the sites where you can inject the glucagons in these children. Now, this was a switch study. I was talking about type of insulins which can cause hypoglycemia. So they have done degludec with aspart and glargine with aspart. In degludec and aspart, they have shown reduction of severe hypoglycemias and nocturnal hypoglycemias. But A1C, there was no difference. But it made a lot of difference with severe and nocturnal hypoglycemias. So these are, I'm not going to talk in details. These are some of the technologies which can prevent hypoglycemia, because they can be shut off of the insulin delivery half an hour before the hypoglycemia. So these are some of the gadgets we have. And now we have got the multi-hormone the other part. So multi-hormone pens have come, and these are very important when we cannot afford with the pumps. So these are some of the smart pens. You see, they can record the amount and timing of each insulin, and these pens can be through the Bluetooth, they can be connected to the mobile app, and he knows. These are very important with recurrent and hypoglycemic episodes, psychological distress. So we can ask them to keep these pens here. So my last 2 slides is that how to prevent hypoglycemia, taking proper and timely diet, especially children below 5 years of age, taking insulin at correct time at the prescribed dose. Type of insulin modification is very important for we doctors when a child is going in for recurrent hypoglycemias. And we will try to use the technology, as Archana said, you give an option for even the pump, CGMs. We are putting CGMs in many children who have got nocturnal hypoglycemias. And to sum up my talk, acknowledge the problem. If any child doubtfully or a mother says, my child had even pseudo hypoglycemia or suspected hypoglycemia, we doctors should take it very seriously, talk to the parents, and when does a hypos occur and what changes in the brain and heart it can make, especially the cognitive disorders. Apply the principles of aggressive glycemic therapy here. Then patient education and empowerment is very important regarding anticipation, recognition, and treatment of hypos is very, it needs a skill, it needs a decision making, which we should teach them. frequent SMBGs if they cannot afford CGMs, flexible and appropriate insulins have to given, individualize the glycemic scores. If a child with 7.5 A1C is going into repeated hypos, please verify, take the proper history, change the insulin and see that you put a CGM and you can remove the cause of hypoglycemias in these children. My last slide, consider the conventional risk factors for hypoglycemia in this child, insulin dosage, reassess the timing, the type, what is causing hypoglycemia in this child, whether there is an endogenous or exogenous influx or efflux of the glucose. Consider the risk factors for hypoglycemia regarding the HAF, the degree of endogenous insulin deficiency, history of severe hypoglycemia. Friends, severe hypoglycemia, I don't think we should see these in these days where there is a technology, when we are giving them 24/7 helplines, so they should not go into severe hypoglycemia because they have to study, they have to grow, they have to be independent, this type 1 diabetes. So we have to concentrate when we want to them to lower their A1C levels. So proper history, education, and most important, our patience when we have a child with hypoglycemia is very important to tackle the hypoglycemia. Thank you, Diabetes India and the chairpersons for patient hearing. Thank you.
Thank you, Dr. Sujata Jolly ma'am, for an excellent and awesome presentation of that very difficult topic, and definitely cover the entire part from symptoms to the latest technology, and you cover the each and every top part of that hypoglycemia in a wonderful manner, in a very good slides. They are really, I was just taking the photograph in my mobile because the slides were wonderful. So thank you very much, ma'am. So definitely we'll take the question answer in the last, I think.
Sure, sir.
So now I request Dr. Next speaker, and I request Dr. Suchi to kindly invite our next speaker, as Dr. none other than Dr. Rishi Shukla from Kanpur.
Thank you, ma'am. Thank you, Dr. Ramchandani. And to introduce Dr. Rishi Shukla is actually the very most difficult task, because it's my pleasure to introduce him, and it's my honor to. He is none other than Rishi uncle for us, because I have known him for such a long time. Or everyone knows he's DM endocrinology. He's one of the renowned endocrinologists in UP, in Kanpur. He is one who organized first national type 1 diabetes meet at Kanpur in 2007. And I think that was a great fun. And over to you, sir. And please enlighten us.
Slides are visible? My slides. Am I audible?
Yes, sir.
Yes. Good evening, friends. Thank you, Shuchi, for nice words. And it's nice seeing you growing. Dr. Jingan was mentioning. So I'm at the back of Dr. Jingan. And thank you, organizers. I'm seeing all my good friends, Dr. Ramchandani, Shuchi, Dr. Manisha, Dr. Jali, Archana Didi. Where is Archana? So all good friends are there, and we are जैसे सब लोग मिलकर के सत्संग कर रहे हैं. Something like this. It's sort of this thing is happening to us. And thanks, Bansi, to push forward juvenile and young diabetes in the country, because I think Manisha must have mentioned that I remember 20 years back there had hardly been any sessions, and Dr. Jingan would remember any sessions in our diabetes meetings. They used to give one talk or two talk, and I think we have started pushing forward things for last. It is the hard work of 20, 30 years that we are seeing the fruits. But before I close my eyes, I have seen the fruit. So this is the wonderful thing that has happened to me. So many sessions, so many people are interested in type 1 diabetes. So I will live happily and I will leave happily. So both ways, I'm a happy man at the moment. Thank you for allocating me the topic pertaining to my specialty, because endocrine things I looked at, it's really interesting. And what am I going to talk is thyroid disorders, which are very common, celiac disease, Addison's, polycystic ovarian disease in type 1. I think I will have a word. Erectile dysfunction in type 1, we seldom talk about it because most of the time we encounter with younger patients. Hypogonadism and hypothalamus. So this is lastly low body weight, they have amenorrhea, and it is like a central hypogonadism. Second thing that I have noted, I think maybe I'll share when I discuss the polycystic part. First, coming to the thyroid, type 1 and thyroid both are autoimmune disorders, so share a common connection. Up to 17 to 30% of time, autoimmune thyroid disease occurs in up to 17 to 30%. And the risk of hypothyroidism in any type 1 diabetes is around 25%. Both hyper and hypo are more commonly associated. So I think there was a word I was speaking on type 2. So type 2 is also associated and type 1 is also associated. Poor diabetes control predisposes. So again, the role of control comes. There are some studies.
I'm sharing the slides.
Coming to thyroid antibodies, thyroid peroxidase antibodies are present up to 25% as compared to 10%. So 2.5 times more common, and 5 to 50% in different studies convert into autoimmune thyroiditis. So that is another important thing. In larger part of these patients will develop hypothyroidism, but a subset of them also develop hyperthyroidism. So always keep in mind the hyperthyroid, the thyrotoxicosis also.
Beloved Sadhguru sir,
Duration of diabetes may be a risk
who
factor
renewed the
for
show,
type 1,
and I must
but not
thank
type 2.
Dr.
What are the
Bansi
factors? No,
and
this is
his
not
great
specific,
team,
but these are general factors.
our great
Responsible thyroid,
whole team, sir,
hereditary,
and the
increasing
colleagues,
age,
and the
puberty,
whole team
female
for
gender, estrogen use,
continuing the
pregnancy, and association of any other endocrine
I'm very
disorders,
proud to be
which
part of
of
diabetes
which
India.
type 1 is one of
I'm
them.
shine the topic
Management part,
NFL and
the
diabetes
hyperthyroidism, I would like to put a word.
and this all of you know very well.
The standard management like
Diabetes
antithyroid drugs,
is
radioactive iodine, or surgery.
very conscious.
But for
Today I'm
subclinical
teaching you
thyrotoxicosis, and if the patients are on the, suppose patient has had 20 years, 30 years, 35, 40 years of diabetes, then they are more prone for coronary events, and there we should initiate therapy
and then there are
even in
situations
subclinical
related complications
thyrotoxicosis.
like
So that is
anemia,
important.
cirrhosis, cryptogenic cirrhosis,
Hypothyroidism,
NAFLD,
standard treatment
and
is
TISCO, which
to start thyroxine when TSH is more than
recommended by
10.
all gastroenterologists,
Important thing is whenever we start treatment, it improves lipid profile and reduces insulin resistance.
gathering. And
So
my
even
mission
if lipid profile is abnormal and some amount of hypothyroidism is there,
of diabetes.
first treat
So if you are
hypothyroidism
screened for
and then to
cardiovascular
initiate the
complications, you screen for microvascular complications, you
initiate the
also screen them for
status.
important complications like
Role of thyroid scan, actually nuclear scan is very important. This is all
diabetes is
autoimmune
an
disorder, so
important cause of death,
even if the picture will mimic like
which many of you
thyrotoxicosis,
are
if you do a
probably
scan the uptake will be very low, so it may be
telling
simple
how there is a
thyroiditis and we need not do anything. If time permits, I think we will discuss.
CID, which was
In case of
observed in a clinical
ketoacidosis
study with
in
more than
type 1 diabetes,
7,100 patients
thyroid
with
function
type 2
should be
diabetes.
considered
And
even with little
in
suspicion.
recently
Use of
last
statin should be considered
Indian
after
surveys
making patient
have
use thyroid.
confirmed
So
that
that is
one
another
important
important
cause
thing.
is
Another important
diabetes.
entity is the celiac disease.
96%
I
patients
think it has been
with
highlighted.
cirrhosis,
So let us see
glucose
what this is. It
intolerant,
is seen as 12 to
30%
25%. So this is a
diabetic
huge chunk
out of
that
them.
patient
Virtually the
has.
entire
It has a
spectrum of
significant impact on
patients with
growth,
type 2 diabetes,
bone
namely
density,
the
and glycemic control. So
steatohepatitis, the
all
cirrhosis
aspects
of
of
liver,
growth are
and
associated.
also the
And the
diabetes.
non-specific features
Liver
frequently
disease
result
occurring as a
in delay
consequence of
and
diabetes because
misdiagnosis.
of
So many times they
occlusion of
are
portion,
minimal symptomatic or
steatosis and
asymptomatic.
non-alcoholic
We
steatohepatitis,
have some work
fibrosis and
on
cirrhosis,
celiac
celiac
disease,
disease,
and
cholelithiasis,
we published our paper in Indian Pediatrics, and it it was dominantly done by my younger colleague, Dr. Anurag Vajpayee. The celiac disease in Indian children and adolescents with type 1 diabetes. And what we did, it was a retrospective analysis of 208 type 1 diabetes children, and we did TTG, tissue transglutaminase IgA levels within 6 months of diagnosis and annually for follow-up. 14 subjects, first time when we did 14 subjects were negative. And when they were followed, and we did it 6 monthly, mean duration of follow-up was 3.9 years. Then 14 new subjects we detected out of 208. So this is interesting thing. And we tried to calculate the prevalence. It was approximately 25%. It was huge. Coming to the Addison's disease, patient with type 1 diabetes and patients with Addison disease need lifelong replacement therapy with insulin and glucocorticoids, respectively. Patients with concurrent type 1 diabetes and Addison disease comprise a treatment challenge due to counterbalancing effects. And in patients, this is again a very important thing. In patient with diabetes, glycated hemoglobin is a very strong marker that shows a good control, but somehow we are lacking any type of such marker if we are dealing with Addison's disease. What are the issues? The incidence among patients with type 1 diabetes is 193 per million patient years. The risk of developing Addison disease is in patients with type 1 diabetes was around 10 times higher than general population. So the risk is very, very high. So we need to have a strong suspicion. Patients with concurrent type 1 diabetes and Addison disease has 4.3 times higher risk of death. So more chances, 10 times, death chances also 4 times than patients with type 1 diabetes alone. And mind you, type 1 diabetes or any type of diabetes are more chances of death compared to non-diabetics. Up to 60% of patients with autoimmune Addison disease have additional autoimmune condition, maybe thyroid, type 1 diabetes, or some gonadal dysfunctions. So insulin versus control. Because of these counterbalancing effects on glucose metabolism, patients, I think let us see, both type 1 and Addison disease is a complicated condition due to counterbalancing effects of insulin and cortisol. Because if you give glucocorticoid, blood sugar goes up. And if you give insulin, the blood sugar goes down. The management of both diagnosis during an infection or other stressful event is challenging in order to prevent adrenal crisis and manage hypoglycemia or ketosis. Because of these counterbalancing effects on glucose metabolism, patients with type 1 diabetes present with reduced insulin requirement when they develop severe glucocorticoid deficiency. So another important thing is whenever in practice also we do, whenever there is hypoglycemia or the insulin requirement is going down, we think on these lines. What are the indicators of patients of Addison's disease in patients with type 1 diabetes? There is a frequent hospitalization. So A1C is 1, anemia is 2, and this is the third. Multiple diabetic complications. And this is a new thing. If diabetic retinopathy is coming frequently, look for adrenal once. Prescription of thyroid, if there is any association of any type of thyroid disorders, one has to look. Patient is requiring glucagon. Dr. Sujata very nicely mentioned about glucagon. Patient requiring glucagon or recurrent hypoglycemia, one has to give a thought. Diagnosis: cortisol more than 500 anytime excludes, and less than 140 suggests cortisol deficiency. And we also do a stimulation test with synaptin. There is a actin prolongatum, long synaptin, short synaptin. So there are different tests. If you're interested, you can discuss. This is another interesting fact. Time of Addison diagnosis in patients with or without diabetes. So this is with type 1 and this is without. If you compare to normal population, they develop Addison disease much, much earlier. Polycystic ovarian disease used to be considered as topic of type 2 diabetes, hyperinsulinemia, gestational diabetes, but the picture is sometimes different. PCOS is the most common endocrine disorder in women. the prevalence is variable from 16 to 15%. Insulin resistance and compensatory endogenous hyperinsulinemia in close association with obesity. Type 1 diabetes needed supraphysiological doses of subcutaneous insulin. So this also causes hyperinsulinemia. So exogenous hyperinsulinemia could then contribute to androgen excess and predispose women leading to polycystic ovarian disease, as happens to insulin resistance. So again, this is the theory. And I looked at the paper, type 1 diabetes and a polycystic ovarian syndrome. This is a meta-analysis and it is interesting. And what it did, the pooled prevalence of polycystic ovarian disease with type 1 diabetes is 24%. It's huge. And studies especially reporting the prevalence according to different definitions of syndrome. Prevalence androgen excess related traits in women with type 1 diabetes, hyperandrogenemia was present in 25%. The prevalence of androgen excess traits, particularly hirsutism. So all these things are very frequently seen. Sometimes we anticipate that this is nothing but this is part of young type 2 diabetes. No, type 1 can also have difference in women with type 1 diabetes depending on the presence or absence of polycystic ovarian disease. Exogenous systemic hyperinsulinemia may be involved in the pathogenesis of type 1 diabetes and PCOS. Glycemic control and daily insulin doses were similar in patients with type 1 diabetes presenting with or without PCOS. Mean HbA1c levels since diagnosis of type 1 diabetes in patients, this is again important. Mean HbA1c level continuously over the years. Women under intensive insulin treatment had a significant higher prevalence of polycystic ovarian mass or polycystic ovarian disease syndrome compared with those under conventional 2-dose insulin. So more strict control, chances are that you'll have a more chances of polycystic ovarian. My thoughts are in young ladies, even with normal, sometimes they present with irregular cycles, or when they grow up, there is an evolution and all these things. So if we go for a nicer control, sometimes this also helps. So PCOS and related hyperandrogenemia traits appear to be among the most common comorbidities. PCOS may contribute to subfertility of these women, and a screening of PCOS and androgen excess should be included in current guidelines for management of type 1 diabetes. So this is another important, a very fast running of erectile dysfunction. The epidemiological studies suggest that both type 1 and type 2 diabetes are associated with increased risk of erectile dysfunction as compared to general population. And this is a paper. Earlier, we used to think only with type 2. Now the picture is different. This was a study on type 1 diabetes. Metro study was conducted to assess prevalence and correlation of erectile dysfunction in young men with type 1 diabetes and evaluate whether CSSI therapy is associated with better sexual function as compared to MDI. The prevalence was 37% in men and compared to 6% in control, so huge. And if you look, this is overall prevalence and MDI versus CSI. So maybe if as diabetes progresses, something happens. What happens, we need to understand. To conclude, the prevalence of erectile dysfunction was consistently higher in the whole population of diabetic men as compared with age-matched control subjects. Erectile dysfunction prevalence rates were not different in diabetic men treated either with MDI or CSII. So this is another important, very strong control. Sometimes, I mean, there is a known fact that with good control, the autonomic neuropathy reverses, but this is seen in both the categories. The overall prevalence, as I told you, was 37%, huge. The prevalence of rate of ED as well as this is IIEF international scoring system were similar in diabetic men treated with MDI or CSII. In an ancillary study of DCCT, the prevalence of ED was significantly lower in intensive versus conventional. So here we are observing a little different thing. Obesity, poor glycemic control, smoking, psychological disorders are well-known risk factors for ED in men suffering from diabetes. In the present study, men with ED showed lower weight body mass index as compared to men with or without erectile dysfunction, presumably as a result of reduced insulin doses. And last slide, uh, there is a word known as autoimmune polyendocrine syndrome, type 1 APS1. So this is a rare thing, less than 500 cases. But if you see type 1 diabetes, mucocutaneous candidiasis, Addison disease, hypoparathyroidism, and hepatitis, so any one of if you are seeing, look for remaining things, and it is autosomal recessive syndrome. So this is another important thing. These syndromes are seen, they are within our community, but we miss them. And finally, this is a beautiful picture dating from SPAD, Society for Prevention and Awareness of Diabetes from city. We have been doing lot of work as my friend Dr. Sujata, Archana, and Dr. Chingan, Dr. Ramchandani. We had a meeting in 2015 RSSDI Lucknow. So is Larry Hurst, BD Chief, Dr. Aish Bhatia from SGPGI, Sunil Gupta, Archana Sarda, Archana Didi, Dr. Deepak, Dr. Gangli, friend of mine, and Madhukar Katiyar from Lucknow. So with this, thank you so much for your kind attention. Thank you so much.
Thank you, sir. Thanks a lot. At this place, I'll really like to mention that his one principle that I am because we are has motivated so many, including me, and that makes our life worthwhile. Thank you, sir. Over to you, Dr. Ramchandran.
Thank you, Dr. Suchi. The Rishi Shukla and followed by Dr. Deepak Dalal. I think both are, the name suggests one is the truly Rishi, not Adunik Rishi, but it's a truly Rishi of the type 1 diabetic patient. And Dr. Deepak is the really a diya for the patient of the type 1 diabetes. I heard many of the times both the speakers that truly they are legendary in the type 1 diabetic patients. And next topic, I think this topic is 100% fit for Dr. Deepak Dalal. I think he's not a diabetologist, but he's a very good, excellent counselor. He's an excellent psychologist, I can say. And after meeting him, I think every type 1 diabetic family is feeling so much enthusiastic that बिल्कुल सही जगह आए हम लोग, and now we'll be हम ठीक हो जाएंगे and we'll be living better life. So it's just such a wonderful counselor. I heard about many of the time. He is running a juvenile diabetes foundation in the Mumbai. That is his trustee and honorary diabetes specialist of that foundation. He's running a trainer of the regional coordinator and trainer of the NDP program, that is National Diabetes Educator Program, for the past 7 years. And I think he's educating every year more than 40 or 50 educators with the help of this NDP. He has a special interest in lifestyle transformation education and coaching. He is not only educating the patient, but also have a very interest in yoga and plant-based therapy and diet in type diabetes also. He's a consulting diabetes specialist and endocrinologist in the Srimati BCJ Hospital and Bharati Arogya Nidhi Hospital. And I really have a proud privilege to introduce Dr. Deepak Dalal, and I request Dr. Dalal to kindly start his session. That might be the wonderful for us. We will learn a lot from Dr. Deepak Dalal, sir. Welcome, sir.
Good evening, everybody. Am I clearly audible?
Yes, sir.
Okay. So I begin my presentation with my Guru Vandana to my two teachers, Dr. Bhandarkar and Dr. Ajgaonkar, who has hammered the principle of education, empathy, and empowerment beyond a point. And whatever I am today, I am because of them. So with this Guru Vandana, I begin. Now let us define our role. Are we family physician, pediatrician, diabetes specialist, endocrinologist, whatever we are or whoever we are, No one can manage diabetes of a child alone in OPD by writing a prescription. And OPD, we must listen to them quietly, and listening to them quietly without interruption, half job is done. And now rest of the job starts with a team effort. So I will start with a very short 4 clinical cases in few sentences. So case number 1, grandchild has a diabetes, juvenile diabetes, and grandfather has a diabetes. Now one day, grandfather gets hypoglycemia in the night, and he goes to the fridge and takes out some sweet to control his hypoglycemia. Child says, दूसरे दिन उसने दादाजी का बैंड बजाया, मेरे दादाजी चोर हैं, रात को छुप छुप के मिठाई खाते हैं. And that old man goes in a depression. So here is the psychosocial part. Second is a case, Dr. Sarda has described this, that the father cannot afford 2 meals for a family. Now father, and there is a girl, teenager girl with a diabetes. Father says, if you live, we all will die. Better you die first. They can't afford. At that time, that girl is ready to put kerosene and a matchstick. And she thinks for a while that forget my family, but what my peer will feel about this when they know. And she had tears in the eye, and she immediately goes to the peers and tells that this is idea, and they say we will save you. And they saved not only her but the family. A third case is a mother asking that can my daughter have a ghee and a milk? She is overweight, she has PCO, but she is bent on ghee and milk. So after a deep counseling, she says that she was raised up in very much poverty, and at that time ghee and a milk is considered as a luxury. Now I can afford, so I want my child to have it. So where is the connection? And the last is a child is repeatedly going into diabetic ketoacidosis. And during deep counseling, he says, doctor, I hate that label diabetes and those restrictions. I want to break all the barriers and I want to die, but I want to live a normal life. So these 4 cases clinically has a no clinical relevance as far as the body aspect goes, but it has relevance nothing but the mind and the spirit. So my message, do not manage alone. Only 2 things you have to do. If you can manage, join the team for a proper, total, lifelong care. Either in a team or institute, you become a part of that, or you direct them. आपको पोस्टमैन का काम करना है या पुलिसमैन का काम करना है? पुलिसमैन होकर रास्ता दिखाओ, पोस्टमैन होकर डिलीवरी करो. तीसरा काम ही नहीं करना है. Now managing a diabetes, managing a child is a problem. In that case, managing a child with diabetes has to be extra problem. And what are the problem? This long slide I will say, but there is a child crossing the road, accident हो गया, पाँव कट गया, पूरी जिंदगी उसको जयपुर फुट लगाना है, आर्टिफिशियल लिम्ब लगाना है, और वो आर्टिफिशियल लिम्ब का साइज भी धीरे धीरे बढ़ने वाला है, फिक्स नहीं रहने वाला है. वैसा ही हादसा डायबिटीज में होता है. उसका इंसुलिन बनाने वाला पाँव कट जाता है, उसका शुगर चेक करने वाला पंख कट जाता है, वो पंखी दोनों पंख कट जाते हैं, तो वो दोनों पंखी को दोनों पंख जीवन भर के लिए चाहिए. चेकिंग एंड गिविंग अलोंग विद द डाइट एंड एक्सरसाइज, और वो भी खुशी से. यही हमारी चैलेंज है जो हमें दिखाना है. जैसे ये आदमी अपना जयपुर पांव लगाकर जिंदगी जीता है, वैसे ही डायबिटीज के हर बच्चे को 2 पंख लगा के उड़ान भरना है, checking and providing insulin. So in nutshell, it is a body problem first, but it has to be accepted with the psych, social and economy, because उसको जीवन भर ये खर्चा लगने वाला है. तो हम इसको 2 तरह से देख सकते हैं. We can see with two things. One as a challenge, chance or a blessings, or as a burden, problem, calamity. So I am going to show you the path of the first by negating second. Now, what are the challenges? Daily, for the whole life, high, low, ketosis, sick day management, and whatnot. Daily basis, even with the best control. And what you have to do? 4 things. Khushi, khana, khilna, napna, lena dena, prem se. If these 4 things are done, then there is a solution. So answer is a prem se. Prem se means mind. And he cannot do alone. He requires a family support. So social. And it requires a money economic. So psych, social and economic are intertwined. Now these are 2 sides of a coin. Otherwise it is a fake coin. One is a mind first and body. And it is a dynamic problem like 2 wheels of a cycle. And these are all connected by psycho, neuro, endocrine, immune axis. So initially what I said is a mindset. Now it is a science by itself. Now when the child develops a type 1 diabetes for the first time, it is like a child coming out of a nest and parents are struggling. And just remember this slide, it is everything. And they repeatedly, child and parent, everybody undergoes gadbad, guilt, anger, denial, bargain, anxiety, depression. And every time they feel impossible, difficult, inaccurate, inconvenient, costly. This is a mind. Now the body, it says it is possible, easy, accurate, convenient and economic, peace. So this is to be dealt mentally, this is to be dealt physically. So the child is in hospital, child comes back, now child requires my shirt. I don't put it proper, accurate sugar monitoring and insulin. So these are the people, everything is important and this management goes throughout the life. So you have to take, Dr. Sharda said, these 2 things are done, then there is a samruddhi, enrichment, and there is a wealth creation. So this is a whole dynamic process, and throughout the process, you require a coach, people who are traveling in the same direction. तो संग भी अच्छा चाहिए और संग भी अच्छा चाहिए और मार्गदर्शक भी अच्छा चाहिए. That's why it is a psychosocial and team. So again, I mean that Dr. Ajgaonkar, he realized this in 1982, that one diabetes specialist is not enough. You require something different way. So he took everything out of that and he created diabetic camp, staying together for 3 like a child. We are all students of Dr. Sir, playing with the children. Another thing, and child has a leg need not come, which we have seen in education, basic and higher, aspirant and fruitful life, provided I perform my duty. Needy every time. Sukha of these are the challenges. This is Tukam Mina Fernandez, the eldest. This is a small setting, and I have said initially has to be achieved. They are on minimum screen time, lifestyle principles, and like a dynamically moving car. And if the car has a problem, management of a sick day. And these are the typo and a sick day. And again, acute even special challenges. But how these challenges affect food, exercise, different type of do not come to normal. वो बोलते हैं डॉक्टर कितना डोज बढ़ाएंगे, क्या खाने में फर्क करेंगे. At that time they are made to understand that these are the, I think I have completed, I think before my time, but I am happy for that. So I am really grateful for giving me this opportunity and Dr. Shuchi for kind words of introduction. So I will request all the places to the Diabetes India RSSD through chemist, insulin.
Dr. Deepak Dalal, sir. I think there is no words for your excellent presentation about the experience of 40 years and whether it is API, whether it is any other form. He accepted that talk and he kept that talk in Hall A. I still remember, and everybody appreciated about the challenges in there. This is a good idea that we must keep. You all are legendary here, and I welcome Dr. Jargar sir. Also, he's a true legend of the.
Ramchandani, I would like to make a comment.
Yes.
Work, I think I wish one could do it. People get quite a bit scared rather than to me, because quality data of the previous decade. Starting from that era when, you remember those syringes used to be used, pens were not that available in the previous decade. And people in the Indian subcontinent, even if, and which was a stunner. More like type 2 diabetic is just write a prescription. एक साफ साफ prescription लिखो बस. But we have realized all our lives it doesn't make a huge difference. That saaf prescription only makes a difference once you treat diarrhea, pneumonia, tuberculosis. And Chingan, I know so personally very well for such a long time have made prescription. And then, after that 99 paper, I was stunned. I was already a senior endocrinologist, senior professor. I said, it's a shame. This is happening right in front of my eyes. So we changed a lot of our working pattern. And I published another paper, mortality paper of prospective paper for another 10 years, 2009. And Postgraduate Medical Journal asked Mohan to write an editorial on our work and on that paper. It was an amalgam of happiness and discomfort. Happiness in the sense that now I realized quite few diabetics are making it to the 5th decade. And, sort of it was gratifying that more staff was coming, we're starting a DM program, more OPDs, more customized care. And telling you very honestly, it's an honest confession. We were learning in the process. I'm so like, it was that attitude of writing a good prescription, being in that psychophantic state, being a one rare endocrinologist and few in the whole country. And that psychophancy got contained once I found out we are not doing that great a job. And it was because of this paper that we published in 99, but it had been in the making for 2 years. But what put me aghast, that even though quite few people were living beyond 50th birthday, the average life expectancy of a female type 2 diabetic was only 27 years. It means the social preference still was with the male. It's a job getting insulin, getting syringes, getting an insulin pen, spending that money, taking him to a lab, getting a sample done, spending a full day in a government-run hospital. People more often found that money for a boy rather than for girls. So, and after that, we started another tirade that, we specifically started targeting the parents of a female type 1 diabetic for special education. That we don't know how much that worked. By then, I came older and left the institution. So, but I'm sure we have now an ICMR registry in place, where one of my junior fellows, who is now a professor, is taking care of that. Maybe another decade has now gone by. We look at whether they made a difference or not. But it's amazing. I'm so like somebody has to. It needs an exclusively focused and customized care. Then magic can be done. I think you can be Dalal proud that you have people who are 70 and above with type 1 diabetes. This would be this would be a proud moment even in the United States.
Thank you, sir.
Kudos.
Thank you, sir.
Thank you, Jargar sir, for your kind words. And thanks for joining and thanks for giving the expert comments. Thank you, sir. So now we are moving the last session, last topic of the today's session on the adjuvant therapy in type 1 diabetes. And the speaker is very young and dynamic, Dr. Meenal Mohit. So I request Dr. Suchi to kindly introduce Dr. Meenal Mohit from Jaipur.
Now there is a problem with the voice.
Dr. Suchi, your sound is not clear. Kindly mute yourself. Yes. So I think your speakers are not working properly. So I take the you try once again. Either you remove that headphone. Dr. Suchi, try and remove that headphone and try to speak speaker without headphone. Okay, Dr. Meenal Mohit is a consultant and head of department in endocrinology in the Manipal Hospital, Jaipur, and she is working in type 1 for the past, I think, 8-10 years, and she is a director of Shashak Thyroid Endocrine Diabetes Center, and she has various publications in the national and international reputed journals, and she has presented national international endocrine meetings, various topics she cover. I think in every endo meeting or any diabetes meeting, everybody love to listen Dr. Meenal. She is a very good orator and very good speaker, and she is a gold medalist in University of Rajasthan in all the first and second and third year, and she got various awards. I still remember in all APA conferences, all awards, every time the first award goes to Dr. Meenal Mohit, whether it is oration, and she got one oration also, M. Chandra Reddy Award, and the Jaipur Chapter Award. There are various awards in the Raj Epicon, and probably she got all the awards in that residency career. So I still remember when we did Epicon in Kota, she got 2 awards in that. So I welcome Dr. Meenal, and she is going to speak the adjuvant therapy in type 1 diabetes.
So thank you so much. Very good evening. And first of all, I must pay my special thanks to Dr. Zargar for being here. It's a pleasure to see you, sir, after a long, long time. You've been very kind to me, and thank you for this honor. Thank you.
Always a pleasure.
Thank you, sir. Thanking Dr. G.D. Ramchandani, sir. And it's very true. In my first year PG, my first award, the journey began from Kota. Yes. And it was never looking back. Of course. Thank you so much. I remember Kota for that. And Diabetes India, very, very special thanks to Dr. Bansi and Diabetes India for giving me this opportunity and making me a part of this wonderful symposium. Yes, type 1 children are very close to all of our hearts. That's very true. They do take a special place. Probably they are already suffering, and we as doctors really understand that yes, they are really suffering, and we can help them. Yes, and we should help them. If you allow me to share my screen. Okay. So if I'm visible, my topic today would be adjunctive therapies in type 1 diabetes. Now, why do we need adjunctive therapies, and what do we mean by adjunctive therapies? Adjunctive therapies are needed. Yes, it is needed because in spite of all the best efforts as Dr. Dalal, Dr. Sharda, Dr. Jali, and the entire symposium, Dr. Rishi Shukla, Dr. GD, Dr. Zargar, everybody agreed that in spite of putting our best foot forward, we are still only able to achieve the glycemic control in some 20% of the population of type 1. We are still not facing the entire lifespan of the children with type 1. We still lose them somewhere around 50 or 60s, as Dr. Zargar also mentioned. So in spite of having the advancements in insulin, the insulin delivery devices, the continuous glucose pumps, and the continuous glucose monitoring, still what we face is that we are lagging somewhere. We know that these children are at high risk of micro and macrovascular complications. And when we start them on insulin, we already know that we have put them on the path of repeated, frequent, and the dreaded hypoglycemic episodes. And also they might end up with weight gain, and of course the glycemic variability, which none of us can actually escape. So with all these challenges with insulin therapy, despite all its benefits, we do need some adjunct therapy. So the purpose of adjunct therapy, let us be very clear right from the beginning, is not to replace insulin. We are not talking of replacing insulin any day. We are not even talking of decreasing the dose per se. We are just trying to help insulin give our patients a little more stable glucose profile with less hypoglycemias and less weight gain. So So that is the concept. And with that concept in mind, the very first molecule that we have been using, like not in my practice, of course, but there is this preparation available in the market. And we have heard of it that there is amylin analog, which is secreted right from the beta cells, right along with insulin from the very beginning. And that has been used as an adjunct therapy to insulin in children with type 1. The challenge is that it is still injectable. It works by delays gastric emptying and improves satiety. So it does help in lowering the HbA1c, and it also prevents weight gain. But just like insulin, it also needs 3 injections per day. It might lead to hypoglycemias. And the worst part is that it has significant GI side effects. So one meta-analysis with pramlintide states that yes, though there was HbA1c reduction in the group which was given the benefit of pramlintide along with insulin, but that group also faced a significant nausea, vomiting, anorexia, and hypoglycemia. Talking of another important molecule which we have all tried, yes, we all have tried in maybe our over-hungry type 1s or a little overweight type 1s, is metformin. And the metformin was analyzed in one of the important, that is the removal trial, and it was found that the molecule did not help in controlling or preventing atherosclerosis. So the carotid intima media thickness did not change much as compared to placebo. But in spite of this, we could find that there was some weight loss and some improvement in dyslipidemia, though HbA1c did not reduce much, and the atherosclerotic plaque also did not improve much. Then we thought of trying the GLP-1 RAs. Liraglutide was one molecule which was tried in type 1 children, aiming weight reduction. HbA1c reduction did not happen much, though it was added to insulin in various regimes in 0.6, 1.2, and 1.8. The dose-dependent effect, it was also associated with some increase in hypo and also landed in few cases of diabetic ketoacidosis. As a result, the trial was called off and the molecule has not even filed for FDA approval for type 1 children. Though we have very soon SEMA coming up, probably we can try SEMA in children with type 1, not sure. I cannot speak that. Now I think it's too premature. Now, this was the adjunct one, the Lira insulin trial, where it was found that as compared to placebo, as the strength of Lira was increased from 0.6 to 1.2 to 1.8, there was some HbA1c reduction, though the p-value was not significant. There was some control in weight gain, and it was coupled with hypoglycemia and diabetic ketoacidosis. Now the newer concept of SGLT, that is sodium glucose linked transporters. The sodium glucose linked transporter 1 helps in the glucose absorption from the GI, and the sodium glucose linked transporter 2 helps in the renal reabsorption of glucose, almost 90% in the proximal convoluted tubule. So if we block the molecule here, the enzyme here, and the transporter here, can we help the patients? So if we begin with blocking SGLT2, then we can prevent the renal reabsorption and promote glucose urea. That would help in bringing the blood glucose down. And at the same time, if we also block SGLT1 and prevent glucose absorption right away, right at the time of entry of the food, we can still bring the blood glucose down. So with this concept in mind, we thought, let us frame a molecule which works at both SGLT1 as well as SGLT2 and block the renal reabsorption completely, and at the same time also block the GI absorption of glucose. And the dual SGLT1 and 2 inhibitor, that is sotagliflozin, was tried in type 1. So sotagliflozin is a novel dual SGLT1 and 2 inhibitor. It inhibits insulin independent mechanism. By way of insulin independent mechanism, it blocks the reabsorption of glucose at the kidney level and the glucose absorption at GI level. It also promotes the release of GLP-1 and then adds to weight loss by increasing satiety. So the various trials that we can attribute to the newer molecules, beginning from the sotagliflozin, that is in tandem program, in tandem 1, in tandem 2, and we also have in tandem 3. Also, we have a number of DEPICT trials, the DEPICT 1 and DEPICT 2, and we have the EASE program for empagliflozin. So just quickly going through some of the trials and the results, you find that in both tandem 1 and tandem 2, it was found that the HbA1c reduction was reported with 200 milligrams as well as 400 milligrams of sotagliflozin. Also, some systolic blood pressure reduction was noted, and the body weight reduction was also noted. In tandem 2, the blood pressure was not taken into account, but HbA1c reduction and body weight reduction was documented. All these trials with sotagliflozin were insulin optimized. So now another tandem 3 was planned where the insulin optimization was not taken into consideration, and any patient on any regime of insulin was added sotagliflozin in 200 milligrams and 400 milligrams. And the primary endpoint was not to see the reduction from baseline, but the primary endpoint was to achieve the glycemic target, that is 7%, at the end of some 24 weeks. So the primary endpoint was definitely achieved as compared to placebo in some 13% patients more. And the HbA1c reduction from the baseline was also significantly more with sotagliflozin as compared to placebo. And you will find that there was also significant reduction in the total insulin dose. You will find that the insulin dose is reduced by almost about 3 units in the total daily dose, the bolus dose, and the basal dose. So the results were quite similar in tandem 1, 2, and 3. The only difference being that in tandem 3, the insulin was not optimized before inclusion in the study, and the CGM analysis was not conducted. But at the same time, we have to take into consideration that we came across a term called euglycemic diabetic ketoacidosis. So there were children who faced more than one episode of diabetic ketoacidosis in the group given SGLT. Though the number of hypos or the severe hypos were almost comparable in the placebo group versus the SOTA group, but the number of diabetic ketoacidosis was significant enough to draw attention. Then came the DEPICT trial. DEPICT trial were done with the dapagliflozin. Dapagliflozin estimation and their efficacy in type 1 children to see the control of blood glucose. The study design was almost similar, that after an initial lead-in period, the patients were stratified into 3 groups on DEPA 5, DEPA 10, and placebo. The DEPICT 1 and DEPICT 2 both showed significant HbA1c reduction over 24 weeks period. As you can see, as compared to the placebo, the DEPA 5 and DEPA 10 both have shown HbA1c reduction over a 24-week period. In DEPICT 2 also, we could find the HbA1c reduction as compared to placebo. The time in range, the time spent by the patients definitely increased in both DEPICT 1 and DEPICT 2. Then the empagliflozin was compared, the EASE program. The EASE program, it was EASE 1. EASE 1 was just a pilot study with some 75 patients that led us to EASE 2 and EASE 3 programs, which was larger studies spanning some 26 weeks. And it was found that almost 1,750 patients were included with 10, 25, and EASE 3 also included a smaller dose, that is 2.5 milligrams of empagliflozin as compared to placebo. And the results were that yes, HbA1c did reduce in EASE 1, EASE 2, and EASE 3 with 5 milligrams and 10 milligrams, also with 2.5 milligrams, but the number of DKA increased, the number of hypos increased, though the hypos were not much with 2.5, but there were significant hypos documented with 10, 25, and there were also DKA documented. So that led us to some doubts. And of course, we also know by our practice of SGLT2 inhibitors in type 2 diabetes that we are dealing with some mycotic infections, some UTI, some genital infections, and other adverse events with SGLT2. So are we going to face the same in type 1? That was the important question. So looking to those parts of the SGLT2 therapy as adjunct therapy to our type 1 children, it was found, the data from CREDENCE trial and the EMPA-REG trial, that these molecules are not going to damage the renal hemodynamics. Rather, they are going to be of help. They are renoprotective, nephroprotective molecules, as stated by the CREDENCE trial with canagliflozin, EMPOWEREC trial with empagliflozin. So we can probably extend the benefit of these molecules to our children, and we can help them in renoprotection. Though we have to take care of genital infections, especially the candidal infections, the mycotic infections, and we have to be alert towards the likelihood of ketoacidosis or euglycemic ketoacidosis. So when we talk of EASE trial and the TANDEM trial, yes, we also have reported genital infections. We had some DKA reported with 10 and 25 milligrams of empagliflozin. Severe hypo was rare, but yes, there was a documented 1 or 2 episodes. Similarly, in the TANDEM trial also, the hypoglycemia was comparable with the placebo, but then we do have documented hypoglycemic episodes in the TANDEM program also. Just a few more words about diabetic ketoacidosis with SGLT2 or SGLT as a whole group of molecules, because that has been the most talked about complication. Frankly speaking, diabetic ketoacidosis is a risk associated always with type 1 diabetes. And the risk is more with skipping of insulin therapy rather than any other thing. So skipping of insulin therapy or worsening of any underlying pathology like infections or hyperglycemia and dose mismatch are more culprits responsible for diabetic ketoacidosis. So elevated blood glucose is the warning of imminent diabetic ketoacidosis. Ketones or ketogenesis does occur, though we have few studies to say that SGLT per se do not add to ketogenesis. So the risk of DKA is increased, and this time because there is glucoseuria, these patients actually have euglycemic diabetic ketoacidosis. So more importantly, you have to check the pump failures, missing insulin doses, and you have to check for underlying infections which might have precipitated the diabetic ketoacidosis. In one of the studies, though it was a very small study, it was shown that per se SGLT2 do not accelerate the rate of ketogenesis if the basal insulin is interrupted. So how do we actually manage DKA in case the patient is on SGLT2 or SGLT and along with insulin? We have to make sure that SGLT is withdrawn and the patient who's put on SGLT is made clear that they are supposed to monitor the ketones timely. Just as they are monitoring blood glucose, they are also supposed to monitor blood ketones or the serum ketones. We should be using the lowest dose possible, which is clinically efficacious. We must reduce some insulin, but we have to make clear that if the glycemic control is good, that does not mean you have to escape insulin or skip insulin. You can reduce the insulin, but some insulin has to go on to keep and maintain the metabolism to carbohydrate metabolism. We have to adjust the blood glucose for both fasting and postprandial. And if we know that the patient is a non-compliant patient or a non-adherent patient or a patient who has already witnessed few episodes of diabetic ketoacidosis, that such population should not be added to SGLT inhibitors. So we have to avoid SGLT inhibitors, especially a patient who is also aiming weight loss by low carb or who's aiming glycemic control with low carb. So a patient on low carb diets should not be given SGLT inhibitors. They should always be promoted or motivated to monitor the serum ketones as well. Urine glucose monitoring is not the usual method of recommendation because glucoseuria is an integral part of the therapy that is SGLT2 or SGLT1. And diabetic ketoacidosis can occur even when the blood glucose is below 9 millimoles per liter. So it is not always hyperglycemic ketoacidosis. It can be euglycemic ketoacidosis also. So these are few things that we have to keep in mind when we are prescribing SGLT to type 1 patients. So we must promote our patients at the very moment they report nausea. We must ask our patients to check their blood ketones, take some carbohydrates and stay hydrated. You have to reassess the insulin carb ratio, that is IC ratio should be reassessed once the patient is stabilized on SGLT dosing, and we must be using some insulin and the lowest possible dose of SGLT inhibitors. Then there is a stitch protocol that if you are suspecting euglycemic diabetic ketoacidosis, immediately stop SGLT inhibitors, inject the bolus insulin, consume some 30 grams of carbohydrates, and keep your patient hydrated. Some other considerations, it was found that yes, the DKA risk in EASE was more in women because probably women are more into low carb diets. And this was one reason that DKA was reported more in women. But now with equal awareness among men, they are also becoming more prone to these low carb diet fads and these low carb diet fad complications, that is euglycemic ketoacidosis. Another thing is any patient population planning fasting. First of all, as we all know that fasting should not be recommended in population with type 1 diabetes, but still if the patient is insisting on fasting because of any other reasons, religious reasons, or before any surgical procedures, SGLT inhibitors should be withdrawn some 72 hours prior. We must also educate our staff or the paramedical staff because there's a new thing which is happening, that is euglycemic ketoacidosis. So our staff is more familiar with the terms like hypoglycemic acute emergencies in diabetes and type 1, but they're not aware with the terms like euglycemic ketoacidosis. So they should be made aware, and we should always prompt things like provide immediate insulin, calories, and food. Another important concept of adjunct therapies in type 1, which we really miss, because once we think of type 2, we think of severe risk. But in type 1, we rarely think of severe risk. But we all know that these children, after 5 years, are at equal risk of micro and macrovascular complications. And these children very soon will end up with CVDs. So all this type 1 population need to be very careful about their cardiovascular status also. And this glycemic variability hits directly the plaque, the endothelial stability, and they are at higher risk of cardiovascular mortality and morbidity after 5 years. And this has been shown both in the TANDEM and EASE trials. So we have to target lower glycemic variability, and we also have to pay attention to the cardiovascular health. And that is again through these adjunct molecules, especially after the EMPA-REC trials and the LEADER trials, which have shown these molecules have a cardioprotective effect also. So probably the same benefit can be extended to our type 1 children also. So this was proven in the Swedish registry that almost 27,000 population is there in Swedish registry, and they have shown that in type 1 children, almost 10 years of life are lost in women and in children, in men equally. So cardiovascular and renal, both benefits can be extended to our type 1 children with SGLT inhibitors. And the similar studies need to be done. We have not yet done these studies. Both EMPA-REC, LEADER, CREDENCE, all were with type 2. So we need to do all these studies still with our type 1 children before actually proving what we are talking today. Just a word about what patients have their experience with these adjunct therapies. Probably it is a skip from insulin, or probably it is more of the glycemic stability that patients have all given a very positive feedback with all these molecules in terms of weight loss, in terms of reduced glycemic variability. Even in spite of the challenges of urogenital infections, patients still were more eager to continue the treatment with oral molecules and the adjunct molecules, and they were really willing to complete the clinical trials. SGLT2 inhibitors still are not approved. So this is very important. In spite of all these talks, these molecules are still not approved. They're still off-label in use, though the off-label uses are increasing because of their credibility. But we have to be aware of the slightest of the alert signs we have to remember, and we have to take off these molecules. So just to summarize, DPP-4 inhibitors as adjuncts, no reduction in HbA1c, no increased chances of hypos. GLP-1 still not filed for FDA approval, still under investigations. SGLT1 and 2, that is the dual SGLT inhibitors, sotagliflozin, or the SGLT2, DEPA or EMPA, still in the clinical development stages. We are still not in usage with these molecules. So that would be the last slide. Just to summarize, in spite of the intensive insulin therapy, all the advances in analogs and the continuous subcutaneous insulin infusions and the continuous glucose monitorings, we are still far, far away from achieving our targets in our children, the sweet little children who are actually facing the challenges of sweetness, that is high blood glucose in their blood, high blood glucose, that is type 1 diabetes. We are still facing and fighting how to not face hypoglycemias, how to prevent weight gain, and how to give them a smoother blood glucose control and improve their quality, that is quality of life years. We still are finding newer therapies, adjunct therapies that aim to improve the quality of life, control, give them smoother glycemic control, no weight gain, no hypos. But we are still not thinking of doing away with insulin. We are still trying to match something to insulin or some companion to insulin to control type 1 diabetes and give us a better control, the right balance that we need to find between metabolic improvement without compromising and without accepting any complications in terms of hypoglycemias, weight gains, or atherosclerosis, or even diabetic ketoacidosis, or any other complication that we do not want to add to the lives of our children. With that, I close this. Thank you so much.
Thank you, Dr. Meenal, for a nice and wonderful lecture on the adjuvant therapy, which is definitely a different topic, usually not covered in type 1 diabetes, but this time you have covered in a wonderful way, and you covered all the adjuvant part on the type 1 diabetes. So now the session is open for question answer. So I invite Dr. Manisha Gupta.
First of all, I would like to thank all chairpersons and all the wonderful speakers for giving their enlightening us with their clinical insights. And I'm truly blessed to have you stalwarts for the wonderful discussion. So my first question would be like, these are my clinical queries, and I would like to discuss with you all. So my first question is for Dr. Archana ma'am. Ma'am, how to make them understand, like we deal with all small children, and so how to make them understand regarding this carb counting, correction factor, and dose titration. It really becomes very tough. So ma'am, how to deal with it, and how can we make it more simplified for them? Ma'am, kindly give your expert opinion.
So that is probably the most difficult part. As I said, I took a long time to learn it myself. And the only way I feel is to do it in stages. As I said, the first thing is once they identify the macros, and then you see who understands. Everyone cannot, we have to accept, can do actual detailed, perfect carb counting, calculate the ICR, ISF, and do dosing. So it's very important who is it relevant to. So people who are on basal bolus, who are using CGMS, are the ones who, or of course those who are on pump, they must know, and hence it's a stepwise process. So we start with learning the healthy plate model, then identifying the carbs, then simplifying it into bits and pieces, and not trying to teach in one day. So my tip would be take a good 3 months to 6 months to reach that point, structure it, reinforce it, cross check it, and it happens. It happens like magic, but it is slow.
I've kind on everything. Yes, ma'am.
To add on to Archana, what we have done in our center is that we have made calendars. Okay, we have got the photograph of all the preparations like roti, how that roti looks, size of the roti, and what is the carb count in it, what is the protein content in it, and all. So these calendars have been distributed free of cost to all the children, and we have advised them to put it in their kitchen so that they know how much it contains, and we have made it in local language also. But said and done, as Archana said, it is still difficult to teach them, and sometimes we may have to do glucose related insulin dosages also in these cases, like what we call it as a meal related insulin doses. So sometimes we do that also.
Okay, thank you, ma'am. Thank you, ma'am.
I think Dr. Suchi is here. She is a Mahaguru in type 1 diabetes. She can tell us how she is doing in day-to-day practice, just simplified way, how you are managing the carb counting in your day-to-day practice, ma'am.
Look, Dr. Archana and Dr. Jali summed it up. It's a very slow process. And the era I am coming, there was no carbohydrate counting. It was simple things, very simple things. These are carbs, these are proteins, these are fats. So once my mother understood it, and it was told that more proteins, not more fats and carbs. So it was more protein based diet, and actually when I was diagnosed, then human insulins were there. So you need to have a protein snack, and that was good thing rather than a carb snack. So that was a principle, and I think that made life very easy for me. I'm still a very small eater. I can't eat big, heavy meals. So carb counting is very like I will not do carb counting every day. It's tough. It's counting is a very thing. But I have an idea that this portion is equal to this portion. That food exchange list, like one apple is equal to half banana is equal to one mosmi is equal to 3 slices. That I have. That is in my mind for almost every food. Like if you fruit exchange, if you want starch exchange. And I personally am a fruit lover. So even I will exchange carbs, like they would say that do not exchange starches with the fruits, but I will exchange starches with fruits also. And that works. So basically eating the same amount, but exchanging carbs is that. But yes, as now when we teach children, definitely these calendars, carb counting helps. And few people are very good in it and they do it. But for me, visual carb counting, and as Dr. Archana said, it's a slow process. Don't do it in one go, otherwise it will destroy the whole.
Okay.
Okay, thank you.
Okay, ma'am. This question is for Dr. Rishi. It was just coming in my mind during COVID times. We were giving glucocorticoids to our patients, and it was very tough to manage their blood sugar. In case of adrenal insufficiency, if when we are giving patients glucocorticoids, so how to manage their blood sugars? They would be needing a very high dose of insulin. So, sir, what's your take in this regard?
I think we always, the answer is same. And the best part with type 1 is that they are type 1. For type 2, what we used to do, we used to add insulin and then patients used to resist. And finally, we end up adding one basal insulin. And if basal doesn't work, then we add prandial insulin. But here, things are very simple. We always teach our patients to monitor blood sugar, how to monitor basal, the long-acting insulin, and how to monitor the short-acting. So this is one thing. The principle will remain same. They should be warned that they should do the changes on every day. So this is one thing. Second thing they can do is to increase the doses of, increase the frequency. If you look at the adult population, majority of the adults are taking only 3 pricks. Children, I think Dr. Manisha would agree, we need 4 pricks, sometimes maybe more. So we can increase the number of pricks in adults also, adults type 1. And the basic principles are same. Algorithm to control diabetes is same. And last thing, we should warn them that the steroid is going to increase the prandial blood sugar more compared to fasting. So this thing also they need to keep in their mind. And before I speak a final line. One thing I add, you asked about a carb counting. I think all of us are sitting here, and what we can do is, whenever we have finished our teaching, we can have while doing our regular education program, and allow patient to allow patient to have meal of their choice. Sometimes maybe high glycemic index, high calorie meal also. So, and manage that meal with glycemic with carb counting. Take out insulin sensitivity factor and take the extra doses of insulin, and then you can manage. I think this would be a good exercise for all of us. Before coming, they can get a meal of choice, see pre and post, and see what happens. So this is.
Thank you, sir.
Yes.
I think Manisha, if I'm not wrong, you were asking about COVID and glucocorticoids, is it?
No, ma'am. Yes, sir. Please continue.
Yes, madam. I replied actually COVID and glucocorticoid. Something was coming into my brain. My hairs are less. To continue with carb counting.
No, I think so. wanted to add on what you are saying, not with the carb counting, of
No,
course.
no, it has nothing. Actually, I have finished the glucocorticoid part. Then in last, I added in continuation of the previous question.
Yeah, as a pediatrician, I just wanted to highlight that COVID and glucocorticoid steroid therapies is there. We are just using it in this one, MIS-C, that is multi-system inflammatory syndromes in children, MIS-C. So MIS-C is hardly 1% in children who are suffering. And we have managed about 2 cases with MIS-C with diabetes. But the thing is that because of the hyperglycemia, it is again and pro-inflammatory. We have to control like in any other inflammations and infections, the COVID during the COVID. So we may have to increase the insulin according to the, or you put a CGM because they're admitted here. All MIS-C children are admitted, so you can put a CGM.
Because algorithm, madam, is same. I mean, if you more is the, then you have to insulin, you have to increase more practice.
Yes,
the algorithm will move up and up and up.
Dr. Rishi also has a
ascending order.
experience with
It's
type 1
ascending
diabetes.
order. You can do that.
Yes.
Dr.
Sir,
Dalal, no.
Yes.
Sir, I have a clinical query here, so I can discuss with you all. Sir, recently me and Dr. Rishi, we were discussing one case and seems to be interesting. Sir, if you allow me, I want to discuss that.
No, thank you.
Sir, 8-year-old male child, he came with a family history of diabetes with no signs of insulin resistance, and C-peptide was normal and with positive GAR antibodies. We try to rule out like all the other possibility of subclassification of diabetes, including FCPD and rest. And to deal with, initially we tried HbA1c was 8, so we told the child, okay, go for lifestyle modification since he had a family history. So initially for 3 months he responded well with lifestyle, but subsequently his glycemic control was like going like haywire. It was like fasting was going above 200 and post-prandial 300. So how to, like, first classification would be whether to deal with child with positive GAR antibodies, to deal classify this child as type 1, or with good, or considering this as like family history. So how to deal with this, and how about metformin? Can we start metformin in like 8-year-old as a therapy, adjunctive therapy? Sorry, your take.
You want me to respond?
Yes, sir. Please go ahead. Like
you see, first thing you must remember, you see what we see as a clinical disease, type 1 diabetes. That is an autoimmune disease at the dead end, where it has sufficiently destroyed beta cells. But this does not mean that this is the only autoimmune disease of islet cells, because it is something like, you know, somebody being an ANA positive, but everything else being normal. But someone else being ANA positive and developing a very fast renal failure. And both we describe as systemic lupus erythematosus. And the third person developing psychosis, encephalitis. So in a similar fashion, autoimmune disease in type 1 diabetes is quite varied. But what brings a person to you and me is his dysglycemia and the symptoms associated with it. And there will be a huge chunk of people who will have an suggestion of a pancreatic autoimmune disease, which could be smoldering. And this is the slower form of it. In adults, we always recognize as latent autoimmune disease of the adult. There's another one, latent autoimmune disease of the young, which is slowly walking in. So it can modify their own clinical behavior over a period of time. You'd be amazed to know, we have described fibrocalculous pancreatopathy in a 7-year-old kid, and published in Journal of Pediatric Health and Endocrinology, where we postulated that these stones evolve so slowly and he has such massive calcular disease. Did they start developing from the intrauterine life? Because from 4th year onwards, he was a diabetic and was on insulin. So a lot still needs to be understood on that. But the moment your GAD antibody is positive, your scanner should be there. These need to be followed. Like, you know, if an anti-DNA antibody is positive, when you see somebody is ANA positive, you follow them after every 6 months for any proteinuria, for any progression of titer of the antibody against double-stranded DNA. In a similar fashion, you follow them up. Beautiful question. You know, you just talked about maybe if Minal is around still, she could respond to it. Now, you know, as people, youngsters with type 1 diabetes live longer now. And many do reach adult life. As they cross the teenage life, you know, 13, 14, 15, and then in the early adult life, and they acquire these current times, you know, urban habits, obesity is going to be very common in them. And metformin has been seen to be quite useful in them. So now, not at the earlier stage, not when somebody see at 7 years or 8 years, as you described, not someone whose BMI is 17 or 18. Once you cross that BMI of minimum 25, you start looking at it. One, what that multiple dose of insulin do, and second, what do the current time habits of lifestyle habits of the youngsters do to our body? You'll be amazed to know we are a part of a global study that published some data on in 2007 in Lancet. Obesity has increased tenfold in youngsters and young adults in the last half a century. So this now about this SGLT2 inhibitors, one big issue is that I think they will find a use in type 1 diabetes, those who find it have an unstable diabetes who are on MSI, and but whose A1Cs are not all that stable. If they are on the thicky side, an SGLT2 inhibitor probably would find its use. But the only problem is, many times when you start getting blood sugars a bit normal, you have a tendency to curtail insulin, or once in a while just stop insulin because you see it's 180. You are used to seeing them 180, and that is where euglycemic ketoacidosis will walk in and will give a problem. But if you have a conscious person who has been through Dr. Dalal, and I've seen a huge chunk of type 1 diabetics with Dr. Rishi also. In 2007, he had organized a meeting of type 1 diabetics in Kanpur.
Yes, sir.
It was amazing how well those guys are done in life. I'm saying, it always, you know, would give me a sense of inadequacy that I couldn't do so. So I'm sure that that also would find its own route. So your patient is an highlights and which needs to be followed. And expected diabetes would not be something exceptional. And these were the guys, you know, people tried to give immunization. So that's another thing we'll discuss someday.
Certainly, sir, we'll do that. Thank you.
Manisha, next symposium lectures are
yes, sir. Yes, sir.
There. So I think we should conclude this session now.
Yes, sir. Yes, sir. Certainly, sir. Thank you so much. Thank you. I thank all the chairpersons and speakers for this wonderful session. And probably we are getting late for the next session. I thank you all for joining us here. Thank you so much.
Thank
you for all
thank you.
the
Thank
gurus.
you.
They are all the gurus for giving their knowledge. They're sharing their knowledge to us, and this is a wonderful session for type 1. Thanks once again to all the teachers. I think they are really not doctors; they are teachers. They are teaching every time to youngsters and our patients also. Thanks to all. Because we are getting late, तो मैं नाम नहीं ले पाऊंगा. So thanks once again thank you very much, Dr. Manisha and Dr. Suchi.
Thank you so much.
Thank you, sir.
Thank you so much, everyone.
Thank you.
And thank you, Diabetes India. And thanks, everyone.
Thank you so much, everyone. On the behalf of this organizing team of the Diabetes India Conference, let me thank you, our esteemed chairperson, Dr. Ramachandani sir and Dr. Suchi ma'am, for wonderfully conducting this session. I would also like to thank all the wonderful speakers who have given their insights and knowledge and over type 1 diabetes. So we are running a little bit late of time. So we are moving towards the next diabetic food symposium. So it's a wonderful symposium coming next 2 hours, and I'm sure that you will be happy to have a wonderful knowledge about diabetic food, how we can manage it and improve the outcomes of our patient. And for this symposium, I would like to invite our reporter, Dr. S.S. Daria sir. Sir is consultant physician and diabetologist from Jaipur. He doesn't need any introduction, and I would invite him to introduce our chairperson and to start the proceedings of this session. Over to you, Dr. Daria, sir.
Thank you so much, Dr. Jimit, for a kind introduction. At the outset, I would like to thank Diabetes India Organizing Committee, especially Dr. Bansi Sabu sir, for giving me this opportunity to interact with you all. Now we are already 5 minutes late, so we'll move on the diabetic foot symposium. The earlier type 1 symposium was very good. There was a good lectures. Now, why we are worrying about the diabetic foot? As we all know that diabetic foot is basically increasing a dreaded complication of diabetes. As today we are losing 1 foot across the globe every minute. So it's a big problem in diabetic patients, and it's a very painful also. So without wasting much time, I would like to invite our respected chairpersons, Dr. Vibhakar Vachrajani sir. He's a diabetic foot surgeon from the Rajkot, Gujarat. And yes, Dr. Rajni Saxena sir, my mentor, my elder brother, he's from Ajmer, and he's working a wonderful job regarding the diabetic foot in Rajasthan. So over to you, chairpersons. Thank you so much. Yes, Rajneesh sir, Vibhakar sir, kindly introduce the our speaker.
Yeah, good evening, everybody. I thank Bansi Sabu and the whole team of Diabetes India. Dr. Jhoni is a very good friend of mine. He's a consultant diabetologist and head in VPS Lakeshore Hospital. He was trained in diabetes at WHO Center, Zagreb, Europe. He's the first doctor in Kerala, state of Kerala, who is trained and specializing work in podiatry. He was also trained at King's College London under Professor Mike Edmonds, who is world famous in diabetic foot care. He's also the recipient of Guinness World Record in podiatry, awarded Fellow of Academy of General Education, Manipal, and his research interest is in the field of diabetes, diabetic foot, and islet cell transplantation. He gives lectures in many national and international conferences. And let me tell you, in all diabetic foot society conferences, we are there together enjoying the fellowship and scientific delegations. So I present Dr. Jhoni Kanampili to you. Jhoni, please.
Thank you, Dr. Vajrani. I just would like to share my slide. First of all, let me a special thanks to Dr. Bansi and team for this wonderful virtual conference. And in this COVID era, it is a great opportunity to meet without even traveling. If they're sitting at your home, you're able to attend such a big conference. And it's a great opportunity. And today I don't want to extend because we're already going short of time. I'm just going to give the first part of the diabetic symposium talk. Following speakers will be more dealing into the depths of it, but I'll just give a short run what causes diabetic foot ulcers and its long-term complications, outcomes. Well, I don't know whether the slide is clear, but let me just go through it. We know the burden is high, and we know 50% of non-traumatic amputations are due to diabetes, and 85% of amputations due to untreated or inadequately treated diabetic foot ulcers, and 60% of the admissions are due to diabetic foot problems. Now, if you look at this, this is a very thing that we can understand that about 25% of these diabetic patients can develop diabetic foot ulcers in their lifetime. Among all the people with diabetes, up to 4% annually develop diabetic foot ulcers and other problems into amputations. So you can see that patients who develop infected foot ulcers have 55% increased risk of hospitalization. And the presence of DFU for 30 days or longer carries fourfold risk of infection. And peripheral arterial vascular disease and neuropathy are major contributing factors for diabetic foot ulcers. So it's very important to note this. A presence of DFU for 30 days or longer carries fourfold increased risk of infection, and also infected foot ulcer have about 55 times increased risk of hospitalization. I've already said that many of the time it is inadequate treatment when or late referrals or even late treatment which leads to a small ulcer going in for an amputation. Now this all, I'm sure that most of us present in this forum are aware of this, but I just would like to highlight the causal pathway or the multiple causation pathology, the neuropathy, which is 85% of the cases of the ulcers. And then you also have vascular problems, and then a trauma, which can all aggravate the problem. And the bottom, you can see diabetes with neuropathy, with ulcer, then finally with infections and amputations. So a diabetic foot can be either a neuropathic or a vascular ulcer, or even a combination. Then when it is infected, then it becomes a major problem. So the risk factors, we have many. We have the the neuropathy, vascular problems, the foot pressures, the hyperglycemia, trauma, the deformities, limited joint mobilities, previous ulcers and amputation, poor vision, old age, duration of diabetes, all can contribute to the risk factors for diabetic foot ulcers. Again, I have told you the ischemia, neuropathy, and infection is the three main etiologies. And this is the pathophysiology. Now, I don't know whether you can read it, but then it's also the same thing, the neuropathy, peripheral vascular disease, which leads to the ulcers, and barefoot walking, improper footwears, lack of education to our patients, lack of education to healthcare providers, and lack of foot protection service, which all can lead to ulcers, also infections, and finally lead to amputations. Also, all these also can lead to neuropathy, which can lead to also Charcot arthropathy, again, which can lead to ulcers and which can lead to amputations. So again, as I said, the neuropathy, these are the healthy nerves, and once the loss of nerve function is the main problem in our Indian patients. The nerve and the blood vessels get damaged in the neuropathic foot, and then the supply to the nerves are occluded, and then the nerves also get into problems. Again, the musculoskeletal issues are a major issue. Once the neuropathy comes in, then slowly muscular deformities also develop, and then that also leads to ulcerations at different areas of the foot. So again, excessive pressure on the metatarsal heads resulted in marked callus buildup, and that further accelerated by dry skin, and the patient is at high risk for these kind of ulcers at different areas. So again, as I said, the Charcot arthropathy at the chronic stage, deformities are developed, then ulcers are developed. Now, different other problems are like the shoe bites, the injuries also can lead to foot ulcer formations like home surgeries or insect or rat bite, thermal injuries, foreign body injuries, vigorous massage, chemical injuries, etc. also can trigger already problematic foot with neuropathy or ischemia, which can also trigger to ulcerations as well. Now, high foot pressures is another problem with neuropathic patients, and which can also change the biomechanics of the foot, which can lead to high foot pressure areas. And in that areas, as I said, callus formations can come, and these are the changes which happens, and then callus have a higher 11-fold increased risk of developing an ulcer. Again, this is just to show you different areas where you can get calluses, metatarsal heads, and other things, and which can finally trigger infections, and which can go up the tendon sheath and get infected. Now, this is just to show you that you may see a callus and you may think there is no problem, but underneath there may be ulcer developing. Only when you do a callus removal, then if there is a hemorrhage, that is a sign that that area is going to ulcerate very fast. So it's better always to remove the callus, reduce the pressure so that the ulcer formation is reduced, or the ulcer risk is reduced. Now, I just want to touch upon foot infections, which is another problem which I said. There are three stages of infection: the non-limb threatening, and life-threatening infection. Many a times, it is with the starting of a non-limb threatening infection, that is less than 2 centimeters of cellulitis from the portal of entry, is the non-limb threatening infection. And the limb threatening is more than 2 centimeters of cellulitis from that ulcer area, or then finally the life threatening. Now, the main key is that if you can stop the progression from one stage to the other, when patient comes to you with the 2 centimeter cellulitis or less than that, then if you do the right thing and the good treatment at that point, then the infection won't proceed to the next two levels. That way you can save the leg from amputations. Now, this categorization of system, all of us know that category 0, 1, 2, and 3. Okay, again, 0 is with less risk, and 1 is with absence of protective sensation, and 2 is with also with deformities and PVDs, plus or minus PVDs, and lastly is already having an ulcer history or an amputation. Now, as the category increases, the risk for all amputation also increases. Now, this is the different, how the risk assessment and of ulcers. Patients who have a low risk, we have to assess our patients who are chances for going for an ulceration and annual screening. But if already they have impaired sensations or skin deformities or calluses, then I think again a podiatry workup is needed to look into various areas. Again, if there is a absent or reduced vascularity, then it needs higher. The risk becomes higher, and you need to definitely look into the management of the vascular problem as well. But if it is already more than that, the vasculopathy is much higher with severe infection, gangrene, etc., and then if your center is not adequately ready for it, then you may have to refer to a specialized podiatry team. Well, amputations are a serious predictor of death, and 6 of 10 patients who receive the first amputation die within 5 years. So nearly half of all unhealed neuropathic ulcers result in death within 5 years. So there is a high risk for amputations and high risk for death. A patient who is going for ulceration, and which is actually a neuropathic or a neuroischemic, they have a higher risk of death in the due course. So it's very important to manage these patients. So this also is another mortality, study where they found that, the increased mortality by 47%, 5-year mortality risk with the history of previous ulcer alone. And these are different other diseases. Like you can see, the neuropathic ulcers are at higher risk than even Hodgkin's cancer or breast cancer or prostate cancer. And the amputation rate is also higher. So again, lastly, I just want to touch upon that all these patients who have neuropathy as well as cardiac, vasculopathy, neurovascular problems, where you have found out there is a vascular issue, you may be only targeting the ulcer, but don't forget to look into the cardiac issues. These are many times associated with cardiac problems. So we need to look into that. For that, we did a study. Patients who had ankle brachial index, which is already low, we succumbed them to, did angiogram for these patients. And in this, what we found that, as the angle brachial index is increasing in these patients who come with an ulcer to you, if the patient is having severe vasculopathy, then the chances of coronary artery disease is also high. So the mortality while the patient undergoes a treatment with you is also a high chance. And today, with all these litigations and all the problems which is happening with the patients and relatives in the Indian scenario, it is very important to look into that aspect as well when you treat diabetic foot ulcers, whether he has got a chance of coronary artery disease, and whether because the hemodynamic instability can trigger a coronary artery disease when in your treatment center, and then that can lead to problems. I still remember a patient. This study was, I took up this study because of one reason. About many years back, I still remember a patient who came to my center. I was at Lakeshore, in my center at Lakeshore, and then patient came with an ulcer, and he was admitted for that ulcer. He was otherwise stable, and he was going for a workup. So he came in the evening around 5, and he got admitted in the hospital. He had he was a slightly limb-threatening infection with an ulcer, with cellulitis more than 2 centimeters of cellulitis. So then I had to admit for injections and debridement. So what happened was, the same night he had a cardiac arrest and died. And the patients were very unhappy. They said they just came with, uh, just an ulcer, and he had a cardiac arrest and he died. And they thought that it could be because of the insulin we started. Many times when the patient comes to your hospital and we admit the patient, if they are on OHAs and he's already on infections, we stop the OHAs and start on insulins. So they thought that it's because of the insulin he went into cardiac arrest. So, these are very dangerous things today's world. So I urge that patients with ulcers, they have a higher risk for problems, and look into that as well. So lastly, the cost is a major issue. The cost increases as the patients have got, infected ulcers are 2 times expensive than non-infective ulcers. And annual cost is per ulcer healed with conventional care is also very high. And also we know about the inpatient cost and other major cost of amputations, etc. So the cost is also very huge in treating foot ulcers. And if you don't treat it at the early stage, know the risk factors, understand and educate your diabetic foot patients, and then try to help them prevent it from worsening, or even prevent it from recurring. I'm sure my next speakers who are going to follow me are going to highlight more into it. With this small introductory talk, I stop with thank you very much. The old Sanskrit saying, one who walks is good fortune, also marches ahead. So, well, we should protect the patient's foot, and he'll be thankful to you that he is able to walk on his foot, and you are able to give his life for a longer time. Thank you.
Thank you very much, Dr. Johnny, for wonderful presentation. First of all, I congratulate and thank Dr. Bansi and his team for this wonderful, great event. Now, it is my privilege to welcome my senior, my friend, rather I can say my elder brother, one renowned personality of West Bengal, Dr. Dr. Ghanshyam Goyal. He director and consultant diabetologist and diabetic foot specialist at SK Diabetes Research and Education Center, Kolkata. He is head of the Department of Diabetology at ILS Hospital, Calcutta. He is vice president, Diabetic Foot Society of India, and article Diabetic Foot is and Assessment and Management and Diabetic Foot Society of India was published in annual conference 2009 at New Delhi. Dr. Ghanshyam Goyal's main objective are to educate people on the management of diabetic mellitus and its complication to reduce diabetic foot amputations. He has been instrumental in starting the first India Diabetic Educator Project in collaboration with Project Hope to educate and train nurses, dietitians, nutritionists, and paramedics. Dr. Goyal has presented several papers, delivered guest lectures, and participated as faculty at numerous conferences and workshops in medicine, diabetology, and diabetic foot in India and abroad. He is inventor and introducer of SK offloading, one of the very nice and economical device for achieving offloading in diabetic foot patients. Now, today he will highlight the importance of physician, because without help of physician, we cannot save the limb, we cannot prevent the amputation. Now I welcome Dr. Ghanshyam for giving his talk on diabetic foot ulcer physician's perspective. Welcome, Dr. Balsi.
Thank you, Dr. Rajneesh, and thank you, Diabetes India, especially Dr. Bansi Sabu, for inviting me. And thank you, Johnny, for setting the screen. One of most costly complications a patient can have. What happened to this?
Sir, can you stop share and then share it again?
No, the laptop is blank actually. I don't know what happened suddenly.
Can you press escape on the keypad? Just press escape.
Yes, I press the escape. Can I rejoin?
No, just a moment.
No, it's not happening. I've joined. I've pressed the escape.
Yeah, now can you share your screen again? Can you see anything on your screen?
No, I'm not able to see anything. My screen is blank.
Can you mail me your presentation? Then I'll share it from my side.
Yeah, just a minute. I'm just restarting my laptop. Give me a minute. Huh? Okay.
Okay.
Let me see what happened.
Sir, we can take the next session.
Actually,
Unable to stop it.
The next speaker is Dr. Manisha Singh, and she hasn't joined yet, so I have to call her as well.
Yeah, so you can ask another to join, then I'll do it. I don't know what happened suddenly, why the screen is blank. So I'm trying to get out of it. Meanwhile, you can ask
Dr.
another
Viswanathan sir is there.
colleague.
Dr.
So you
Viswanathan
can
sir
ask
is there. Sir can
Vijay
take-
to start it, then can go through it. I don't know what happened. My screen is blank. Is my screen visible to you guys?
No, sir, no, sir. You have to log out from Zoom and log in again.
Some laptop problem.
Okay, I don't know. This blank, so unable to. Just
Sir, you are just like Mamta. Ekdam wash about ke again she is coming with picture.
Sir, if possible, can we take Dr. Vijay Vishwanathan, sir, or maybe Dr. Sharad?
Sir, may I invite Dr. Sarath Pedse, sir? He is ready, or I can go.
Yeah, Doctor. I think Dr. Vijay Vishwanathan is there.
Yeah, I am there. Hello, everybody.
Yeah.
Hello.
Sarath Pense is there.
Yes.
Sir.
Dr. Ghansham has shared the screen, but again we are not able to see anything.
So meanwhile, I will start with Dr. Sarath Pedse, sir.
As you wish, sir. Just let me know.
I can go also. I am ready. Dr. Vacharajani, sir, may I invite Dr. Sarath Pedse, sir?
Yeah, you can invite Dr. Sarath Pense.
Welcome, sir. Good evening, sir. Good evening, sir. Sir, it is my privilege and pleasure to invite you again. And now I invite Dr. Sarath Pedse, sir. He is senior diabetologist from Nagpur. He received advanced training in Germany, Croatia, and in UK. He is the director of the Diabetes Clinic and Research Center at Nagpur. He did MBBS and MD Diploma in Diabetes from Zagreb and MD-DG from Germany. He is author of 2 books, Practical Management of Diabetes and Diabetic Foot, a Clinical Atlas, and editor of the book Contemporary Management of Diabetic Foot. He has also authored many scientific papers, articles, and book chapters. Dr. Pedse is frequently invited as guest speaker at conferences around the world, and his main objective is adoption of poor juvenile diabetes, distribution of free insulin to the needy, prevention of gangrene and amputation, and diabetes education and scientific research. His project, step by step, improving diabetes food care in the developing world with aim to set up 100 diabetic food care clinic pan India. I was one of the part of that step-by-step project, and Dr. Sarath Percy teach me. That's why I can start my diabetic food clinic in a small town of Ajmer. I welcome Dr. Sarath Percy, sir. He will guide us regarding the management of Charcot arthropathy. Dr. Sarath Percy, sir. Welcome, sir.
Good evening, everybody. Nice to see you all, and it's my great pleasure and honor to be a faculty at this All India meet of Diabetes India this year. I'll be talking on Charcot arthropathy. I hope you can all see the slide, and it's very surprising. We have been talking about Charcot for last several decades, and we didn't know that Charcot arthropathy was diagnosed in non-diabetics way back in 18th century, when diabetic patients never used to live so longer to get neuropathy and Charcot foot. So Jean-Martin Charcot described this entity in arthropathy of ataxia in tabes dorsalis. So there were non-diabetic conditions in which Charcot foot was first time described, and several neurological disorders like cerebromalia, meningomyelocele, spinal cord injury. I have already talked about tabes dorsalis. So these were the conditions where they used to find Charcot arthropathy before this century, when the insulin was discovered and diabetic patients started living longer. 40 years back, or almost 30, 40 years back, I used to work as resident in leprosy ward for 3-4 months. And let me tell you, those days, leprosy and leprosy causing Charcot arthropathy was the commonest cause, more common than diabetes. And remarkably, all leprotic patients with involvement of feet, extensive neuropathy, used to have Charcot arthropathy, but they used to carry on with their ulcerations, all sorts of deformities, because they didn't have hyperglycemia, and therefore they wounds used to remain very clean, and they used to keep it clean with the help of maggots. They were the podiatrists for them. But the last 20 years or so, diabetes has emerged as the commonest cause of Charcot arthropathy. It is very poorly understood and frequently overlooked clinical condition all over the world, and in India also is no exception. Although its prevalence varies from 1% to 8%, but what I would like to emphasize that the clinician managing diabetic patients with loss of protective sensations should have high index of suspicion. That's most important to detect Charcot foot. Definition wise, it's relatively painless as they have loss of protective sensation. It's a progressive disease. It's a destructive arthropathy, and it involves sometimes single or even multiple joints due to underlying neuropathy. So neuropathy is a prerequisite with loss of protective sensation for Charcot arthropathy. The pathogenesis of Charcot foot is multifactorial. There is loss of protective sensation, and then it leads to mechanical stress, the abnormal architecture of the foot. In presence of autonomic neuropathy, there is AV shunting, and that leads to more bony resorption. And then unhealed trauma to the foot because of neuropathy is a precipitating event. And patients who have kidney failure or stage 3, stage 4 renal failure have a very high chance of getting Charcot foot and even amputation. So the basic thing is there is more of bone resorption over bone deposition. The commonly involved joints, as you can see here, the most common is tarsometatarsal, but all other joints, metatarsophalangeal joint, interphalangeal joint, tarsal bones, all joints of the foot can get involved, but the commonest is tarsometatarsal joint. But as I said, ankle joint, subtalar, interphalangeal joints also can get involved. The destruction occurs either because of single or repetitive stress applied to bones and joints of this insensate foot. This results in fractures, effusion, ligament laxity, erosion of articular cartilages, fragmentation, luxation of the bone, disintegration, and finally collapse of the foot. Uncontrolled inflammation leads to release of pro-inflammatory cytokines, and this liberation of cytokine increases the expression of polypeptide receptor activator of nuclear factor, which is known as Wrangle hypothesis, and it triggers maturation of osteoclast from pre-osteoclast. And as I said earlier, osteoclastic activity is more dominant than osteoblastic activity. There are various stages of Charcot foot. Stage 1, when it's in the developmental stage, sometimes it is acute inflamed edematous foot. With early bone destruction, you may find some fracture. In stage 2, there is coalescence, the inflammation is subsiding, the foot is no longer hot, and there is an attempt for union of fractures. And stage 3 is the reconstructive phase, where there is no inflammation, the joints get ankylosed, there is hypertrophy of bones, but every patient need not go through all these things. These stages can coexist at the same time in a given patient. So you can have in both feet Charcot orthopathy and in different stages of Charcot orthopathy in the same patient. So as I said, it's mostly misdiagnosed or is missed. The diagnosis is missed very commonly. So early characteristic diagnostic of Charcot foot are 5 important signs. 1, loss of medial concavity. I will come to that. Secondly, unilateral painless swelling of the foot, callus or ulcer on the midfoot. Normally we see callus on the forefoot, on the tips of toes or MTH. But here we find midfoot callus or ulcer, and there is an altered shape of the foot. You see prominent veins on dorsum of foot. And here you can see what I mean by loss of medial arch or medial concavity is lost. This is normal medial arch, and this is what happens in Charcot. Instead of concavity, it becomes convex. So this is early detection. And you can see clinically it looks like this, medial convexity. Secondly, if you get a patient with unilateral painless swelling of the foot, after ruling out DVT and other things, if the patient has painless edema, always do an X-ray and you are likely to pick up. You can see here fracture of the metatarsal, second metatarsal, and this is very common, unilateral painless edema of the foot. Thirdly, I said all the time we see callus and ulcer on tips of toes or metatarsal heads. But in Charcot foot, as I said, the pressure is in the midfoot, and you can find a callus or a deep ulcer and the midfoot. If you find a midfoot ulcer, it's the diagnostic of Charcot foot. And this is how the convexity appears in the midfoot. Finally, the sign is prominent veins over the dorsum of the foot because of AV shunting, and you have to immobilize such feet. And this is the another way to pick up. And you can also see the foot is wide, little abnormal, and that's diagnostic of Charcot foot. So one can detect Charcot in early stages if you keep your eyes open and keep the diagnosis always at the back of mind in any patient with diabetes who has lost all the neuropathic or loss of protective sensations. Radiologically, it appears as fractures, fragmentation, dislocation, or absorption of the metatarsal or phalanges, leading to pencil-like appearance or a suck candy appearance of metatarsals, mortar pestle of IP and MTP joint, and hourglass appearance of the phalanges. And you can see this, you can typical hourglass appearance of the phalanges, mortar and pestle appearance, again in interphalangeal joint of the first toe. This is a pencil-like because of the great absorption of calcium. The bones have tremendous osteoclastic activity instead of osteoblastic. So there is a tremendous osteomalacia, loss of calcium, and that leads to pencil-like appearance or a sucked candy appearance of metatarsals. You can again see a sucked candy appearance of metatarsals, again diagnostic sign of Charcot. And when the foot is advanced with Charcot foot and radiological changes, you can see this again suck candy appearance here, loss of tarsal bones, almost 3 or 4 tarsal bones have been completely dissolved, reabsorbed. So there are hardly few tarsal bones left. This is an advanced Charcot arthropathy. You can see the total abnormality in the shape of the foot, and here the management becomes more and more difficult. Again, as I said, it can involve all the joints from phalanges to subtalar joints. And you can see involvement of the ankle joint. If you see the patient from behind, you're able to pick up Charcot involving ankle joint. And if you do X-ray, you can see the characteristic changes of Charcot foot. This patient came to me in summer last year with thermal injury. You can see on the left foot and superficial thermal injury. But I told the patient that I want to get X-ray of your right foot. He refused for that simply because he said, my problem is with left foot. I don't want to spend money on the right foot. But I insisted I will not treat your left foot unless you get an X-ray of your right foot. And surprisingly, or you can see the right foot was X-rayed. You can see the widening and edema of this foot, which was said to be normal, but you can see the fracture of fifth metatarsal. So this is how you can pick up Charcot if you keep eyes open and mind open for diagnosing Charcot. Here also you can see involvement of the tarsometatarsal tarsal joints. So this can be picked up only if you have that high index of suspicion. Sometimes it involves both the feet because neuropathy is symmetrical bilateral, and this becomes even more difficult to treat when the involvement is of bilateral, involving all the important joints. So the mobility, locomotion becomes very, very difficult. Even the offloading is very difficult if it is bilateral. Here you can see again involvement of the calcaneus. It's almost fractured, loss of a lot of osteoclastic activity. And if you again examine Always examine such patients from behind. You can see prominent tendoachilles on this side, but here there is obliteration of tendoachilles. You can see the foot is only swollen. And if you do the X-ray, you will be able to pick up the diagnosis of Charcot foot. But remember, in Indian conditions, treating ankle joint Charcot is becoming more difficult because we do not have so much expertise in doing reconstruction surgeries in Charcot foot in India. But overseas, there are a lot of advances to seal all the Charcot foot of ankle, or difficult fractures and dislocations of the foot can be now managed by metallic wires and internal and external fixation. In extreme case, when the neuropathy ascends, as we know, it's glow and stocking type of polyneuropathy. When the neuropathy extends above knee joint, usually we don't find involvement of the hands in diabetes as we find in leprosy. But in late stages, even hands are involved. So also, as the neuropathy advances in the limb, it goes above knee joint. Even knee joint can become Charcot foot, Charcot knee joint. And then it becomes very difficult because this disability is very difficult to treat. Even if you do a knee replacement, the main cause is not taken care of. But this is not very common. But occasionally in patients who have advanced polyneuropathy ascending up to thigh, you can get Charcot of knee joint as well. And the management is total rest to the foot in acute stage. If the swelling subsides, we can immobilize the patient with TCC, but we have to change TCC every month and have a look at the foot. So minimum 3 to 4 months of TCC, prevention of further trauma, protective footwear are the treatment for acute stage. And this is a chronic stage. You can see the bilateral foot ulcers, but the ulcers have healed completely with complete offloading of the right foot. So even Charcot foot ulcers as big as this can heal if proper offloading is carried out. But in Charcot foot, if the infection develops, you can see the midfoot ulcer here, and this is the source of infection. From it has ascended up to knee joint. There is extensive cellulitis. You can see blisters. This is a bad prognostic sign, and often such patients require major limb amputation. Surgical treatment is osteotomy if the exostosis is there, or orthodesis, internal fixation to restore stability of the joint. This is a typical osteotomy. When the bone is protruding and causing midfoot ulcer, we can remove, excise. This is the simple surgery and is possible in our conditions. And once you remove that protruding bone, the foot can be healed with surgical closure. In some patients, when the ankle is involved, you have to go for internal fixation or external fixation. But these surgeries are not carried out routinely. They are in a specialized orthopedic centers. People have also tried medical therapy like intravenous bisphosphonates, oral bisphosphonates, calcitonin nasal spray. But all these medical therapy have very limited response, and there is no specific guideline to use these oral or intravenous injections for treatment of Charcot. As I said earlier, 40 years back, when I was a resident in internal medicine, I used to see leprosy patients, and this was the commonest cause of Charcot feet in India, and the involvement used to be bilateral. You can see midfoot ulcers bilateral. The remarkable change is, see the floor of the ulcer, it's all red. granulation without any infection. This doesn't occur in diabetic. In diabetic, you find a lot of slough, pus, infection, and that heads for major limb amputation. But here you can see clean floor, even if it is bilateral involving both the feet. These are another advanced case of leprotic foot with Charcot, and you can see complete loss of calcium, tremendous osteoclastic activity, no osteoblastic activity at all. There is hardly any calcium in the bones, but still it's a walkable foot. And if you observe carefully this foot, you see that all the 5 toes are still intact. Few bones have been absorbed, as you can see, but all 5 toes are intact, heel is intact, and this is a walkable foot despite auto amputation and gross osteoporosis. But if in diabetic, as I said, the progression is so rapid, if we don't take or diagnose it at early stage, in a chronic Charcot foot, the foot becomes a bag of loose bones, as you can see. And if you hold this foot, you can turn it by 180 degrees. Nothing happens. It's so painless. But such flared foot in Charcot is very difficult to treat, reconstruct such involvement. So early detection is the key to success. Strict non-wet bearing with TCC for 3 months. Try to convert stage of destruction to stabilization and offer them protective footwear with custom molded insoles, extra depth foot. So high index of suspicion is the key, and delayed diagnosis and mismanagement leads to foot becoming a bag of loose bone. Thank you very much.
Thank you very much. Thank you very much, sir. Very nice presentation. Now I again request Dr. Ghanshyam Goel, sir, to start your presentation now.
Thank you, Rajneesh. Thank you, Sarat Pense, sir. And technology is great, but there is a technical glitches also. So it happened with me. So now I'm going to start with my presentation. And the very important part, the physician's perspective in the management of diabetic foot. Diabetic foot, we all know, is one of the very important and most difficult part in the management of diabetes care, and it is one of the costliest complication of diabetes care. As Dr. Johnny have already mentioned, diabetic foot ulcer is greater than that of 5 most costly forms of cancer, and mortality, except the lung cancer, mortality is also high than the 5 most common cancers. Every 7 seconds somebody dies of diabetes, every 20 seconds somebody is amputated, and believe it, remember it, the lifetime risk of diabetes foot is 34%, staggering 34%. When I went to Dr. Pense 20 years back, he taught me that it is 15%. As Johnny discussed, 25%. It is 34%. And out of that, 50% of diabetic foot ulcers become infected. 20% of diabetic foot infections result in amputation. So prevention is better than cure. It is the prevention is the, I can say, golden word, as mentioned by Dr. Pense. This holds true for diabetic foot. Physicians are the first point of contact for any patient, and that's why physicians play an important role in identification of high risk foot and prevention of diabetic foot. Who is at risk of diabetic foot ulceration? I think Johnny have discussed in detail. Most important, neuropathy, peripheral vascular disease, diabetic foot infection, and others. Then these are the 5 important points which every physician should do in their clinical practice. One is identify the at-risk foot, which is very important. It can be done in your day-to-day clinical practice at your clinics. Regularly inspecting and examining the at-risk feet, educating the patients, family, and healthcare professionals. ensuring routine wearing of appropriate footwear, and treating risk factors for ulceration. These are the 5 important aspects which every physician should do. And very important, this is the risk categorization. After examining the foot, doing a comprehensive foot examination, you can divide the risk category 0, 1, 2, 3. 0 means no loss of protective sensation, and you have to do a annual comprehensive foot examination. Then when there is a loss of protective sensation is there, plus minus deformity, every 6 months you have to examine these patients comprehensively. Then it is the risk category 2, when there is a loss of protective sensation, LOPS plus peripheral arterial disease, every 3 months by split. And then there is history of ulcer or amputation or history of Charcot's foot, as beautifully elaborated by Professor Pense, every 1 month or whenever required. Then as first step to effective foot care is you ask the patient to remove the shoes and socks and examine the feet. So whenever I discuss, I always say in diabetic patients, start your examination foot to head, not from head to foot. It means apada mastak. So by that, you are not going to miss diabetic foot. Then this is the common presentation which we all see in our clinical practice. There's a unilateral, non-healing, long-standing ulcers, neuropathic, and a lot of callus around the ulcers, as Dr. Paints have shown it. Then the bilateral foot ulcer. The problem here is the offloading. To do the offloading in these patients is the most difficult scenario, and to do offloading, you have to keep the activity level to the minimum. Then the infection, this is not even the risk factor for major amputation, but even the life-threatening situation may happen. Then, so what we have learned from these cases, most of the cases which I have shown, and we all come across in our day-to-day clinical practice, that these can be preventable. And but how to address the challenges and barriers to the foot care in our scenario. And we always know these are different from the developed countries. So one is this is a religious faith, that we walk barefoot to any religious place. And what is the physician's role? If a patient who is having having LOPS, loss of protective sensation, they should not walk barefoot even indoors to avoid this sort of problems. Then sleeping in the open. In the rural India, a lot of people go into the fields and they sleep in the open. And there is a lot of ants are there, rats are there, and they bite. And what is the role of physician? What is the physician perspective? Educate their patients not to sleep in the open, and if possible, if not possible, then wear the socks, which should be loose on the upper tight. Then about the footwear, which is very, very important. Inspect the footwear used by the patients, as this is a innovative patient who have seen the insoles, and especially you can see that seams are the cause for the ulcers. So this is very important. That second is about the use of antibiotics without proper prescription. Inadequate doses result in infection caused by more antibiotic resistant organs. So the role of physician is educate patients not to use antibiotics without prescription. Most neuropathic uninfected ulcers do not require any antibiotic. So neuropathy evaluation, we all know: monofilament, tuning fork, biothiometer, pinprick, temperature perception, or ankle reflexes. These are the way you can examine this: the monofilament, VPT, tuning fork, ankle reflexes, and all these. So these are the way. There are two types of examination in our busy clinical practice. I know we are not going to spare so much time, but one is 60-second foot examination, or the 3 minutes examination. Any previous dialysis related foot problem, both foot pulses are palpable, is protective sensation intact, is there evidence of significant foot deformity? We have to see. So first 15 seconds, is your feet numb? Do they ever tingle? Look at the foot foreskin color, colors, toenails, palpate the foot for temperature and range of movement and motion. And the final 30 seconds, do they ever burn? Do they feel like? Means, is there any symptoms suggestive of neuropathy? And check it with the 10-gram monofilament. Then comes the 3 minutes foot examination. In 1 minute foot examination, if find that patient is in problem, yes, it looks that patient is in LOPS or anything else, and the symptoms and signs suggestive of diabetic peripheral neuropathy or diabetic foot symptom, then ask. One is ask, then comes look, and then teach. So one is ask. Does the patient have a history of previous foot ulcer, amputation, is patient had peripheral vascular disease, had a pedal bypass or angioplasty, and is there a history of nicotine use, and does the patient have symptoms and signs of neuropathy, just which is there. And then comes the, if the patient is having the involvement of nail, patient is having corns, calluses, or having open wounds or fissures, or patient having interdigital mycosis, interdigital maceration, which is very common, and neurological examination, especially for the, to look for the protective sensation, and is dorsal pedis and posterior tibial pulses are palpable. So dorsal pedis, we all know, at the extensor hallucis longus, lateral to the extensor hallucis longus ligament, and the tibialis posterior, just behind the medial malleolus. Then what to teach? Visually examine both feet, sole means dorsum and plantar surface in between the toes, and keep the feet dry by regularly changing shoes and socks. Dry feet after baths or exercise, and recommend them appropriate footwear, and what is the frequency of change of footwear, and smoking cessation, all these. So key elements after this examination, if you find the, what are the key elements of lower extremity physical examination, as gait, foot morphology, toe morphology, skin, then the status of nails and foot hygiene. Then in palpation, it comes pedal pulses and temperature, and protective sensation is the sensation of 10 gram monofilament, and then footwear, exterior and interior both. So inspection, look for the nail dystrophy, erythema, prominent veins, foot deformities, clatoids, hematoid, bunions, all these you see, and callus, bunion, hemato, what we have seen, and Charcot's foot with the excellent presentation done by Dr. Sarat Pense, as we come across in clinical practice. Then palpate the peripheral dorsalis pedis and tibialis posteriors, and see for the temperature difference between the dorsum of the both the feet, which is very important, and look for the limited joint mobility. Then, as he have already mentioned about the neuropathic foot and the ischemic foot, so you have to differentiate between neuropathic foot and ischemic foot. So one is plantar callus, location is first, third, fifth empty head, great toe, and the heel areas. It is the high pressure areas, and there is a lot of callus around the ulcer, because callus require a good blood supply, so that these are there, and there is a loss of protective sensation. While neuroischemic foot, it is cold, not pink. It is generally black, pulseless, and is very painful, and marginated ulcers and gangrene. So you differentiate between, at the level of the physicians, that you can differentiate the ischemic ulcer or it is a neuropathic ulcer. And then do palpation of pulses, then do a ABI if possible, and then if needed, further investigation to be done. Then about the wound classification, after examining and deciding, there are, one is most common and most easiest is the Wagner's classification. Superficial ulcer grade 1, deep ulcer grade 2, and if it is involving the bone, osteomyelitis is grade 3, it is a localized gangrene, it's a grade 4, and extensive gangrene, it's stage 5. So that is the Wagner's, which is most commonly used in clinical practice, and or you can use the University of Texas diabetic wound classification, because it is recommended by ADA. That's why I put it. So one is A, B, C, D, grade 1, 2, 3. You take it like this: A superficial wound, one is superficial wound, deep wound, and then the involving the bone. And then the infection is present, it is B. If ischemia is there, C, and both are there, then infection and ischemia is a D. So this is the simple classification. These are the basic tenets of foot management: adequate debridement and infection control, adequate vascularity, and adequate offloading. So this is the common antibiotics which are prescribed, especially for non-limb threatening. Always take a deep tissue culture and send it, and according to the reports, culture reports, you can escalate or you can de-escalate the antibiotic therapy. Then offloading. In the primary setting or physician perspective, most important is, one is the modified footwear, and second is the indigenous offloading techniques based on the principles of Samadhan system, just like SK offloading, what our chairperson Rajneesh have mentioned, and Dr. Sarat Pense have done a lot of work on the offloading techniques, especially total contact cast and the instant total contact cast. Then the physician's role comes for the management of comorbidities. One is the, as we all know, in these patients, as the Johnny was giving an example, great example, that patient had just admitted for ulcer and sudden cardiac arrest. So these patients are associated coronary artery disease. There is a retinopathy, nephropathy, peripheral vascular disease, depression, autonomic neuropathy, erectile dysfunction. So we have to manage all comorbidities in diabetic foot patients by the physicians. And very important, education of the patients, family, and healthcare providers about the foot care to be provided. So there's a foot care, how you can provide by your staff, and what is the 10 commandment by the Diabetic Foot Society of India. And we all say, do not walk barefoot, even indoors if you are in loss of protective sensation, and do not soak feet. All these are the advices which used to given. And how to care for toenails, cut straight across, file sharp edges, ask a friend or relative if you are not able to do it. These are the things which a physician can advise at his level for to take care of nails. And what about the fungal nails, difficult to treat? Thick nails should be filed. This is a common presentation. We find this sort of nails in our clinical practice. So how to handle it, and what to look for in the shoe, wide and deep at the toe, and very important, this is that to buy in the afternoon and measure both feet. Sometimes there is a difference. One feet is 7.5, another is 8. So one is tight, another is fit. So in that situation, two different shoes to be taken of different. So that is very important. And in the evening, why? Because there is a lot of swelling in the evening due on account of neuropathy or due to associated common conditions. So that is very important. So foot care instructions, very important. Do not walk barefoot. And all these we do in our clinical practice. What is there? So physicians education, very important, and to pertaining the how to impart the foot care. And most important thing, again I am repeating, ask the patient to remove the shoes and socks and examine the feet. By that you are going to go a long way. Then patient's education in the groups, in the individual, or in the and the foot care education for the diabetic educator. So dear friends, to conclude, diabetic foot examination is mandatory in all diabetic patients. Physician should examine a diabetic patient from foot to head, apadamasak, not from head to foot. So that's why you are not going to miss the diabetic foot. Physician should identify the high risk feet. It's a high risk 1, 2, 3, and according to that, comprehensive foot examination to be done. Team members of physician should impart foot care education to all diabetic patients at every visit. It is not like that comprehensive foot examination to be done every year, but we have to impart the diabetic education, foot care to all the time whenever a patient is there, and we have got the resources are available, or our diabetic educator or our foot care specialist, foot care nurses are available, then it can be done. Then minor foot pathology and travel injuries should be managed by physicians and the team. It is not necessary that we have to refer each and every patient to Dr. Bacharajani. We have to, these minor and travel injuries should be managed by physician and team. Complex foot pathology should be referred to the higher centers. Thank you very much for giving me patient hearing.
Sir, can we move on to the next speaker?
Yeah.
Hello, can you hear me?
Yeah.
Yeah, so
Dr. Bachcharajani, please continue.
Yeah.
Nice
I think.
presentation of Dr.
Yeah,
Ghanshyam.
okay, fine. Yeah, Dr. Manisha Singh is here. I think I am supposed to introduce her. She is an assistant professor at Department of Surgery, Gujarat Raja Government Medical College since 2009. She is MS in General Surgery with fellowship in Diabetic Foot Surgery. She is a consultant podiatric surgeon at Gwalior Diabetes and Foot Care Center and Gwalior Diabetes Center since 2005. She is pursuing PhD and doing study on use of plant-based products on diabetic wounds. She has attended many state, national, and international conferences on diabetes and wound complications as faculty and delegate since 2004. She has presented a paper at Asia Pacific Diabetic Limb Meeting, Kuala Lumpur in 2014 and awarded Best Oral Paper Presentation Award. As an international faculty, she has presented multiple lectures on diabetic foot at EDFC Dubai 2014. She is a national faculty in diabetic food and executive member, Diabetic Food Society of India. And she is on editorial board in Indian Journal of Orthopedic Surgery. She is doing excellent work in Gwalior. I have already seen her work, and she has even worked hard for a very good conference at Gwalior. I present Dr. Manisha Singh to you.
Can you hear me, sir?
Yeah,
Hello?
I can.
Slideshow on here. From beginning.
Yeah, Manisha ji.
Yeah. So can you hear me, sir?
Yeah, I can.
Okay, sir. Thanks for the that introduction, sir. And many thanks for the invite, Dr. Bansi Sabu, sir. And good evening, August audience. I shall be presenting my talk on surgical management of diabetic foot ulcers. Well, the global burden of diabetes has risen in 21st century, and so also have the microvascular complications registered a rise in the last 10 years. With double the number of feet to address a huge burden, it is seen that it accounts for 20% of the hospital admissions in the diabetic patients. 50% of the foot ulcers would get infected, would recur, and 50% of the cases would proceed to major amputation with history of contralateral amputation within 2 years. So in the diabetics, the risk ratio for infections is higher, and the hospitalization rates are higher, and also the mortality rates. So the up to 75% of the lower extremity amputations are being performed in these diabetic patients, which are constituting just 5 to 10% of the general population. And the triopathy of the foot actually leads to the sets a background for the lower extremity amputation. And we have noticed that after 1990s and 95, there is a reduce in the rate of major amputation. However, the incidence of partial foot amputation are estimated to triple across the century. And as I said, that as has been said in the today's thing, the death from diabetic foot ulcers and related amputation, it equals or exceeds the death from prostate cancer, breast cancer, and Hodgkin lymphoma, and it is really alarming. In the infected diabetic foot ulcers, it has been found that 17% of them required lower extremity amputation, and 15% had a mortality. And in the last 10 years, as I said, that most frequent topic of discussion and most highly cited publications is the diabetic foot infection. The infection is more prevalent in the Asian countries. So diabetic foot ulcers are a pathologic heterogeneous entity, and we do not have an podiatric surgery setup or a specialized podiatric surgeon with special training or focused approach in our Asian countries. The emerging complications like Charcot foot, necrotizing fasciitis are frequently seen in developing countries compared to the West. There is a large number of infections which go undiagnosed because of lack of training and lack of recognition. There is late referral to the health system, resulting in amputations, and more so the proximal amputations. So the roughly 40% of the patients have a recurrence within 1 year of ulcer healing, and 65% within 5 years. There's a huge number, and 50% of these infected ulcers would undergo an amputation. The risk factors amongst all them, the major is the persistence of the triopathy of the foot, which again leads to the re-ulceration, and the presence of a previous scar will be a very big risk factor, because once a cloth is torn from a place and stitched, it will again get torn from the same place. The transfer ulcers which occur after amputation, or the recurrent ulcers, are also seen in these patients. The overcrowding at the OPD in primary health centers, the basic 2-minute foot examination, as mentioned by Dr. Goel, would be missed. And in India, it's very common to see the maggot-laden, ant-laden coming out of the wound dressing, barefoot habit of walking barefoot, applying massage, all home remedies, everything what is eaten is applied on the foot. And every 6 seconds, someone will die from diabetes. Every 30 minutes, a limb is lost to landmines. And every 20 seconds, a limb is lost to diabetes. So diabetic foot patients are vulnerable because of the triopathy of the foot, the altered biomechanics, the rupture of the plantar fascia, which are getting inserted at the metatarsal heads. And majority of the diabetic foot ulcers are within out. 85% of the ulcers are, and the correction of the causal factors would be needed to heal these ulcers, and no amount of dressings or any other topical application would help it. So plantar tissue damage due to heat dissipation during walking occurs because of the deposition of the products of non-enzymatic tissue glycation, which render the plantar tissue damage more easy. So there is delayed recovery from anoxia because at a higher elevated plantar pressures above 600 kilopascals, the capillary circulation gets closed. So the peak plantar pressure, there is anoxia and ischemia in the foot every time during the walking cycle. And in diabetes, the delayed recovery occurs in the diabetics. Inflammation and warmth will be present, leading to blister formation and formation of an ulcer. The presence of echinus deformity because of the elevated plantar pressure, Achilles tendon contractures due to a non-enzymatic tissue glycation. They are present in 40% of the high-risk foot. Microachill lengthening will be required to lower the forefoot pressure, and as it restores the biomechanical balance. And the surgery will be required in the cases when the cases get infected or gangrenous in the history of the diabetic foot. So the aim of surgical treatment is to achieve and maintain weight-bearing plantigrade foot, to restore and maintain adequate soft tissue envelope, and to abolish and minimize the risk factors, the triopathy or the other factors which threaten the either of the above. While evaluating the foot, which has already been discussed in detail by Dr. Ghanshyam sir and Dr. Johnny, Sir Frederick Reeves, he actually in 1853, he gave new principles to the practice of diabetic foot, and on those pillars the standard of care practices were developed, which included debridement, choice of the wound dressings, wound offloading, local wound care, and vascular assessment of the vascular. Patient should be evaluated for arterial insufficiency, infection or the microbiological control, good glycemic control, and the integration of all the systems, like giving a multidisciplinary approach to the foot so as to take care of all the aspects. And the diabetic foot wounds and their healing are very, very typical. These wounds are arrested in the stage of chronic inflammation against the background of hyperglycemia, poor granuloma formation, bacterial overgrowth, impaired wound healing, and prolonged persistence of abscesses, which leads to the chronicity of these wounds, plus the higher rate of carriage of Staphylococcus aureus in the anterior skin, nail, and the fungus infections. So the surgical debridement involves the removal of all these dead necrotic tissues so as to give a good wound bed for angiogenesis and for the laying down the granulation tissue. And this is very important procedure, should not be left to the junior most member of the team. The person should be well versed with the anatomical details of the foot, and the sharp debridement is found to be more efficacious in several clinical trials. So in this case, we can see that after the grade 2 amputation and debridement, the wound started granulating. And also another case of medial plantar space abscess with grade 2 osteomyelitis. We had to debride the wound, remove the necrotic tissue, and go for a grade 2 amputation. And then again, another medial plantar ulcer where the grade 2 had to be lost, and this was as a result of friction injury to the footwear, from the footwear, a very minor trauma. And another case where there was a lot of destruction underneath an innocent looking dusky grade toe, and the debridement was done, and now the wound has granulated. Since the patient did not allow skin grafting, it's granulated on its own. Another chronic callus ulcer spreading to the dorsum of the foot and involved the loss of the grade toe. Another case where the grafting was done after debridement and amputation. So according to IWGDF 2019 recommendations, hydrogels have apparent benefit, but RCTs have high risk of bias. So these are the only choicest wound dressing material, and the ideal dressing material or the should create a moist wound environment that promotes granulation, autolytic process, angiogenesis, and migration of the epidermal wound, migration of the epithelium, and manage the exudate wound exudates. So such ideal dressing material does not exist because it is not ideal for all the wound types, as their wound presentation is heterogeneous. So There are a variety of wound care products amongst the common antimicrobial layerings to the advanced wound care dressings, and we can choose according to the need and the economic condition of the patient. The wound offloading has been discussed in detail in the previous lectures. So in the pathophysiology, presence of a prior foot wound is a mandatory for the DFI, and it's a DFI is essentially a intramellular infection of the foot, and it is defined as an inflammation, presence of at least 2 signs of inflammation to make it to label it as an infected diabetic foot. The various risk factors for infection may be metabolic derangements or the immunopathy or the biochemical mechanical factors and a history of previous ulceration. So the plantar spaces in the distal foot are packed and the human anatomy is unique, and these plantar spaces are packed and they have rigid bony compartments, the fibrous tissue and the septa, which put a compression on the neurovascular bundles as the fluid or the pus will accumulate inside. So this the altered functional anatomy due to the non-enzymatic tissue glycation, they convert the foot into an end artery disease because the atherosclerosis processes are mainly involving the metatarsal arteries, which are getting converted to the end arteries due to blocked by the septic emboli. So we can see that the infection from the foot can go up to the leg, can ascend up the leg from the tendons to the along and the loose iliotibial tissue to the muscle bellies. So we should always look for the and palpate the muscle bellies while looking for the when you are looking at the site of infection in the foot. And due to continuous and repeated walking, as a patient is unaware because of the neuropathy, he may not be knowing that the foot ulceration is present also. So we can see that initial lesions which become as a break in the skin envelope, they may grow to the bigger amounts by minor trauma and pressure unawareness in the neuropathy, and the normal act of cutting of the nails, the thermal trauma, the presence of plantar fissures due to autonomic neuropathy. So all these are have to be a minor trauma, and the foot examination has to be done because there is no complaint. So the patient, the doctor should not be missing the foot examination. For limb salvage, it is essential that the infection has to be picked up early. The guideline-based approach has to be followed. The categorization of lesion, grading of infection, and the local wound assessment is must, noting the size and the shape of the wound, the peri-wound erythema, the maceration, and also the depth of the wound has to be noted. Apart from the evaluation of the patient as a whole, complete foot evaluation and application of a multidisciplinary approach. So we should evaluate the psychosocial status of the patient, presence of comorbidities. In the lab investigations, we need to do the procalcitonin, the inflammatory markers, ESR, C-reactive proteins, etc., and the other routine investigations. The affected limbs and the foot have to undergo a neurovascular evaluation, and also the plantar pressure measurements to note the sites of the elevated plantar pressure. The wound should be assessed for the presence of infection, and the wound culture, deep tissue should be sent for the deep wound culture. The bone culture can be sent after a bone biopsy. So we have already discussed this in the previous lectures, and the University of Texas classification is most popularly used. PI5 classification may be done needed if the revascularization is planned, and the ITSA classification of diabetic foot infections, the infected patients would not have any signs of infection. In the mild cases, at least 2 signs of infection should be present, and the peri-wound erythema and the extension of infection in the peri-wound space starts increasing. However, in the moderate infection, there will not be the wound area would be larger, infected wound area would be larger, but there is absence of SIRS or the systemic inflammatory response syndrome, which is present in the severe infection. Patient needs hospitalization. So the various WGDF guidelines have made in the past, and they have found that the management of the foot problems improves, and there is a reduction in the tragedies caused by these foot problems. Also, our standard guidelines for the in India have been made in 2016, and these in 2019 they found that the diagnosing soft tissue diabetic infection by local and systemic signs of inflammation within 24 hours, somebody should come and see the patient, and based on ITSA classification, severity score should be decided. Hospitalization of patient with severe foot infections and moderate infections with comorbidities is a must, and inflammatory markers should be made. If the clinical examination is equivocal, we should go for the inflammatory markers. In suspected osteomyelitis, probe test, ESR, CRP play a role in the diagnosis. Advanced imaging, bone biopsy may be done for the doubtful cases, and these guidelines also suggest there is no role of adjuvant therapies or so many wound products. They have hardly have any role. Even the adjuvant therapies like VAC therapy and all for a particular indication per se for the diabetic foot infection, they are not needed. So if a patient with a limb-threatening infection, apart from systemic infection, systemic signs of infection, they may have widespread necrosis, gangrene of soft tissue, air crepitus, bully, disproportionate pain to clinical findings, uncontrolled infection despite appropriate therapy, and they need hospitalization. The indications for conservative treatment in osteomyelitis, they include control of infection is achieved with appropriate antibiotics within for 72 hours. Then unaltered biomechanics of the foot despite bony destruction. Patient refuses for surgical treatment or surgery is a high risk. In surgical treatment should be undertaken without delay if the bone destruction is continuous and biomechanics are altered and they despite therapy, and we cannot get a appropriate or the inadequate the adequate soft tissue envelope for primary closure, and there's contraindications to medical treatment. So the classification of surgical procedures as done by given by the Frickberg and the Armstrong, they say that they are divided into class 1, 2, 3, 4. There is the elective, prophylactic, curative, and emergent. And the highest level of risk in the of a high level amputation, the proximal amputation, the class 4, the emergency procedures, and class 2, we do it on neuropathy patients without ulceration. Class 1, we do it for when the neuropathy is absent. So the surgical categories and the various procedures can be surgical procedures can be done like hammer and claw toe correction as a prophylactic surgery, ingrown toenail removal, osteotomies, bunionectomies, and incision and drainage of the in emergency conditions, incision drainage, major minor debridement with or without amputation. However, the multidisciplinary approach, that is inclusion of a surgeon, general surgeon, orthopedic or plaster surgeon, vascular surgeon, and apart from the diabetes specialist and the physiotherapist, wound care specialists, and the other faculties which may help help in limb salvage and may prevent amputation by up to 85% of the cases. In the COVID outbreak recently, the algorithm which has been planned says that in the mild infection or the home treatment is enough and the local wound care suffices. However, the patient is running fever, then COVID-19 investigations have to be done. In moderate cases, they have to come for the outpatient clinic and then follow up at the home and also get a RT-PCR or the serology done if the fever persists. In severe cases, they need hospitalization, and if the cases are non-urgent, then they have to be COVID-19 investigations have to be done apart from the conservative management. However, if the as a part of protocol, thorax CT scan is a must whenever it is suspicious, and single stage radical surgery must be planned under regional anesthesia preferably, and a shorter hospital stay should be done. So the various diverse spectrum of the clinical presentation of diabetic foot infection in the form of common minor foot infections, the nail infections, onychomycosis, fungal web space infection or the intertrigo, you can see spreading it to the infection to the dorsum due to poor foot care and trapping of the moisture. They leads to thrombosis of digital arteries and spread to the adjacent joint spaces. In paronychia and wet gangrene, leading to the wet gangrene of the toe if the treatment is delayed. And in this case, we had to do a partial nail excision to prevent the tragedy. And hammer and claw toe deformity occur as a result of motor neuropathy. And distal foot calluses and ulceration also may lead to the forefoot abscess and infective gangrene subsequently. Again, web space infection, which are minor looking, may lead to major catastrophes. Dorsum abscess due to scratching may result into may need drainage and debridement. Infected heel ulcer, it said that heel never heals and occurs in the areas and takes a long time to heal. Again, neglected minor infections may lead to the major amputations or the partial foot amputations. Again, a cause of forefoot sepsis and midfoot amputation had to be done in this case. Amongst the major foot infections, we have the central plantar space abscess, where the infection in the central spaces, tight central space may lead to compromise of the neurovascular bundle and the gangrene of the distal digits in presence of proximal palpable circulation. We can see the infective emboli blocking the distal arcade and the build-up of pressure in the tight compartment space. The extensive debridement in these plantar space infection medial plantar space and lateral plantar space type of infections. So we should know these categories so as to ensure a good surgical management. So these lesions are a tip of the iceberg with massive destruction may be seen underneath, and a dorsal foot phlegmon because of a pathology on the plantar surface. The dorsal foot phlegmon may be present in malperforance ulcer. There will be these are chronic ulcers present over the metatarsal heads, and septic arthritis of the joints may issue. In necrotizing fasciitis infections, a surgical emergency, aggressive surgical debridement may be necessary. There will be bully, skin necrosis, patches, and extensive necrosis of subcutaneous tissue and fascia, relative sparing of the muscles and the skin tissue. Rarely it may spread to the gangrene if unattended, and myonecrosis may issue. We can see the releasing incisions may be given and the fasciectomy being performed. Partial amputations should be the first option offered for the functional limb salvage, and they have an operative mortality rate less than 1%, 5-year survival rate up to 43%, less is more. So while considering a patient for a PFA, we should see that there is gangrene, osteomyelitis, or there is adequate perfusion is present or not, and whether adequate soft tissue cover is available or not, and the structural biomechanical factors, and suppose the tendoachilles has to be released, that has to be taken care of. Apart from the patient's own preference regarding the level of amputation, which should also be taken into consideration. So in this case, we can see the distal toe amputation, hallux amputations, second toe amputation, and the filleting flap to close it, a biomechanically viable foot with all the toes amputate, and we can see the transmetatarsal amputation done in this case due to the gangrene of the forefoot. So for the limb salvage procedure, we should do the post-surgical and the pre-surgical biomechanical assessment, and elective balancing procedures to follow, followed by the prosthetics. The major amputations in non-salvageable foot, there is no point, it is futile to waste the energy in saving such feet, and we should go for the major amputation. So the amputation should be viewed as a reconstructive procedure, and treatment recommendation in ulcerated foot are the surgical offloading procedures, including teckless tendon lengthening, silicone injections, callus debridement, metatarsal head resection, osteotomies, and correction of the toe deformities. So in the great toe ulcers, we are doing the
sorry to interrupt you, ma'am. We are getting late, so can you conclude with
I will take, I'll try to do it as fast as possible.
Yes, ma'am.
So we can see the selective plantar fascia release being done as a percutaneous procedure, or it may be done by as an open procedure. Keller's gap arthroplasty may be done so as to remove the distal part of the base of the proximal phalanx and create a gap and relieve the pressure of the metatarsal head. Again, flexor hallucis longa tenotomy, percutaneous flexor tenotomy, which is done in this case, can be done as an OPD procedure and with the help of a needle. And for the claw toe and minor toe, which are present as the dorsal lesions or the apical lesions, we can go for the correction, release of the flexors and the extensors. Then even the flexor digital longus sternotomy may be done. TA lengthening gastrocnemius release procedures, they help in reducing the forefoot and the mid procedures and the pressures during the loading. So the prominent metatarsal head resection, pan-metatarsal head resection can help in relieving the forefoot pressure. Metatarsal osteotomy may also help in relieving it. And a tendon transfer operation may be help in balancing the stumps and also to take care of the weak extensors and the flexors. So in the ostectomy, midfoot collapse, exhaustectomy was done, and with a conventionally healed skin grafting, it has been found the ulcer recurs. So the tendoachilles or the triceps contraction has to be taken care of, and it has to be released for the permanent results. And tendonless gap restoration may be done by facial autograft or FHL tendon transfer to balance the gait. Pantellar fusion. In the reconstructive surgery, we have debridement followed by skin grafting and VAC therapy to increase the granulation. Again, local flaps may be tried to fill up the defects, especially in the weight-bearing areas. The Charcot foot reconstruction therapy, fixation with the external fixators. Here, the angioplasty of the posterior tibial vessels were done, and the great toe stump healed with that. And again, we can see that in this, the reverse sural artery flap was covered for the exposed calcaneum. And I'm thankful to Dr. Sunil Rathore for sending me this picture. And severe calcaneal osteomyelitis, again, gap, it's covered by the reverse sural flap. So the surgical plan depends upon the stage of the diabetic foot disease at presentation, and the high index of suspicion is must for the diagnosis and the extent of the lesion. Most DFUs would heal, and only a quarter of them would actually need an amputation. Sharp surgical debridement superior to other methods of debridement. Early, aggressive, and radical approach in these debridements is a must, and it should be done within the expedited time. The primary goal of amputation is eradication of infection, removal of non-viable tissue, and functional and healed residual stump. It should be viewed as a reconstructive procedure. Intrafoot amputations or the disarticulation advantages, proximal amputation advantage over the proximal amputation, and they should be preferred. Reconstructive surgery or the plastic cover, we should know that prior revascularization has to be done, and surgical offloading has a good healing outcome. So preventive, an ounce of prevention, an inch of prevention is better, and we should always, prevention is better than curing and spreading so much. So prevention is the best aspect, and Dr. Vijay Viswanathan will cover the rest of it. So in view of recent petrol hike, preventive foot care for foot fitness is a must. Let's walk. Thanking you. Thank you, sir.
Thank you so much, ma'am, for your wonderful talk regarding the diabetic foot ulcer management surgical. So I'd like to call Dr. Rajni Saxena sir or Dr. Vachrajani sir for the next talk to introduce our faculty, Dr. Vijay Vishwanathan Anand sir.
Hello.
Yes, sir. Kindly introduce.
Yeah. Am I audible?
Yes,
okay.
Sir.
Yeah. I am really honored to introduce Dr. Vijay Viswanathan because he, as such, doesn't need any introduction. He's a genius in the field of diabetes and foot care. He's head and chief diabetologist at MV Hospital, Chennai. He is MD, PhD, and FRCP London and Glasgow. He has WHO Collaborating Center for Research, Education, and Training in Diabetes. He is President-elect 2021-23 in D Food International, based in Belgium and consisting of experts from 193 countries. He is a National Vice President of RSSDI at present. He has completed 29 years in diabetology. He is PhD in diabetic nephropathy and published 50 research papers in this field. He is the first Vivian Fonseca Award from the American Diabetes Association for work in diabetes and TB in 2013. Developed the specialty of diabetic food care in India by training over 2,000 physicians in India and abroad. He is awarded Fellowship of Royal College of Physicians, London, for research contribution in diabetes. Let me tell you, friends, he is also instrumental in my publication of a book, Science of Wound Healing and Dressing Materials. He recommended, he has even reviewed, and that review is there in that book. And he is a very good friend of mine. I present Dr. Vijay Viswanathan to you. Vijay Viswanathan, please.
Thank you, Dr. Vajrajani and Dr. Daria, Dr. Saxena. Thank you for being there. And my good friends, Sharad Pense and all others have already given you a big overview of the subject. I'd like to thank my younger brother, Banshi Sabu, for inviting me. And another, can you? Okay, I'll have to share it again. Huh? Okay. So I'll be taking over the DFoot International another 10 days from now. And I'm really honored that India is sending the first president of DFoot. The first president was Christine Van Acker from Belgium. The second was Jose Luis from Spain. And the third will be from India. So with that introduction, since the others have all covered what has to be told, I'm going to cover next 8 minutes. I'll finish my talk in 8 minutes. And this was one of the, I've been asked to talk on how to prevent amputation, how to prevent a foot ulcer. So I think this is a very good study which we did from 31 centers across India, from Uttar Pradesh and Madhya Pradesh and everywhere. And when we looked at the cost for amputation, we found that 31 centers, mostly diabetologists, and we found that infection on top of diabetic neuropathy was responsible for most of the foot ulcers, foot infection, and amputation in India. Therefore, in the last 7 minutes of my talk, this is a fantastic algorithm given by Mike Edmonds and Ali Foster, who's not with us anymore today because she died of cancer, from King's College, where the stage of diabetic foot is divided into stage 1, a high risk foot, ulcerated foot. So we diabetologists come in this stage when the person has got normal feet and a high risk feet, about which I'll talk to you in the next 6 minutes. When you get an ulcer, it's almost like end stage kidney disease, and when it gets infected and gangrene, then there is no going back. Now, this was Caroline Abbott and Andrew Bolton from Manchester, who said that all that you need is not a biothiometer or anything, but all that you need sitting in a rural village in Bihar is a 128 hertz tuning fork, something to test the temperature, or the small fiber. This is the large fiber. Pinprick again is more a test for small fiber. An Achilles reflex, tendon reflex is more for large fiber. Now, if you don't feel the vibration perception in the right and left, you score 1. But if you can't elicit the ankle reflex, you get a score of 2. And Carolyn Abbott, along with Andrew Bolton from Manchester, showed that if you have a score of more than 6, that is, if you have 1 here, 1 here, 1 here, 1 here, and 1 here, with just temperature testing, pinprick, and vibration, they showed that your chances of ulceration, if you have a score of more than 6, is 6 times more than if you have a score of less than 6. This was a study which we published 15 years ago, where this is nothing but a graduated tuning fork, 128 hertz. It's 128 hertz. It replaces a biothiometer because you place it on the medial malleolus or bony prominences, and you ask the patient, you can see this triangle here, and you ask the patient whether he can feel the vibration up to the last mark, which is 8. And if he says he's able to feel only up to 4, which is somewhere in the center of the black pyramid, he's got neuropathy. So this is a 128 hertz graduated tuning fork. I told you about temperature testing. It might not be possible to have a beaker of hot water and cold water and so on. So this was a study which we published in 2002 in the Postgraduate Medical Journal, where we tested a tip therm, which has got a metallic end and a wooden end. And if you can't feel the difference in temperature between the metallic end and the wooden end, you can assume that the person has got loss of small fiber. Many people don't test for limited joint mobility. In the hands, we use the prayer sign, but in the feet, you dorsiflex the big toe. And if you can't dorsiflex beyond 60 degrees, you have limited joint mobility. We showed in 2003 that if you have limited joint mobility, it increases your plantar pressure and ulceration. Many people don't test this, so they test only vibration and heat and so on, but they don't test. So you please dorsiflex the big toe, and if you can't dorsiflex beyond 60 degrees, you have limited joint mobility. In the hands, you can have the prayer sign. If you have a physiotherapist, they have an instrument called a goniometer, where you can measure the subtalar joint movement and so on, but that's not needed. So using one of these instruments, which I showed you, you have something called a high risk feet, which is loss of protective sensation. If you can't feel the pulses, if you have a deformity, as you showed, you saw the gruesome pictures from Manisha, or if you have a history of a foot ulcer or an amputation. And as I said, if you have limited joint mobility, Then I'll go back to that slide, which is very important. The slide from King's College. You have a high risk feet. So stage 2 is a stage where we can do something for the patient. The gruesome pictures which you showed, which Dr. Manisha showed, are in stage 4 and 5. So we can prevent it as physician and diabetologists if we detect patients in this stage and guide them through and prevent a foot ulcer. Lastly, the last 2 minutes, I think every diabetologist must read the International Working Group of Diabetic Foot, which is the chairman is Nicholas Schapper from Netherlands, and it is found in iwgdfguidelines.org. Every diabetologist, every physician, every podiatrist must read it because it's very extensive. It's written every 4 years. And I was fortunate to be with Siko Bus and with David Armstrong writing the guidelines in 2019 on offloading. And the IWGDF has asked me to take part in another working group, and that is wound healing. So in 2023, I'll be in 2 groups, one on offloading and one on wound healing. These are beautiful guidelines written every 4 years. And the DFoot has translated it into Portuguese, into Spanish. I have translated it into Hindi. I've translated it into Tamil. If you go to our website, www.d-foot.org, you can see the Hindi translation of the IWGDF guidelines. You can see the Tamil translation. And lastly, I think diabetic patients in India have a very poor knowledge. We showed in 1999 in JAPI that people in India have a very poor knowledge about foot care. So if you have somebody with high risk feet, we should educate, especially if they're from a lower socioeconomic status. And in this wonderful paper from Diabetes Care, which is the official publication of AD in 2005, we showed that foot care education, if you educate your patients, you can heal the wound faster. We showed that 26 versus 5 was the people who followed the advice and did not follow the advice. And new surgical recurrences of the ulcers were only about 3% in people who got educated versus 14% who did not get educated properly. And lastly, my last slide, as diabetologists and physicians, let us remember most of our patients in all these studies, their HbA1c is never 7. They'll say COVID and they could not exercise. I'm not talking about COVID at all. I'm talking about 2019 and before that. Most of the studies have shown that the average HbA1c in people in India with people with diabetes is between 8 and 9. So I think we need to achieve the target of HbA1c of 7. And the other way to educate is this was a wonderful program by Sharad Pense. And this was a photo taken in 2004 when we were all young. Sharad Pense, Arun Bal, and Ali Foster. We were discussing, and we trained nurses and a doctor and a nurse from India, Sri Lanka, Bangladesh, and Nepal. They were all rural doctors. And I can proudly say that this was one of the best programs ever done in diabetic foot in the world, because from India it went to Africa, from Africa it went to West Indies, Pakistan, everywhere. So Dr. Sharad Pense and I, we were the architects. And I would like to once again thank my younger brother, Dr. Banshi Sabu, and all the panelists who are great friends of mine. Here is Dr. Sharad Pense, the father of diabetic foot in India. And we owe a lot to him, and we learned a lot from Sharad Pense. Thank you for your kind attention.
Thank you so much, sir. You all are the teacher of the teachers, and I am very happy today that I am seeing the Encyclopedia of Diabetic Foot in India. I am very grateful to you, all of you, sir. Any inputs from chairpersons?
Dr. Vachrajani is a good surgeon from Rajkot. Dr. Rajesh Saxena, Dr. Manisha is there. So let us learn from the surgical colleagues something about diabetic foot. Manisha's talk was very good, but it was very extensive. It covered the entire spectrum of diabetic foot. And I think we learnt a lot from the type of foot lesions which occur commonly in India. Of course, Dr. Sarath Pense's talk on Charcot foot, which is a very neglected field in diabetic foot in India. People think that edema is due to nephropathy and they think it's due to filariasis. There are many people who mistook their swelling in the feet to filariasis and were taking hetrazol for months together. So I think Dr. Sarath Pense's talk was an eye-opener on Charcot foot.
I have always a feeling that proper early diagnosis is the key. But many of my meetings, doctors tell me that we don't get Charcot foot in our city. We don't find Charcot foot in our area. That's not true. We have to have that eye to diagnose Charcot foot, early diagnosis. Then only it's always often missed. I was very happy to see Dr. Manisha Singh's extensive surgical treatment. Congratulations, Manisha. Very good.
I think there is no question in chat box, but I'll ask one question to all the teachers that any role of hyperbaric oxygen therapy in diabetic foot ulcers?
I think Vijay has one.
So we have been using hyperbaric oxygen for the last 8 years. But again, I'm telling you, it's only an adjuvant. And it is we have used it as an adjuvant. We cannot fool people with the hyperbaric unit just because you have one. And you after revascularization, where I have found it in maximum use is after my interventional radiologist does a revascularization, where he puts a balloon into the peroneal artery or into the tibio-peroneal trunk or antitibial artery. It takes a few days for the collaterals to come. So the hyperbaric oxygen, Jay Shah from the American College of Hyperbaric Medicine, he's just retired as a president. So he also told me that after revascularization, after a balloon angioplasty or a bypass from the popliteal, femoral popliteal bypass, if you use hyperbaric, it will help you to build the collaterals, which are very important. Somebody comes to you with gangrene of 2 toes, with no pulse. You do a revascularization, put him onto hyperbaric oxygen, you give him silestazole, whatever, and then you give him clopidogrel aspirin, whatever, and then you put him onto hyperbaric oxygen. We have seen collaterals coming beautifully. We have published 2 papers on hyperbaric oxygen. We have done histopathology before of the tissues, before the hyperbaric and after hyperbaric is published. So we have found that the collagen and the neovascularization pattern improves after hyperbaric. Vinay, you want to say something? You're muted, Vinay.
Sir,
Vinay,
kindly
you're muted.
unmute, sir. Unmute yourself, sir.
Vinay, you're muted, yeah. Vinay, you're muted, yeah.
Yes, sir. So I have a very important question in this monsoon times, especially in the rural India. Most of the people go for farming and agriculture. And when they are actually sowing the seeds and going to the farm, the foot care goes on a toss completely, sir. Whatever you suggest, these people just refuse to take care of their foot care. You can ask them to put on long boots and you can ask them to rural India. How do you educate these people to actually take care during their farming times?
and mosques and the other religious places to be stick there. That wear cotton socks when you visit these things. And I distribute all across Saurashtra.
So Dr. Vacharajni is a diabetic food surgeon, a dedicated diabetic food surgeon working only for diabetic food, and he has a very good workshop also where he prepared even the footwear and everything, and one of the finest diabetic food surgeon in state of Gujarat, that much I can tell. A very close friend of mine. Recently he has written a book also, sir, and as Dr. Vijay had already told, in RSSDI, we had come out with a RSSDI Diabetic Food Task Force, D-Food Task Force, and definitely we will be increasing our network across the country, because our purpose is that a rural area where diabetic food is a neglected area, where we can teach them, we can educate them, and this diabetic food problem can be prevented. We have from South India, East India, North India, Central India, the part of task force. We have also international advisors for this task force, but definitely we would like to educate all our district coordinators and all RSSDA state chapter EC members along with the national EC members. We are planning to have a national meeting for 1 or 2 days as a workshop, maybe next month. As COVID was a time, that was the reason we could not have. We are going to have a few modules also, and we would definitely would like to have few surgeons like Dr. Manisha and Dr. Vacharajni and few more surgeons as a part of in this group or in our network, which is we are going to have widely across the country. Many more doctors are required to educate the doctors also. I think a wonderful program it went, and the food symposia is always a very hit program, every time. This time we had not kept as a word name workshop, because to do a workshop on a virtual basis was a bit difficult. So we thought we should keep the name as a symposia. That's better name. And during our face-to-face meeting, physical meeting, probably next year in RSSDI at Chennai, may not be again in Mumbai, or in Diabetes India, which we'll be doing next year, we may have face-to-face. And once again, we would like to have food symposia or food workshop rather. And maybe in next 1 month only or 1.5 months, once Vijay will tell, we are going to have a virtual meeting with only with food, and we will be having our district coordinators and all doctors from across the country who are interested in food problem. They'll be joining. If no other question, Dr. Daria or Dr. Vacharajni, or if you want to make the last comment, the last comment, then otherwise we can end. Yes,
Dr. I want to ask one question to Dr. Vijay Viswanathan, sir. Sir, is there any role of rivaroxaban in the management of peripheral artery disease in diabetic foot, or is it can increase the microcirculation in the two area?
Rivaroxaban is used for prevention of DVT classically, and nowadays we are using it post angioplasty along with aspirin. We don't use it with clopidogrel. We use it with aspirin and rivaroxaban. Xarelto is in the name, and it only thing is watch out for bleeding. We had a patient who bled a lot and severe bleeding after angioplasty, giving rivaroxaban and ecosprin.
Sir, I am using 2.5 mg BD. Is this dose is sufficient, or may I increase it?
I think 10 milligram BD is the ideal dose after angioplasty. If you're wanting prevention of only DVT, you can use 2.5.
Okay.
But if you're using it post angioplasty to prevent blockages of the angioplasty segment, you should use higher dose, 10 milligram BD.
Sir, I'll add on this that this dose 2.5 BD with aspirin is basically in a post angioplasty patients, and for the venous thromboembolism particularly, the dose is 10 mg OD or it may be a BD. But like people are using anything like that, all oral anticoagulants like rivaroxaban, apixaban, and the dabigatran in the COVID patients. But that is nowhere written for the arterial thrombosis, and in COVID patients, I think there is a arterial thrombosis is more problematic than the venous thromboembolism. So I think it should be 2.5 mg BD with the aspirin in the post PTA patients. I think there is no question in chat box, so we can.
Can I just add? Can I just add?
Yes, sir. Yes, sir. Please, sir.
Yeah, actually, just to add, there was a recent trial, which is, I think, the Gabit Compass trial.
Yes, sir.
If I am not mistaken,
Yeah, Compass trial.
we did a study with rivaroxaban 2.5 and they found in peripheral vascular disease they could reduce the amputation by 43%, and the bleeding incidence was much lesser, and they added aspirin and rivaroxaban.
Yes, sir. That was in Compass trial. They have done it with the 2.5 BD with the aspirin, and yes,
For
sir.
arterial disease.
Yes, sir. Arterial.
Peripheral arterial disease. And also it reduces the cardiovascular events as well.
Yes, sir. So, if there is no question, we can conclude. Thank you so much, sir. All the stalwart speakers from across the globe, across the country. And thank you, our chairpersons, Dr. Rajni Saxena, sir, and Dr. Vachrajani, sir. And here we are ending this session, Diabetic Symposia. I'll hand over proceedings for the further next session. Yes, Dr. Male Parekh, Dr. Jimit, sir.
Thank you very much. Thank you very much, sir. And congratulations, Dr. Vijay Nathan, sir. Congratulations.
Yes, sir. I forget. We must congratulate Vijay Vishwanathan Anand, sir, that he is the pride of India. He is a president of DFOOT. It's a really honor for India also. So, congratulations.
Good night. Good night, everybody.
Thank you. Thank you so much, Vijay sir, Vachhajani sir, Rajni sir, and Daria sir. Hello, sir.
Yeah, hi.
So it's a wonderful diabetic foods symposium, and we all wish to good night. And so tomorrow morning we will continue. Stay home, stay safe. Bye. Good night.
Okay.
Good night.
Good night, everyone.
Thank you very much. Thank you. Thank you.